ठीक है।
Good afternoon, everybody. I'm Dr. Ramesh Venkatraman,
Arnav, हाँ जी,
consultant critical care medicine at Apollo Hospital, Chennai. I want to first of all
लाइव हो गया,
लाइव हो गए आप लोग अब।
Good morning, sir. Your mic is off, sir.
Good morning, boss ji.
Good morning. Good morning, Dr. Shrikant.
Can we start now?
Okay, sir. Sure. A very good morning to all of you. I, Dr. Devin Juneja, welcome you all for the second day of Criticare 2021. Like yesterday, we have got a exciting line of lectures lined up for you, and I, along with Dr. Sahil Kataria, will be the host for you today. So to begin with the first session, I would like to invite Dr. Deepak Goel, who is the President-elect of ISCCM and Director Critical Care Medicine, Medanta, the Medicity Hospital, Gurgaon, and Dr. Shrikant Srinivasan, who is Head Critical Care Medicine at Manipal Hospital, Gurgaon. So over to you, Dr. Deepak Goel.
Good morning, Dr. Devin, for kind introduction. Can we have first slide, Sahil, Neeraj? So first talk is by none other than Dr. Daniel Talmor. He's from Boston. He is the chair of Department of Anesthesia and Critical Care and Pain Medicine at Beth Israel Medical Center, Boston. He is his area of expertise is ARDS and mechanical ventilation, and he is very famous for transesophageal pressure monitoring. So over to Dr. Daniel Talmor.
Hello, everyone. I'd like to thank the organizers for inviting me to this virtual meeting. It's a great honor to speak to the Indian Society of Intensive Care Medicine, and I look forward, hopefully, to a better year in next year. And I'd like to thank the organizers for inviting me to this virtual meeting. It's a great honor to speak to the Indian Society of Intensive Care Medicine, and I look forward, hopefully, to a better year in next year, and perhaps being able to visit your lovely country in person. So the topic I was asked to speak about is the role of esophageal pressure measurements in the management of ARDS patients, and topic which has received increasing attention over the last few years. So these are my disclosures, and I have a number of them, but the most important one is on the bottom, and that's that I have my own opinions, of which I'm going to express today. So first off, what do esophageal measurements tell us? So when we look back at our respiratory physiology, and we all learned this in medical school, the actual pressure opening and closing the lung is called the transpulmonary pressure. And the transpulmonary pressure is the pressure applied at the airway minus the pleural pressure. So PL, transpulmonary pressure, equals airway minus pleural pressure. And that's the pressure which is opening and then allowing the lung to close at end expiration. The pleural pressure is the pressure of the chest wall weighing down on the lung. And before we begin to see the lung open, we have to overcome that pressure. So the transpulmonary pressure may be very different from the airway pressure. And the question is, how do we measure pleural pressure in order to calculate the transpulmonary pressure? Because the transpulmonary pressure varies widely and may vary based on the patient's physiologic condition. So an obese patient will have a very high pleural pressure impacting their transpulmonary pressure. A patient in sepsis who's received a large fluid resuscitation may have a very large pleural pressure, which will impact their transpulmonary pressure. And in this work from several years ago, we compared airway and transpulmonary pressure in patients ventilated in our ICU. And while you can see they trend in the same direction, at any given airway pressure, there's a very wide variation in transpulmonary pressure. And some airway pressures may actually lead, some clinically derived airway pressures may actually lead to a negative transpulmonary pressure. So we have to be thinking in terms of transpulmonary pressure when we ventilate our patients, and not airway pressure, which is what's measured on the ventilator. So how do we estimate pleural pressure? Because we can't actually put a pressure measuring device in the pleural space. We can do that in dogs, but not in humans. We use an esophageal balloon to measure the pressure in the esophagus. The pressure in the esophagus is well correlated with the pressure in the pleural space. So we place this long balloon, and you can see an example on the upper left-hand side. Place it at the bedside, either through the mouth or through the nose, and advance it into the esophagus until it's sitting behind the heart. There's a number of tricks to make sure that it gets into the right place and that it's actually sitting where it should be. That's beyond the scope of this talk. This talk, we're going to talk about the clinical use once it's in. So this is a simple procedure. The picture shows one of our respiratory therapists placing an esophageal balloon, and we're going to discuss now how to use it once it is in place. So once we have the esophageal balloon in place, we're going to derive pressure waves from the esophagus. So here you can see on the top line the airway pressure. That comes straight from the ventilator. On the second line is the pressure measured in the esophagus. And on the third line is the airway pressure minus the esophageal pressure, which gives us the transpulmonary pressure. And these are tracings from an actual patient. And if you look, this patient was ventilated with 26 of PEEP and a plateau pressure of 46. You see that on the top line. But the esophageal pressure was very high too. This was an obese patient with multiple trauma. And when you calculated the transpulmonary pressure, it was going from 4 at end expiration, so 4 at PEEP, to 12 at the plateau pressure. So very different, right? If you're thinking of a PEEP of 26 and a plateau of 46, you're really worried about this patient. But when you look at those transpulmonary pressures, you understand that the situation is quite different, that this patient is actually ventilated with very safe measurements. So how can we use these esophageal pressure measurements? The first use case is, of course, setting the ventilator pressures at PEEP and plateau, and that's was first described in this paper from the New England Journal. This is the use case we're going to concentrate on today. But there are other uses for esophageal pressure measurements. We can calculate the driving pressure of the lung. So the driving pressure of the lung, as opposed to the driving pressure of the respiratory system, is the transpulmonary pressure at plateau minus the transpulmonary pressure at PEEP. And that's very different from the driving pressure of the respiratory system, which is what we measure on our ventilator. And this gives a better assessment of the impact of ventilation on the lung. Another use is optimizing recruitment maneuvers. So this is a paper we published a few years ago looking at recruitment maneuvers in 28 patients. All of them received a recruitment to a plateau pressure of 40 at the airway pressure. You can see that in the gray bars. But if you look at the measured transpulmonary pressure at the same time in blue, it varies widely between 5 and 25 centimeters of water based on that patient's physiology. And the worry, of course, is that those patients who are receiving a recruitment maneuver to 5 centimeters of water will be under-recruited. But those who receive a recruitment maneuver to 25 centimeters of water will be over-distended and injured by the recruitment maneuver. So using transpulmonary pressures to set your recruitment maneuver only makes sense. And the last use case is detection of dysynchrony. So we know that clinicians are really, really bad at detecting dysynchrony. When you look at waveforms on the ventilator, it's not always clear that the patient is dysynchronous. But if you look at this tracing here, here's the esophageal pressure. You can see this deflection is a spontaneous breath as the patient expands their chest wall and causes negative pressure. So that spontaneous breath landing on top of a ventilator-delivered breath is dysynchrony. We can detect this using esophageal balloons much more effectively than we can looking at airway tracings. And this is technology which I predict will be built into ventilators in the near future. So esophageal pressure measurements are useful for a wide range of uses, but we're going to concentrate now on setting ventilator pressures and in particular setting PEEP pressures. So everyone in this audience is aware that there's been multiple PEEP, high PEEP, low PEEP trials in the literature, and those have mostly been negative. Now, what happens when you do a high versus low PEEP trial? You take a patient, and we'll assume they're ventilated at 6 mLs per kilo, and you push the PEEP up in half of those patients. Now, what can happen when you increase the PEEP on a patient? Well, in a non-recruitable patient, when you increase the PEEP, you're actually going to increase the driving pressure because you're over-distending the lung and the plateau pressure will go up. So in those non-recruitable patients, the injury from high PEEP outweighs the benefit. On the other hand, in a recruitable patient, one who's got collapse of the lung and whom high PEEP will benefit, when you increase the PEEP, you will recruit lung, the driving pressure will go down, and the benefit from high PEEP will outweigh the injury. The issue is, unless we are trying to identify the recruitable patients in advance, if we take all-comer mechanically ventilated patients, we're going to injure some, we're going to benefit others, and in the end, we'll have a negative trial because they'll balance out. So a much better way is to use transpulmonary pressure to try to identify those patients with collapsed lung who will benefit from PEEP. And I'd like to show you this somewhat complex graph supplied by my friend Lorenzo Berra. And here you have EIT measured collapse. So here they've put EIT on this patient's electrical impedance tomography, and they're looking at the amount of collapsed lung. So that's the solid black circles. And you can see as the PEEP decreases, you begin to see collapsed lung. And up here, it's 20% of the lung is collapsed. Here is esophageal pressure measurements. So the measurement in the esophagus and calculating the transpulmonary pressure. So interestingly, when the transpulmonary pressure falls below 0, so at the point where the weight of the chest wall is greater than the distending pressure of the ventilator, so when the transpulmonary pressure falls below 0 is when we begin to see increase in collapsed lung and de-recruitment. When the transpulmonary pressure increases above 0, we see that the lung is totally open. So what can we learn from this? We can learn that keeping the transpulmonary pressure above 0 will prevent collapse, and that's what we want to do at end expiration. I'll show you another single patient here. These are airway and esophageal pressure tracings in an obese patient. So the first row of tracings is the airway pressure. Below that, you see the esophageal pressure, then the volume delivered to the patient, and the flow into the patient. And you can see in the middle here, there's an area where we've actually disconnected the patient from the ventilator and allowed the lung to collapse. And I want to focus in on that area. So you can see here, this is the airway pressure. We've disconnected the patient. I've zoomed in on the area. We've reconnected him, and we begin to apply pressure here, okay? So we're beginning to apply pressure at this point, but you can see the airway pressure is going up, but there's no volume being delivered to the lung, okay? There's no flow into the lung. So what's happening here? The airway pressure is going up, but no volume or flow into the lung. Well, it's only when we reach this point at which the airway pressure is higher than the esophageal pressure. So the point at which the transpulmonary pressure is greater than 0, do we begin to see inflation of the lung. So this is additional proof that we need to keep the transpulmonary pressure greater than 0 to maintain inflation of the lung. How do we get to a transpulmonary pressure greater than 0? We measure esophageal pressure and use that to calculate the transpulmonary pressure. So you can see how measuring esophageal pressure can be critical in ventilating a complex patient with ARDS. So now I'm going to show you a real case. This is somebody who was in our ICU this last spring. Obese woman, large volume ascites, ARDS from trolley and aspiration, was on very low tidal volume and a PEEP of 18. And we placed the esophageal balloon and we measured transpulmonary pressure. And by now you know how to look at these tracings. On top is the patient's airway pressure, flow, volume. Down here is esophageal pressure, and this is the calculated transpulmonary pressure. So on a PEEP of 18, the end expiratory transpulmonary pressure was 6, so a little high. We had gone beyond a transpulmonary pressure of 0. At that point, the respiratory system driving pressure was 20 centimeters of water and the compliance 13. So we had over-distended this patient. We had a dangerous driving pressure because we had over-distended the patient. The PEEP was too high. So we reduced the patient's PEEP. So this is now with a PEEP of 12. At a PEEP of 12, the end expiratory transpulmonary pressure is now essentially 0. The driving pressure has improved. It's come down from 18 to 13, and the patient's lung compliance has improved as well. So this shows you that we can over-distend the lung by applying too much PEEP. We can find an optimal PEEP using esophageal balloons and calculating transpulmonary pressure. But we can also overcompensate and come to a point of collapse. So here we dropped the PEEP further to 6. That gave us an end expiratory transpulmonary pressure of -5. The driving pressure has gone back up and the compliance has come back down. So using an esophageal balloon, we can calculate the appropriate end expiratory transpulmonary pressure, keeping it around 0, and that can help us optimize our ventilation. And we showed this principle in this paper from the New England Journal about a decade ago now, where we randomized patients to either esophageal pressure guided PEEP or empiric low PEEP using an ARDSNet PEEP FiO2 table. And this was significant for 28-day mortality. The survival curve was near significant. And at the very least, this showed in a small study that using higher PEEPs guided by esophageal pressure measurements were not harmful and possibly beneficial, very possibly. So we followed that EPVent trial up with the EPVent 2 trial, and here, unfortunately, the signal was a little less clear. On first look, it was a negative trial. So you can see on the survival curve that esophageal guided PEEP was essentially similar to empiric high PEEP FiO2 table. And below in the little cartoon, you can see that the probability was essentially 50-50 that one would be better, and really no difference between esophageal guided PEEP and empiric high PEEP. And empiric high PEEP is the point to remember. So this EPVent 2 trial was not a validation of the first one. We thought that the first one had proven the point that this is better than lower PEEPs. this came to answer whether it's better than empiric high PEEP. And the control arms were very, very different. So if you look at the control arm in the first EP event study and the second EP event study, let's just take a person on an FiO2 of 0.6. In the first study, that patient would have been on a PEEP of 10, right here in the middle. In the second study, they would have been on a PEEP of 20. So it was a different research question. The question here was, is esophageal guided PEEP better than empiric high PEEP? Because that was a question that I got asked a lot. And the levels of PEEP in the EP-Vent2 trial were very different than usual care. So if you look at usual care from the LungSafe study, the patients on an FiO2 of 0.6 around the world received PEEPs between 5 and 10. It sort of averaged out around 8. In our study, as I said, they would have received 20 of PEEP. So it's highly likely that the control arm in EP-Vent2 looked very different than what you do in your ICU in India, or what people do in ICUs in the United States for that matter. So that's very important to remember in interpreting the EP-Vent2 study. Was this a design flaw? In retrospect, I might have done it differently, but when we designed this study in 2011, it did seem as if things were trending towards higher PEEP levels in mechanical ventilation. So we did not achieve separation in transpulmonary pressure. You can see the blue boxes are the control arm, the yellow are the intervention arm. They all hovered around 0, although there was wide variation in the control arm. Similarly, there weren't big differences in the set PEEP between the control arm and the intervention arm, and this is why we didn't see a difference between the two arms in the final outcome. But we went back and we started to look at this a little differently. And the question was not what group you were in, but whether or not you achieved a transpulmonary pressure close to 0. So we relooked at the data based on patients close to 0 or far from 0. And if you look at it this way, suddenly the trial becomes positive. So here's the survival of patients whose transpulmonary pressure was within 2 centimeters of water of 0, so plus minus 2. And here's the survival in patients whose transpulmonary pressure was either too high or too low. And you can see that putting patients within close to a transpulmonary pressure of 0 actually was associated with improved survival. Now, the only way to know that you're putting a patient close to a transpulmonary pressure of 0 is to actually estimate the transpulmonary pressure using an esophageal balloon. So suddenly this looks like a positive trial, and this data is in review now. Another way to look at it is to try to look for patients who may have benefited from the intervention for other reasons. And here we look at heterogeneity of effect based on disease. So I'm going to show this conceptually. When a patient has a probability of death, really there's 2 components to that. There's the component that's attributable to the ARDS, and then there's the component of their mortality risk, which is not attributable to ARDS. So it's their pre-existing condition and their sepsis or whatever brought them in, if it's trauma or whatever. So in some patients, the attributable risk from their non-ARDS is relatively low. So if you come in with pneumonia and develop ARDS, most likely your risk of dying is from the ARDS. However, if you come in with a very high Apache score due to multiple organ failure and sepsis, most of your risk in dying has nothing to do with ARDS, and it's questionable if a ventilator manipulation will make any difference at all. So we went back and looked at these 2 groups, those with a low risk of dying, from their pre-existing condition, and those with a high risk, and we separated them by Apache score. And what we found is that in the patients with a high risk of dying for other reasons, esophageal pressure guided PEEP did not make a difference. So these patients were going to die anyway. That's the bottom line. They were going to die of the disease that brought them to their ICU, and manipulating the ventilator wouldn't make a difference. However, in the lower Apache group, so those who are at risk of dying from their ARDS, but not from other things, esophageal guided PEEP did make a difference. So it comes down to in whom can we actually impact based on a ventilator intervention. And it seems that those who may benefit from a ventilator interaction did benefit from getting their mechanical ventilation guided by esophageal pressures. So how do we tie all this up? It's clear that in ARDS, the one-size-fits-all solutions are going away. We need to enrich patient care by integrating multiple streams of data and providing care targeted to the individual patient. Individualized patient care is the way of the future in ARDS. So how do we phenotype these patients? One possibility is by imaging. So CAT scans, ultrasound, electrical impedance tomography, all of these can help us decide how to ventilate a patient. Another option is over here. We can use biomarkers. So there's great literature now showing that there is hyperinflammatory phenotypes of ARDS and there are hypoinflammatory phenotypes, and that they may benefit from different interventions. For example, in a reanalysis of the statin studies, it seemed that it actually benefited those with hyperinflammatory ARDS. So that's another way to try to come up with better decision-making for our patients. But let's not forget the middle here, and that's physiological phenotyping of the patients. Looking at the patient's own respiratory mechanics and deciding based on those mechanics how to ventilate the patient. We tie the imaging and the physiological phenotyping and the biomarker phenotyping, we tie all that together, and we have an integrated approach to decision-making in ARDS patients, which I believe will come to fruition in the 2020s, because all of these things are starting to mature into decision-making tools that we may actually be able to use at the bedside. So to summarize, personalizing mechanical ventilation is the way to go. Esophageal pressure measurements have multiple uses in mechanical ventilation, and that esophageal pressure guided PEEP improves survival, particularly in patients who are at most at risk of death due to ARDS. I'd like to thank my collaborators, all of these people without whom I would not have been able to do this work and without whom I would not be where I am today. And I would like to thank all of you for listening to me, and again, thank the organizers for inviting me to this meeting. And please, it's easy to get my email. I'm happy to answer questions about this topic. And I hope that you will all go out energized to try to use esophageal pressure measurements in your clinical practice. Thank you very much.
So thank you, Dr. Talmor, for that wonderful talk to set the ball rolling. So for the next speaker, we have Dr. Ramesh Venkatraman. There's a slight change in the schedule. And he shall be talking about an equally interesting and difficult topic, understanding stress, strain, and mechanical power. Now, Dr. Venkatraman is an American board certified in critical care medicine and fellow of American College of Physicians. He's a senior consultant and a department coordinator at Apollo Hospital, Chennai. And he is a wonderful speaker. So, and he's going to be talking about the topic of stress, strain, and mechanical power.
Good afternoon, everybody. I'm Dr. Ramesh Venkatraman, consultant critical care medicine at Apollo Hospital, Chennai. I want to first of all congratulate the organizers for this wonderful conference, which they have pulled off despite difficult times, and thank them for the opportunity to be a part of it. I'm going to be talking about understanding stress, strain, and mechanical power in the context of ARDS ventilation. Part 1 of my talk is going to be about stress. Part 2 is about strain, and part 3 about mechanical power, and the conclusions after that. When we talk about ARDS ventilation, we'll have to see how ARDS CT scan looks. You can see that there is a normal area of the lung here, which you would call as the baby lung or the functional lung. Whatever tidal volume or pressure we do apply is predominantly going to go to this part of the lung, because this is the most compliant part of the lung. And this is where we predominantly will cause overdistension and lead to volley trauma or barotrauma. And this is precisely why we keep the tidal volume low and keep the plateau pressure less than 30. On the other hand, the most dependent areas of the lung are going to be completely collapsed because of the alveolar edema pressing on it. And this is where, with every respiratory cycle, the alveoli closes and opens, causing atelectrauma. And we try to prevent it by setting our PEEP optimally. So this package of low tidal volume, keeping the plateau pressures less than 30, and optimal PEEP is traditionally called as lung protective ventilation. Today, we are going to use different terminologies to understand how ventilator-induced lung injury happens and what we can do about it to minimize it. The first and foremost is stress. So what exactly is stress and strain? Our goal of ventilating ARDS patients is to make sure that we optimize the gas exchange without injuring the lung. Stress is nothing but the maximal applied force to the lung during the respiratory cycle. When I apply a force or a pressure to the lung, the alveoli is going to inflate or get deformed. This deformation of the alveoli that happens because of the pressure we give on the lung is called as the strain. So the maximum pressure imparted is the stress, and because of the stress, whatever deformation happens in the lung is called the strain. However, measuring stress is not very easy because the lung is completely heterogeneous. As you saw in the previous CT scan, there are areas with normal compliance, there are areas with poor compliance, there are areas with intermediary compliance. Any pressure you apply on the lung will selectively go to the areas which are very, very compliant. Therefore, the stress of one part of the lung doesn't equal to the stress of another part of the lung. Number two, there are a lot of alveoli that are not in communication with the central airways, and we don't know what the stress there is. And three, there are significant amounts of alveolar interdependence. I will talk about how this affects stress in the next slide. Because of this, our stress increases in certain areas while it doesn't in other areas. The only way to try to minimize stress would be to try and make the lung less heterogeneous. There are two ways of doing it clinically. One would be to try to titrate the PEEP to an optimal level. Other would be prone ventilation so that the lung is less heterogeneous in these situations compared to otherwise. I talked about alveolar interdependence. As you can see that one alveolar wall is abetting the other alveolar wall, and the pressure exerted on one alveoli will affect the pressure imparted on the adjacent alveoli. If you take a closer look, H is the area here in this figure, which has got atelectatic alveoli. So when I impart a pressure, you can see that the alveoli adjacent to the atelectatic alveoli are going to be taking more amounts of pressure compared to alveoli that are far away from the atelectatic alveoli. So any area of regional atelectasis is going to amplify the stress in the surrounding areas. Therefore, these zones are called stress amplifiers. And our goal would be to minimize these atelectatic areas. And two ways to do that would be to optimize the PEEP and maybe do prone ventilation. When I talk about stress, I told you that it's the maximum pressure imparted during the inspiratory cycle. And we know that the maximum alveolar pressure that is imparted during inspiration is the plateau airway pressure. And we are going to call that as the maximum stress that is imparted during the respiratory cycle. And traditionally, we have been taught that we should keep the plateau airway pressure to less than 30 centimeters of water. However, this study showed that even with a plateau airway pressure of 28, 1/3 of the lungs showed hyperinflation consistent with ventilator-induced lung injury and overdistension. How can that be? It's possible. Let's now take two alveoli, alveoli A and alveoli B. Both have end inspiratory alveolar pressure, or what we call plateau pressure of 30. In one patient, he's taking a nice negative deep breaths at the end of inspiration. The other person, there is a significant amount of pleural effusion that is causing a positive pressure outside the alveoli. So the stress of the alveoli would be the pressure differential between inside and outside that we are going to call as transpulmonary pressure. So in this patient, it is going to be 30 minus of minus 15, therefore 45 centimeters of water. Whereas in this patient, the plateau airway pressure of 30 is opposed by the positive pleural pressure of 15 outside, and therefore the transpulmonary pressure is only 15. So for any given plateau pressure, the alveolar stress or overdistension can happen depending on the pressure outside, and therefore the only determinant of alveolar stress is the transpulmonary pressure across the alveoli, and that is significantly affected by the pressures outside the alveoli for any given plateau pressure. Now, the mode of ventilation also makes a difference. In volume control mode, the machine delivers a volume. So irrespective of whether I take a deep inspiratory effort or not, the volume delivered is roughly the same. Therefore, the pressure generated in the alveoli is not substantially different. However, if you take pressure targeted mode, here I have a patient who's got a mild respiratory effort. Here I have a patient who's got significant respiratory effort. When the respiratory effort is huge, the machine still delivers the same driving pressure. Therefore, the overall pressure change between expiration and inspiration is huge, therefore leading to increased alveolar stress. So what do we know about stress so far? Stress is the maximal applied force. It can only be inferred because of the huge regional variations that we see. Alveolar interdependence amplifies stress, and PEEP and prone ventilation can attenuate this. Transpulmonary pressure is the key determinant of alveolar stress, and understand that pressure targeted modes can potentiate stress. How about strain? We talked about the fact that strain is nothing but the deformation of the alveoli that happens because of the stress. Understand that alveolar deformation happens either because of PEEP. When we apply PEEP, there is some alveolar distension, and predominantly it happens because of the tidal volume. Every time we give a tidal volume, the alveolar deforms and comes back to the baseline position, deforms and comes back to the baseline position. We understand that this deformation is called the strain. More the strain, more the lung injury, more the lung injury, more the mortality. With that kind of an understanding, now it makes sense why 6 ml per kilo tidal volume had a protective effect on mortality compared to 12, because the strain imparted on the alveoli would be much less if we delivered only 6 ml per kilo compared to a higher tidal volume. Therefore, tidal volume is nothing but a strain amplitude. The maximum amount of strain that we would be impart on the alveoli is nothing but the tidal volume. Therefore, it is called the strain amplitude. Traditionally, we have been taught that 6 ml per kilo is better than 12 ml per kilo. I have told you earlier on that whatever pressure or volume we deliver to the lung is predominantly going to be taken over by the functional lung or the baby lung that is present in an ARDS patient. Therefore, if my baby lung size is small, any given tidal volume will increase my pressure substantially. On the other hand, if my baby lung size is big, any given tidal volume will not increase my pressure or strain substantially. Therefore, if I have two patients, one has a larger functional lung size, one has smaller functional lung, by difficult times, and thank them for the opportunity to be a part of it. I'm going to be talking about understanding stress, strain, and mechanical power in the context of ARDS ventilation. Part 1 of my talk is going to be about stress. Part 2 is about strain, and part 3 about mechanical power, and the conclusions after that. When we talk about ARDS ventilation, we'll have to see how ARDS CT scan looks. You can see that there is a normal area of the lung here.
Thank you, sir, for the wonderful. Thank you, sir, for the wonderful talk. So I request Mr. Neeraj to go ahead with the next lecture. So the next topic is matching respiratory physiology and acute lung imaging, and it will be by Dr. Antonio Pasenti, who is the professor of anesthesiology and intensive care medicine in University of Milan, Italy. So please, over to you, sir.
Good afternoon. I'm Antonio Pesenti from the University of Milan, Italy, and I am going to talk about matching respiratory physiology and lung imaging in ARDS. These are my conflicts of interest. There are institutional and personal conflicts of interest. None of them is relevant for this talk. So let's go on. And our story starts in 1967 when Asbaugh and colleagues described for the first time a new syndrome defined as acute respiratory distress syndrome. And this is an X-ray from the original publication. And you can see that as they describe, the X-ray appearance is clinically paralleling the clinical course. The earliest changes are consistent in a patchy bilateral alveolar infiltrates diffused on both sides of the lung. And this is part of the definition of the RDS till now. Please notice that the definition, the original definition of ARDS includes diffuse alveolar consolidation. So if we look at the evolution of lung imaging over the years, we see we started with plain chest X-ray, then we went to CT scan, then we got to a metabolic approach with the positive emission tomography. We ended up with electrical impedance tomography, which is a very dynamic TV-like imaging of the ventilation and perfusion of the lung. So if we start from CT, we must consider that CT is really a revolution in lung imaging. And that is because we thought in late 80s, actually mid 80s, that the lung was homogeneously involved by ARDS. When we performed CT scans, we discovered that the lung was not homogeneously affected, but rather that areas in black here showing ventilated regions and white areas showing collapsed or consolidated regions. So in the same lung, we had ventilated, aerated regions and collapsed, non-ventilated regions. So this discovery that in ARDS the lung was non-homogeneous was a major step forward in our understanding of ARDS. And that was thanks to the imaging of the CT scan. It was not the only result we got from CT scan. We could notice that in the same lung, we could have ground glass appearance, consolidation. We could have blebs, probably generated by the high pressures and volume of the ventilation we are using with mechanical ventilation. Moreover, CT scan actually measures the density of the lung. And density, being the lung mainly composed of air and water, tells us how much water and how much air we have in the lung. If the density is 0.5, 500 Hounsfield in CT scan units, then we can expect the lung to be made up of 50% air and 50% water of tissue. But if we know the volume of the lung, something we can easily measure by the CT scan, then we can compute the lung weight of the lung in vivo. And in so doing, we can measure the amount of edema. You see here that in normal subject, in normal volunteer, the handbook reports a normal lung weight of the two lungs together of approximately 1 kilogram, while in ARDS, the lungs weigh up to 2.5, 3 kilograms. By CT scan, we could see that normal volunteers had a lung weight of approximately 1,200 grams, going up to 2,600 grams in ARDS. That means that the patients with ARDS had lungs weighing 2.5 times normal. Moreover, in their lungs, they had 1.5 kilos, at least 1.5 kilos of lung edema, water. And so we could measure the pathology of the lung in vivo, measuring the severity of the disease in vivo. And it's not only that, we could measure how much tissue was dense and how much tissue is normal in those lungs. And by applying PEEP, we could plot PO2. We could see PO2 go up with PEEP, shunt go down with PEEP. And while PO2 goes up, the normally aerated tissue goes up, while the non-aerated lung goes down. So some of the lung that is collapsed gets open, and now it appears like normal lung. And this is the first available measurement of lung recruitment in vivo. When we put together mechanical respiratory mechanics data and CT scan data, we could notice that the respiratory system compliance and the amount of normally aerated tissue were strictly related. In this sense, we could say that compliance depends on the amount of normally aerated tissue. The respiratory system compliance depends on the size of the residual baby lung, which has the mandate to keep the patient, the adult patient alive, though being of the same size of a small baby. And this stress and stretch is on the baby lung is what causes ventilator-induced lung injury, as we will see later. So one of the major take-home messages of today, probably the most important, is that in ARDS, the lung is not stiff. The lung is rather small than stiff. And we call it the baby lung. As an image to remember this simple fact. the effects of prone position were really surprising. When we took a patient and we moved him from the supine position to the prone, what happens is that densities, which are normally in most patients located in the dorsovertebral posterior regions of the lung, when we put the patient prone, we see that the collapse moves toward the sternum with the gravity. So these regions of the lung are not denser because they are more diseased. These regions are denser because they are compressed by the weight that is over them. And when we rotate the lung, in prone position, then the back of the lung opens up. And being the back bigger than the front region of the lung, that might cause a significant improvement in oxygenation. And now we know also a significant improvement in survival. Talking about lung that opens and closes, Mosheder in Toronto showed that if we ventilate an isolated rabbit lung at 0 PEEP, the mechanical properties of these isolated lung get worse rather quickly. The same happens at PEEP 4, while if we use a PEEP higher than the closing pressure of the lung, that is higher than the pressure at which the lung closes, the lung mechanical properties are maintained and compliance stays high as in control. This opening and closing of the lung is judged to be very dangerous and has been called atelectrauma, one of the major components of ventilator-induced lung injury. We studied atelectrauma in CT scans, and in this scan, as an example, you can see that going from end expiration to end inspiration, some of the lung opens up, and obviously it closes down again at expiration. This might be very dangerous, according to our colleagues in Toronto. And then again, this is a measure of property of the ARDS lungs, the so-called recruitability. We have patients in which by applying pressure, we can improve a lot the amount of lung that is aerated, like in this recruiter lung example. While there are other patients in which, in spite of applying a lot of pressure, the densities do not change. Obviously, if the lung recruits, it's because we have a lot of lung that has been de-recruited, means closes, it has been closed. So if we have a closed lung, it means that it is recruitable. If it is recruitable, that being closed, this patient is probably sicker than the one that is not recruitable. However, consolidated lungs, like in pneumonia, are usually not recruitable. This is a very important paper from Caironi in Milan. It shows you that if you have a patient that is a high recruiter, when you go from, if you ventilate this patient at PEEP 5, at end expiration, this is the amount of non-aerated lung. Well, when you go at end inspiration, the amount of non-aerated lung now goes to this level. And the amount of lung that opens and closes during ventilation is big. In this example, is some 150 grams. But if you put now 15 of PEEP, the difference between end expiration and end inspiration is much smaller. This might be one of the possible beneficial effects of PEEP, decreasing, and then we should select PEEP in such a way to decrease the opening and closing. This other patient is a non-recruiter, and placing PEEP has no effect in opening or closing. Now we move to the next step, a metabolic approach to ARDS lung. We use many other tools, use positron emission tomography to study the metabolism of the lung. The metabolism of the lung is studied by infusing fluorodesoxyglucose. Fluorodesoxyglucose is absorbed but not metabolized by the polymorphonuclear cells. And polymorphonuclear cells, as you know, are one of the major components of inflammation. So when fluorodesoxyglucose is taken up by the polymorphonucleates, it stays there, emitting radioactivity. And here you see an example of a CT scan combined with dynamic positron emission tomography. You see that in this specific case, these densities must be consolidation. And in this consolidation, we have a lot of polymorphonucleates showing inflammation. However, when we studied the well-ventilated regions of the lung, those that appear black in the CT scan, we noticed that those two had a very much increased from 2 to 10 times activity, showing that in ARDS, inflammation is not just located in the lobes that appear collapsed, but is diffused to the entire parenchyma, because the ARDS is a disease of the entire lung, is inflammation of the entire lung. And I'd like to show you that we have at least two types of ARDS. One in which inflammation goes hand in hand with the density of the lung. Like here, you see that the regions, the active inflamed regions are those that appear called non-ventilated. And the higher the density, the higher the metabolic activity. This kind of patient, however, is homogeneously inflated, is everywhere, is inflated everywhere, and there is no relationship between density and metabolic activity. So we have two populations, one in which the metabolic activity increases with density, while there are another population in which the metabolic activity is not related to the density of the tissue. And these two classes are somehow different in many parameters. Here, excuse me, here we show you that in those patients in which metabolic activity goes with density, the plateau pressure is lower than the plateau pressure in those patients in which metabolic activity is totally independent from density. So in a way, uncoupled patients are sicker than those in which the inflammation goes with the density. My friend Benani studied, which is the main investigator in these positron emission studies, investigated also the opening and closing problem, but then he focused on the effect of tidal volume. Here you see a region of the lung in which inspiration increases the volume of the ventilated region. So the difference between these two volumes is the tidal volume of this region of interest. And he found out that the relationship between tidal volume and end expiratory lung volume is strictly related to inflammation. So inflammation goes hand in hand with the ratio tidal volume over end expiratory lung volume. And you know now that this relation, this ratio, is described by a mechanical parameter which is called driving pressure. The higher the tidal volume for a given end expiratory lung volume, the higher the driving pressure. The higher the driving pressure, the sicker the patient, the higher the mortality. The last technique I want to talk about is electrical impedance tomography. Electrical impedance tomography measures the changes in air inside the lung by using electrical impedance. Air has a very high impedance, while tissue has low impedance. When we put air into the lung, the impedance increases. So this is expiration, and this is inspiration. And you can see it dynamically, like in a movie. Moreover, you can follow the changes in impedance that translate changes in end expiratory lung volume. Here you see the application of FEB that shows how much the end expiratory lung volume changes. Obviously, the instrument does not measure the end expiratory lung volume in liters or milliliters. So you only have to compare it with a reference measurement, which might be the tidal volume itself. But in mechanical ventilation, you know very well. If this tidal volume is 500 milliliters, then this change might be some 300 milliliters. You make a ratio, and you can compute the change in end expiratory lung volume. In the same time, in this study, as an example, Dr. Mauri studied the effect of psi on end expiratory lung volume. You can see here that the use of a psi every minute, let's say, as in this example, causes an increase in end expiratory lung volume at the same peak. And this might be the beneficial effect of psi in maintaining lung volume, something we do every time, every minute or 2 minutes in our normal spontaneous ventilation. Again, we can see here that if in a patient in pressure support, we might use very high level of pressure support, like in here, or a low level of pressure support. The low level of pressure support, the patient uses more of his diaphragmatic power, and by using the diaphragm, it distributes more volume to the dorsal region of the lung. This is high pressure support. The diaphragm works very little, while here with low pressure support, the diaphragm works more and ventilates more the lower regions of the lung. We can use EIT also to measure lung perfusion. Because saline solution have lower impedance. So if we inject a saline solution into the pulmonary circulation, we'll have a signal of perfusion by a decreased impedance. And so we can measure local perfusion and local ventilation. And we can do local ventilation perfusion matching or mismatching. And in studying COVID-19 patients by these techniques, we were able to show ventilation perfusion mismatch in patients with COVID-19. And we know that patients with COVID-19 have peripheral vascular occlusion, which cause a huge increase in dead space ventilation and often a huge increase in pulmonary artery pressure. These vascular occlusion are often accompanied by an increase in high dimers in circulation product, the fibrin degradation product. So we divided our COVID-19 patients into patients with high dimers and high compliance, high dimers and low compliance, low dimers and high compliance, low dimers and low compliance. This association between dimers and high compliance did not have any effect on mortality, except for patients with high dimers and low compliance, which had almost double mortality than the other three classes. And we published that on Lancet Respiratory Medicine. And I think I have finished my time. And in any case, I will not talk about ultrasounds as a last approach to study lung morphology, matching it with lung physiology, because this is not exactly my topic, and I'm sure there will be some specific presentation about ultrasounds and ARDS. By that, I thank you very much, and I hope you enjoyed the talk.
Thank you, Dr. Antonio, for enlightening us with your talk. I thank all the speakers of this session and the chairpersons, Dr. Deepak Govil and Dr. Shrikant Srinivasan. And now I invite Dr. Parikshit Prayag for our next session on the clinical importance of detection of carbaminoids. Okay. I request you to please display the introduction slide. Now, Dr. Parikshit Prayag is a consultant in transplant infectious disease in Dinanath Mangeshkar Hospital, Pune. Over to you, sir.
So, hello everyone, and again, thank you for giving me this opportunity. So, over the next 15 to 20 minutes, I'm going to be talking about the utility of detecting the different mechanisms of carbapenem resistance. So, when we have these depressing gram-negative bugs in our day-to-day clinical practice, I'm going to be talking about how can we identify the different mechanisms of resistance, and does it really make any difference clinically when we try and identify these mechanisms of resistance? So in the next 20 minutes or so, I'm going to be using this term beta-lactam antibiotics pretty frequently. So let us try and answer the question, what exactly is a beta-lactam antibiotic? So beta-lactam antibiotic basically belongs to any of these four classes. So beta-lactams include penicillins, cephalosporins, carbapenems, and the monobactam, which is astronam. Now, if we look at a gram-negative bacteria, and we'll try and familiarize ourselves with the mechanisms of resistance. So if we look at a gram-negative bacteria, then normally what happens is that this beta-lactam antibiotic, it enters the outer membrane through this foreign channel, and once it enters the outer membrane, it tries to bind to the penicillin binding proteins. And this is where it exerts its mechanism of action. Now, during this process, resistance can develop at any of these 4 points, or any of these 4 places resistance can develop. One mechanism would be that this beta-lactam is not able to enter the outer membrane at all, which means that the bacteria has a modified foreign channel, because of which the beta-lactam is not able to enter. The second mechanism could be that it is able to enter, but it is kicked out by these efflux pumps. The third could be that once it enters, it is destroyed by the enzymes known as beta-lactamases. And since they destroy the beta-lactam antibiotics, these enzymes are known as beta-lactamases. The fourth mechanism could be that the PBP, or the penicillin binding proteins themselves, mutate so that the final step cannot be executed by the beta-lactam antibiotics. So these are the 4 points where resistance can develop along the journey of the beta-lactam antibiotic entering and trying to disrupt the cell wall of the gram-negative bacteria. Now let us try and consider the most clinically important out of all of these mechanisms, which is the production of enzymes. So as these enzymes destroy beta-lactams, these enzymes are known as beta-lactamases. Now, there are many different types of these enzymes, and there is an increasing order of complexity. So the enzymes that destroy only the penicillins are known as penicillinases. If you have enzymes that destroy up to the third generation of cephalosporins, then these enzymes would be known as AMP-C enzymes. So they destroy up to ceftazidime or ceftriaxone, but they are not able to destroy cefepime or carbapenem. So these typically are known as AMP-C enzymes. Now we have extended spectrum beta-lactamases or ESBLs, which are able to destroy all the generations of cephalosporins. So these are cephalosporinases. So these are also able to destroy cefepime. And typically the drugs of choice for them are carbapenems. And then last but certainly not the least, we have the carbapenemases, which are able to destroy the carbapenems. So this is how you classify these enzymes. So either you classify them based on their substrate, which means that you either call them a penicillinase or an extended or a broad spectrum penicillinase or beta-lactamase, or you call them a carbapenemase. Now there is another popular way of classifying these enzymes, and this classification is known as the amylase classification. So amylase classification basically divides these enzymes into 4 different groups or 4 different classes. Now you have class A, which contains many different penicillinases, ESBLs, and carbapenemase. Then you have class B, which are the metallobeta-lactamases, which are the Wim-based enzymes, and these typically contain Wim, NDM, or the New Delhi metallobeta-lactamase, IMP, and so on. Class C contains only AMPCs. So class C does not contain carbapenemases or ESBLs. It contains only the AMPCs. And then you have class E, which is again a big, broad, huge, heterogeneous family of oxoenzymes. And within this family, you have ESBLs. Within this family, you have carbapenemases. You have got penicillinases. So really, each enzyme is different as far as its ability to destroy the beta-lactams is concerned. So looking at this structure or looking at this classification, you already know that there are many different enzymes that exist, and each enzyme has a peculiarity, which means that each enzyme has a peculiar power of hydrolyzing the beta-lactams. So some of these enzymes are more potent at destroying some antibiotics compared to the others. So that is why it's very important to clinically know which enzyme we are dealing with. And we'll see over the next 10 or 15 minutes how and why that is important. Now, before we start and try and see why it is important to detect the enzymes which are involved, let us try and see how can we actually detect these enzymes. So in 2021, this is not just a theoretical talk. We can now actually detect many of these enzymes. So there are different tests that are used across laboratories and hospitals in the world. And these are some of the important tests, or these are some of the common tests that are used to identify the enzymes. So one is the Carba-R test. Then we have got the eSIM and the MSIM tests. Then we have got sepsis flow panels or PCR panels, which is what I personally use in-house in my hospital. And then we have biofire panels, which are now coming up. So let us start with the expert Carba. So expert Carba is a simple test now, which the hospital or the lab that have the Gene Expert platform, they can definitely do the expert Carba because it uses the same platform. So whoever there is a Gene Expert for TB can easily do the expert Carba-R. The expert Carba-R, is it really useful? Yes, because it identifies the 5 good basic carbapenemases that you see in clinical practice. So it identifies IMP, Wim, and NDM. And what are IMP, Wim, and NDM? These are our group B carbapenemases, or these are our zinc-based enzymes. So these are group B enzymes, and these are well identified by the expert Carba-R. Then it also identifies KPC. Now, what is KPC? KPC is a class A carbapenemase, but KPC is clinically less relevant in India because epidemiologically, India is not the epicenter for KPC, which means that, in other words, KPCs are not endemic in India. They are more endemic in the Western world. So if you see, majority of the carbaphenamases in the United States are KPC enzymes. And the other enzyme that it identifies is OXA48. So very important, because OXA48 is the main carbaphenamase of Enterobacteriaceae. When I use the word Enterobacteriaceae, it means E. coli, Klebsiella, Serratia, Enterobacter, Citrobacter, and so on. So these Enterobacteriaceae, when they produce a carbaphenamase, many of them actually produce an OXA48. So OXA48 is an important enzyme of Enterobacteriaceae. Again, OXA48 is not a simple enzyme. OXA48 has different subtypes like OXA48 or OXA162. So many of the time, depending on what exact enzyme we are dealing with, you could see different susceptibility patterns in the blood cultures or in the isolates that you are culturing. Now, the export carbair is a test that identifies these 5 important enzymes. So, of course, it doesn't identify many of the other oxals. It doesn't identify some of the ESBLs like CTXN. For example, CTXN is the most important ESBL of Klebsiella in India. It doesn't identify many of the enzymes of Acinetobacter or Pseudomonas. For example, if you take into account Pseudomonas, then its main enzymes are group B enzymes that it identifies well. But the group B enzymes of Pseudomonas, like OXA2, 5, 10, or 50, these are the kind of enzymes that are not well identified by the carbair test. So it's not a comprehensive test, but it's a very useful test in clinical practice, because it tries to identify these 5 important enzymes that we see in clinical practice. And more importantly, when you are trying to answer questions like, should I combine Astronom with Ceftazidime avibactam for, let's say, Klebsiella or E. coli, the carbair test many times will provide you with the answers for these questions, as we will see later on in the clinical cases. So for Klebsiella and E. coli especially, the carbair test is a very good test that we must all use and try and identify these enzymes. Then ESIM tests and MSIM tests, these are basic tests, but these are extremely good tests and clinically very reliable. So the MSIM test basically is going to tell us whether a carbaphenamase is present or not. If it is present, then we are interested in knowing whether this is a metallo-beta-lactamase or this is a serine carbaphenamase, which means that are we dealing with a group B enzyme or are we dealing with a non-group B enzyme? So again, very robust test, very dependable test. And then this is something that I use in-house. So this is a PCR panel. So this uses hybridization in situ plus PCR, and that tells me many of the clinically relevant enzymes. So this is almost a 20 enzyme panel that we use in-house. And as you can see here, it is a fairly comprehensive test because it tells me OXA23 and 24, which are enzymes of Acinetobacter, OXA48 again, which I mentioned is the main enzyme of Klebsiella, E. coli, and so on. It tells me OXA51 again. We see OXA51 quite a bit in the Indian Acinetobacter isolates. It tells me many of the group B enzymes like M, WIM, and NDM, and it also tells me many of the ESBLs, like it tells me CTXN, which as I mentioned is one of the important ESBLs in India. It tells me SHVs and so on. So again, this is a fairly comprehensive test, and the advantage is that once you have positivity detected in the blood cultures, in the next 4 hours or so, you can actually have the enzymatic results. So this is a real life experience, or this is a real patient. The blood culture showed growth, and as soon as the blood culture beeped positive, we actually run the enzymatic panel on this, and in the next 4 hours, which means almost 24 to 48 hours before I get the susceptibility patterns, this test tells me which enzymes are present. So look at this patient, for example. It tells me in the next 4 hours that this is a Klebsiella, and it is producing SHV, CTXN, NDM, and OXA48. So once I look at this kind of an enzymatic pattern, I know that if I use something like avibactam will be able to destroy SHV, CTXN, and OXA48, but not NVM. But what is the good news? The good news is that the NDM will not be able to destroy aztreonam, which means that if I combine avibactam with aztreonam, I'll be really well able to cover this Klebsiella. So 48 hours before you get the actual culture results or the susceptibility results, I'm able to know with a fair amount of certainty and with a fair amount of confidence that if I combine ceftazidime avibactam, because we commercially still don't have aztreonam avibactam in India, so if I'm able to combine ceftazidime avibactam with aztreonam, then I'll be able to really cover this Klebsiella very well. So these are the kind of important clues that these tests give us. And then you have the BioFire panel. So the BioFire is coming up with a newer panel known as the BCID2 panel. So similar to the PCR panel that we use in-house that I showed you, this is similar, except that, it does not identify as many enzymes. So it identifies all the enzymes that the Carba test identifies. Additionally, it identifies CTXM, which I think is a very good addition. And then it identifies one enzyme of colistin resistance. But unfortunately, that's not a very common enzyme on the Indian subcontinent. We have got other enzymes involved in colistin resistance here in India. And then it also identifies some gram-positive enzymes. So again, within 3 to 4 hours of a culture being positive, you will be able to have these results and you will be able to tailor therapy accordingly. So really, I find these kind of tests or these pieces of information very relevant and useful in clinical practice. So which are our main enemies here in India? If you talk of E. coli, it's mainly Indian, then OXA48. For Klebsiella, it's the other way around. For Pseudomonas, clearly the most prevalent carbapenemases are the group B carbapenemases. And for Acinetobacter, our main enzymes in India are OXA23, 24, and 51 and 58, as I mentioned. Now, what has been our experience so far? As you know, now we've been doing these PCR panels for almost 2 years, and 40% of our carbapenem-resistant Klebsiella have actually been colistin resistant, provided you do colistin susceptibility testing in the right manner. 87% of our carbapenem-resistant Klebsiella have been multiple enzyme producers. So that's a genuine problem in India. Your Klebsiella will not just be producing OXA48 or NDM, it will be producing a host of enzymes, like the patient I showed you, like SHV, CTXM, NDM, OXA48. And that is really the time when you need to know the kind of enzymes that it is producing so as to tailor antibiotic therapy. It's like a game of chess. Whatever the bacteria or the bug is trying to produce, you are trying to counteract. Then 60% of our Klebsiella have actually produced 2 carbapenemases. CTXM has been the commonest ESBL. For carbapenem-resistant Klebsiella, OXA48 has been the commonest carbapenemase. For E. coli, it has been the other way around, the NDM. And very few patients, less than 5% of the patients have actually had a genotypic phenotypic discordance, which means that whatever the PCR test gives you, the next day, the blood cultures or the reports of the susceptibility test do not agree or do not concur with the genetic testing or with the PCR testing. That has happened in less than 5% of the patients, which means that for 95% of our patients, based on the enzymatic test, we have been able to correctly modify antimicrobial therapy. And so I'll give you about 3 or 4 cases which are real life scenarios, and how detecting these enzymes or detecting these mechanisms of resistance helps us in clinical practice. So my first patient is a 40-year-old male with AML, status post-induction chemo, now with febrile neutropenia. So on the 5th day of his neutropenia, he develops a fever. He started on piperacillin tazobactam. 4 days later, he remains febrile. So the hematology team changes him to meropenem. Day 6 of fever, continues to have fever. And now the lab calls you saying that, the blood cultures are growing, lactose fermenting GMBs. So you're really worried that this patient is growing something like a Klebsiella or an E. coli. So what would you do at this point of time? Clearly, he is not responding to meropenem, and he's growing lactose fermenting GMB. So my guess is that he's growing either Klebsiella or E. coli, probably Klebsiella 1 in an E. coli too if you had to put your money on it. Now you have various options, changing to colistin-based therapy, using combination therapy with colistin or polymyxin, or changing to a DLBRI combination, something like ceftazidime, avibactam, plus or minus astronam. So that is the time when I dial up the number of my microbiology department and ask them to run the enzymatic panel. So 4 hours later, they have informed me already that, this patient is growing the lactose fermenting GNB in blood. 4 hours later, they are able to give me this wonderful information that this patient, this is the same patient that I showed you previously, is actually having a Klebsiella in the blood, which is SHB, CTXM, NDMN, OXA48 producing. So what do you use for this? So as I mentioned, if you use avibactam, it's going to destroy SHB, CTXM, and OXA48, and the NDM is going to remain. Luckily, the NDM is not going to be able to destroy our astronam. So if you combine astronam with avibactam, you will have this bug covered. And this is what actually is reported 48 hours later. So if you look at the susceptibility pattern, astronam is resistant. Why? Because of the fact that SHV, CTXM can destroy astronam. So SHV and more so CTXM is destroying the astronam. So astronam is resistant. Now why is ceftazidime avibactam resistant? The reason is that this bug is also producing NDM. So NDM destroys ceftazidime. So that is why ceftazidime avibactam and astronam on their own are resistant. But because I knew the enzymatic pattern, I was able to change to Zavicefta or ceftazidime avibactam plus astronam combination therapy almost 48 hours before. Now, what do I do when I have culture? You should not just go by the genetic results or the genotypic test. You should actually confirm combination susceptibility. And there is increasing evidence to suggest that drug elution testing is the way to test for synergy. And this is how we actually do synergy testing in our setup. This is something that I got my microbiologist to do in the last 2 or 3 months by drug elution methods. You can also use this, and you will have the zone of hope, as we call it. But so this tube contains astronam and this tube contains Zavicefta. So look at the kind of clarity or the lack of turbidity that we have when you combine Zavicefta with astronam. So you should always confirm these genotypic results by actual synergy testing. And that is why this patient was able to do well when we combine Zavicefta with astronam. Now, here is another patient with fever and abdominal pain who is found to have liver abscesses. He undergoes drainage in the liver abscess and he was found to have Klebsiella in the abscess culture. And this shows the presence of CTXM and OXA48. So, very importantly, this does not have NDM as a part of it. So, when I look at this enzymatic pattern, I know that I really do not need astronam for this patient because avibactam will be able to destroy both CTXM and OXA48. So, I expect my Zavicefta or I expect my ceftazidime avibactam to be susceptible. And that is what was confirmed 48 hours later. But again, 48 hours prior to this susceptibility result, we could put this patient on ceftazidime avibactam monotherapy, and this patient did well. Next case is a post-Hapner stem cell transplant recipient for AML. He is now day +9. So he has not engrafted as yet. He is a haplo stem cell transplant patient, so he is still neutropenic, has not yet engrafted. Blood cultures show pseudomonas, and it is resistant to carbapenem, so resistant to astronam. Now the enzymes get detected are NDM and OXA50. Now what will you use? So this is a little bit trickier. Now, if I use my ceftazidime avibactam plus astronam, there are a couple of important things here. One is that some of these panels do not identify all the pseudomonal enzymes comprehensively, which means that they do not identify AMP-C. They do not identify some of the ESBs of pseudomonas like PER or VEB or the webs as we call it. They do not identify some of the other oxas like 2, 5, 10, 50. Now, here we have the OXA50, but many of the commercially used tests or the tests that I showed you do not identify the pseudomonal enzymes comprehensively. Which means that when I get this type of information, I'm not completely sure whether ceftazidime avibactam plus astrolam combination will cover it. So if I have only this enzymatic information with me, I will probably go for something like polymyxin, and if the patient is really sick, go in for polymyxin plus ceftazidime avibactam astrolam, or go for something like polymyxin plus prolonged infusions of carbapenems plus fosfomycin, something like that. So again, these are the important nuances that we need to know. What are the enzymes that we are dealing with? What is the bug that we are dealing with? And once we have this information, then we have to get help from our ID colleagues, or we have to get help from our microbiology colleagues and try and decide what is the best treatment for this particular patient. Now I have a patient with Klebsiella and blood cultures, and the sepsis flow or the PCR panel tells me that this is a pure KPC producer. Then this patient is not affording something like ceftazidime avibactam. So ceftazidime avibactam would have been a good choice because avibactam would have destroyed the KPC. So what are the other options? One thing is to go for a polymyxin-based therapy. But now with the latest evidence, the PK/PD of polymyxin is difficult to achieve. So for example, usually for Klebsiella or usually for these bugs, we like to see a good AUC to MIC ratio. So we like to see an AUC to MIC ratio of at least 25 when we are dealing with bacteremias, and very high ratios. So something like more than 100 when we are trying to deal with respiratory infections or pulmonary infections. Now, many of our Klebsiella or many of our gram negatives, for them actually we don't have accurate MIC because we really don't do the manual work microdilution to give us the exact MIC. And we do not even do colistin levels across most centers in the world because these are difficult to do. Colistin levels are not technically easy, and their interpretation is also riddled with many nuances and uncertainties. So that's why I do not have a good MIC with me. I do not have good colistin levels with me, or all this is unknown, which means that I'm unable to calculate the true AUC MIC ratio of many of our patients who are on polymyxin. So that's why polymyxin therapy has a high chance of failure, and there is increasing evidence actually now that DLBL combination therapy can be better when compared to polymyxin therapy. But when we know about the kind of enzymes that we are dealing with, the sites of penetration of these antibiotics. So when you have all the information with you, only then you are in a good position to sort of tailor therapy. So one intuitive combination for this patient, since he is a pure KPC producer, would be using ertapenem and meropenem together. The reason is that KPC has a preference or has a liking for ertapenem. So it preferentially destroys ertapenem. So most of the KPC is actually used up in destroying ertapenem, and that spares my meropenem. So there are case reports, of combining ertapenem with meropenem for KPC. So again, this is how you can use these kinds of information to your advantage. So in summary, gram-negative resistance can have different mechanisms. So it can have coding mutations, efflux pumps, which I did not cover because I wanted to mainly highlight the enzymes, and then enzymatic mechanisms of the production of beta-lactamases. It is important to understand these mechanisms to optimize therapy. It is important to get familiar with these enzymes. So I think time has come now in 2021 when all of us who are dealing with patients who have resistant gram-negative bugs here in India, we need to familiarize ourselves with enzymes. We can no longer say that it's something which is only a theoretical aspect. It is practically relevant, and this problem is upon us in huge proportions. So I think it's important to familiarize ourselves with these enzymes. Important to know the local enzyme patterns. So it's important to know the kind of enzymes that exist in our country, the kind of enzymes that exist in our hospitals. And it is essential to identify these enzymes and tailor therapy accordingly. So with that, I'll end my presentation. So thank you very much for your patient listening, and thank you very much for having me. And I look forward to the rest of the discussion.
Thank you, Dr. Parikshit. It was a very engaging talk and a very clinically relevant topic. So for the next lecture, I would like to invite Dr. Supradeep Ghosh, who is Director Critical Care Medicine at Fortis Hospital, Faridabad. And he will be talking about one of his favorite topics, that is the role of balanced crystalloids. Over to you, Dr. Supradeep, please.
Thank you, Devin.
So today we are going to talk about the balanced crystalloids and what is their current role in today's scenario. So I must say, and I must admit that there is no physiological ideal fluid solution available commercially. And the effect of all these fluid solution depends upon how much volume you've infused. And we expecting that with the infusion of volume, it will increase the mean systemic filling pressure and in turn increase the venous return in some correct right patient. But we also are aware about the fact that excess of volume produces worse patient-centered outcome. The effect of different fluid solutions also depends on its composition, including the ionic content of all these crystalloid solutions, different buffering substances like lactates, acetate, gluconate, and maleate. We are aware about the differences in strong ion between these solutions and the effect of osmolality on the body. Coming to different isotonic crystalloids, the most important thing is these are all the isotonic crystalloid solutions which are available in India. Strikingly, if you can see, the sodium and chloride content of normal saline or 0.9% saline, I don't know whether I should call it a normal saline or not, is substantially higher compared to the plasma, leading to a high chloride infusion to the body, producing hyperchloremia. Considerably, the ringal lactate, plasmalite, and shirofundin, they have much less and sodium and chloride content closer to the normal plasma. But they are not same. They have significant differences in calcium and magnesium content, and they all have potassium content. And because of this potassium content, there is a concern that if you give a balanced crystalloid solution, there is a higher risk of hyperkalemia. I'd like to tell you that this is a myth, because once you give a high volume of solution, the potassium content of all these balanced crystalloids, they get rapidly diluted in the extracellular fluid compartment. And moreover, all these balanced crystalloids have got high SID, thus they alkalinize the extracellular fluid, moving the potassium to the intracellular compartment. And this can be seen from these 3 studies which are published on this particular aspect, whether balanced solutions produces more hyperkalemia or not. In all these 3 studies, one was from India, Ahmedabad. They compared normal saline infusion with ringal lactate in patients who are at a high risk of hyperkalemia. These are all perioperative fluid management of kidney transplant. And not surprisingly, ringal lactate actually produces less hyperchloremia and less metabolic acidosis compared to saline group. Coming to the different buffering substances, we know that ringal lactate contains lactate, and there are some concern about the lactate because lactates are metabolized primarily in the liver, which may be overwhelmed in the presence of hepatic failure. And there is also a theoretical concern regarding the high lactate concentration interfering with our lactate measurement while resuscitating the patients. To counterbalance that, ringal acetate plasmalite and sterophundins contains acetate, which are less dependent on hepatic dysfunction, but they are not perfect. High acetate may produce myocardial toxicity. It has been shown in animal model, and we do not know in how much volume of acetate is required in human, and how much in what category of patients this myocardial toxicity is manifested even in human, and this may lead to hypotension. We have gluconate. Gluconate is there in plasmalite, which are metabolized very slowly and almost excreted unchanged in the urine. That's the reason the effective SID of plasmalite is closer to the plasma. But it can give, the gluconate can give a false positive result for galactomannan assay. Maleate is present in sterophundin, which is, as of now, we know very little about its metabolism. Now, coming to the understanding a little bit about the strong ion difference, unless we understand a little bit about the strong ion difference or SID, it will be difficult for us to understand the balanced fluid as such. If you see, according to the law of electroneutrality, all the cations must be equal to all the anions. So in the left-hand side, if you see sodium plus potassium plus calcium plus magnesium plus all unmeasured cations, they must be equal to chloride, albuminate, phosphate, bicarbonate, some unmeasured anion. So if you see, if the sodium level goes down or chloride level goes up, the bicarbonate is squeezed, thus producing metabolic acidosis. This is the fundamental behind the Stewart's approach to defining the mechanism of metabolic acidosis. So if you give a lot of fluid, they will have some effect on the strong ion difference, and they will have some effect on the metabolic milieu of the patient. So as a rule of thumb, if you give a crystalloid which has got an SID, which is equivalent to the baseline of bicarbonate, the pH remains unchanged, provided the PaCO2 is constant. On the contrary, if you give a large volume of crystalloid, which has a SID more than the baseline bicarbonate of the patient, the pH increases, provided the PaCO2 is constant. Otherwise, if the crystalloid which you are giving, which has got a SID less than the baseline bicarbonate of the patient, the pH decreases at a constant PaCO2, producing acidosis. So this is the main mechanism. And if you see at the bottom, the SID of different commercially available solutions, compared to plasma, which has got an SID of around 40, because it mostly consists of the sodium and chloride. So if the sodium is 140 and chloride is around 100, so the plasma SID is roughly around 40. The saline, the 0.9% saline contains only 0. So if you infuse 0.9% saline, it is obviously going to produce metabolic acidosis. And but other commercially available balanced solutions with the ringal lactate, plasmalite, or sterophundins, they all have an SID much higher than normal bicarbonate of more than around 24. So this high chloride content, there is a chance that it can produce renal side effects by tubuloglomerular feedback mechanism, which was shown in this particular volunteer experiment, where they found that compared to plasmalite, the 0.9% saline produces more hyperkalemia, decrease in the SID, decrease in the renal artery flow velocity, decrease in the renal cortical function. So there is a chance, there is a possibility that in patients who are susceptible to renal injury, they have a higher risk of producing renal damage because of hyperkalemia of 0.9% saline. So the McDunis and his team, the colleagues, they did a study where they tried chloride liberal fluid given for a control period of 6 months, and chloride restricted fluid for an intervention period of 6 months to see the effect of chloride liberal fluid, just like saline or some 5% albumin or 4.5% albumin, whether they produce more renal injury or not. And they could find out from their study that in the intervention period where people used chloride restricted fluid like balanced salt solutions, they have a decrease in creatinine rise. They have a lower risk of renal injury defined by the Rifle class I and F, and they have they had lower renal replacement therapy. And they extended the study and they found a similar effect. But there are some problems with the studies because it was a single center study and it was not blinded. There was a lot of interventions taken place, and there is always a chance of bias. So we need more data from randomized control trial. We'll come to that. What about mortality? Does 0.9% saline produces more mortality compared to balanced crystalloid? This was a retrospective study done by Karthik Raghunathan, and they found by a large cohort of patients of sepsis, around 7,000 patients, that balanced crystalloid, if you infuse this patient with balanced crystalloid, they have a lower in-hospital mortality. And this is dose dependent, meaning thereby, if you resuscitate the patient with more ringal lactate or plasmalite or sterohundine compared to 0.9% saline, you have a lower risk of mortality for your patients. But again, we need randomized control trial data. So these are the 4 randomized control trials which are published so far. I know it's a busy slide, but these are the summarizing the data from all studies. The first study was published from Australia and New Zealand, where they did not find any difference in mortality between plasmalite and 0.9% saline. The second study was published in American Journal of Respiratory and Critical Care Medicine from a single center. It was a feasibility trial. So I'll not whether they just wanted to see whether they can perform a larger study or not. And based on the study of SALT, they published the same trialist group. They published SMART study and SALT TD study. And they found in the SMART study in ICU population, giving balanced solution decreases the incidence of something called MAKE30, Major Adverse Cardiac Event. Whereas in the SALT TD trial, they tried hospital-free days as the primary outcome, and they found the balanced fluid group has got lower hospital, higher hospital-free days, not lower, it's higher hospital-free days. So there was some trend towards a better outcome in balanced fluid groups, but there are a lot of problems with these studies. So there were significant limitations in the study design. Different balanced crystalloids were clubbed together, particularly in SALT, SMART, and SALT TD. The indications for fluid were not specified, especially in SPLIT, where they did not, they combined all maintenance fluid and resuscitation fluid together. Primary outcome measures were sometimes not truly patient-centered. For example, this MAKE30 is a very funny thing, you know. How can you club together mortality with renal, persistent renal dysfunction with the requirement of RRT together at 30 days? So sick patients were probably not represented well in these studies, and the fluid volume infused was very limited. For example, in the SPLIT study, the fluid volume infused were around 2 liters, whereas in the SMART and SALT TD, they were around 1 liter. That's very, very limited. So there are 2 more studies going on in Australia and New Zealand, PLUS study, and there is a basic study going on in Brazil, but because of the COVID-19, both of them got delayed. So hopefully we'll get more result in future. Osmolality is different, significantly different in these solutions. And we know the hypotonic solution, particularly all these balanced solutions, their effective osmolality is less compared to the plasma. They have a propensity to produce more cerebral edema in patients with head injury. So my take-home points is we need all types of fluid infusion in our basket. We can't say that, okay, we give only balanced fluid solution. We need 0.9% saline for patients with head trauma or patients with ICSOL or patients with any head injured patients. Or we need normal saline or 0.9% saline for patients who are hypovolemic because of vomiting. But overall, there is an edge of balanced fluid over the saline. But do not forget about the volume and rate of infusion. Thank you very much.
Thank you, Dr. Supradeep Ghosh. It was a very engaging talk. I just have one question for you, Dr. Ghosh. In your day-to-day clinical practice, where do you really use crystalloid solutions, balanced crystalloid solutions?
Then I prefer always, in most of the patients, a balanced crystalloid solution, whether it is a ringal lactate. Okay, I think I'm not technically great. Yeah. So I prefer a balanced crystalloid solution for all types of resuscitation, except some exceptions. Probably either the ringal lactate, which is cheap and widely available, or a plasmalite or kebilite commercially available. Sterophundine I hardly use because of not any particular reason. But there are some exceptions, except some exceptions, like head trauma patients with traumatic brain injury, along with who requires resuscitation for this. So most patients resuscitation we do with a one of the balanced fluid solution.
That's true. There is emerging literature regarding the use of balanced solutions in all the fields of critical care medicine now. We also tend to use balanced solutions whenever we need more than 2 liters of fluid resuscitation. So that is what our cutoff point is. And that is
so
what
for me, I don't wait for even 2 liters. From beginning only, we start.
Whenever we anticipate that the patient is going to require more than 2 liters, a patient with DK, patient with shock, we are going to give him a lot of fluids. So in such patients, we would rather begin our resuscitation with the balanced solutions only.
Yeah, even for DK, we use ringal lactate.
Yeah.
Anyway, there is not much of data supporting or against it.
But there is emerging literature. That is what you had also shown. Thank you, Dr.
I think
Ghosh.
it is time for us to switch over from normal 0.9% saline to balanced crystalloid altogether, except probably in head trauma.
Yeah, I agree with you, Dr. Ghosh.
Thank you.
Thank you, Dr. Ghosh. Now I think we can move ahead. The next talk is on MSSA infection. And it will be taken by
Evan,
Dr.
can I
Sarkar.
leave? Can I leave?
Yes, sure. Thank you, Dr. Ghosh. Thank you. So for the next talk on MSSA infections, I would like to invite Dr. Sarkar, who is the Chief Intensivist and Head Anesthesia Service at Vivekananda Hospital, Durgapur. And his area of expertise is advanced hemodynamic monitoring, TE, and pediatric critical care and anesthesia. Over to you, Dr. Sarkar.
Very good morning to all of you. Respect to all my seniors and chairperson, and my heartiest congratulations to the entire organizing committee of Criticare 2021 for this virtual conference. Without any further delay, I am going to my topic straight away. The time allotted to me is only 15 minutes. It's a huge topic and it's a very interesting topic too. The management of MSSA are real-time insight. But before going to my presentation, I must say there is no conflict of interest. It is an article of 2005 where it has been clearly mentioned that penicillin-resistant penicillin remains the antibiotic of choice for the management of serious MSSA infection. We should discuss why I have presented this article as a first slide of my presentation. These are the different topics I am going to discuss. The Staphylococcus aureus is discovered by Sir Alexander Opston in 1880. This is coagulase positive pathogens and coagulase negative, commonly the commensals. The Staph aureus epidermidis, saprophyticus, hemolyticus, and intermediates, because of the hemolysis and the leukotoxins, they produces different infections in the form of toxic shock syndrome, staphylococcal scale skin syndrome, food poisoning, superficial skin infection, and localized abscesses. And if it goes in deep, it can produce infective endocarditis, UTI, intravascular cath infection, bacteremia, osteomyelitis, and bone and joint infection. MSSA CC398 as an emergent human pathogen around the world. France, nasal colonization has increased in Europe, in New York, specifically in ethnicity in Domitian neighborhood, and as well as in Colombia also. Its variant of different kinds are getting found, and it can cause bloodstream infection, bone and joint, skin and soft tissue, as well as severe infection. And couple of studies has clearly shown that 30-day mortality is substantially higher in MSSA group having this type of infection. An article of 2020, the prevalence of the worldwide in different countries were found, and CC398 frequently implicated in severe infection in form of the bloodstream, endocarditis, and bone and joint infection. Again, an article from 2020 where 356 hospitalized individual has been assessed and found 79% cause because of the MSSA, with the predominance of osteoarticular infection of 38%. 2019 Indian Journal of Medical Research, the prevalence of India is actually the MRSA is gradually coming down. We are finding mupirocin resistance, we are finding inducible clindamycin resistance, and actually the MSSA is coming in front. And 93% of the Staph aureus isolated from all specimens were non-susceptible to penicillin. This is a list of non-susceptible percentage of the gram-positive cocci isolated from all specimens. You can see the MSSA list in comparison with the left side, the list of the antibiotics. A case of the toxic shock syndrome. A lady of 50 years of age with hypertension, diabetes, with a dengue fever-like features for 4 days, admitted, and in 24 hours, the lady developed pneumonia, refractory shock, and ultimately succumbed to the multi-organ failure. The microbiological examination revealed it is a pan-susceptible MSA trait. 2020 article, and they found the couple of different toxins in the form of ACC3, ACIL are there that producing this type of features. It is inhibited by amoxicillin, cefoxitin, ceftriaxone, and different antibiotics like penicillin G, piperacillin, tazobactam, rifampicin. The next one is infective endocarditis, a very close topic to all our heart. 3 to 7 per 1 lakh person years, a very fatal disease. Staph aureus, specifically for the IV drug abusers, and streptoviridis is the commonest one. We all know the infective endocarditis has a prevalence in a bioprosthetic valve and an implantable cardiac devices. It is a case, it has been published in 2021, 27 years old lady, 22 weeks of the gestation, with a history of intravenous drug abuse. Developed MSSA tricuspid valve endocarditis with septic emboli. 4 days later, the patient developed decompensated congestive heart failure, baby delivery done, the patient volume status normalized, but fetal demise was there. It is such a virulent one. The STEMI with aortic vegetation. It is actually very, I can say I'm fortunate because just today, I got this type of one case. It's a 53 years old female that admitted in the hospital with a coronary artery disease like features. It was no history of the CAD, like it was the patient is having a features of the myocarditis. Then in the echo, it was found the vegetation is actually blocking the right coronary ostium, the aortic valve vegetation. They had to replace the aortic valve, and ultimately the person survived and went home. The treatment of the bacterial endocarditis, this empirical therapy of the endocarditis, either in the form of the ampicillin, gentamicin, flucloxacillin, or the vanco, the gentamicin, or the vancomycin, gentamicin, or the rifampicin. But if it is a native valve infective endocarditis, the ofloxacillin for 4 to 6 weeks, and cefazolin or the cefotaxime for 4 to 6 weeks. Regarding the prostatic valve endocarditis is concerned, it is actually of 3 types. Early, if it is within 60 days of the replacement of the valve, it is typically iatrogenic. If it is intermediate, 60 days to the 365 days of the implantation of the valve, and late, if it is more than 1 year, the 1 year or the longer after the valve replacement. Regarding the prostatic valve endocarditis is concerned, we have 6 weeks therapy of oxacillin plus 6 weeks of rifampicin, 6 weeks of gentamicin. We have a parallel limbs of the other treatments of 6 weeks of cefotaxime, rifampicin, gentamicin for PCN anaphylaxis, cefazolin or the rifampicin, again gentamicin if the PCN. Obviously, the gentamicin always come if there is any PCN anaphylaxis is there. It is published in 2020 endocarditis antibiotic regime. These are the list of the catheter-related bloodstream infection in methicillin-sensitive group. Particularly patient with the hemodialysis, the prevalence you can easily see. The central venous catheter 3 months 35%, 6 months 54%, 12 months 79%, and it can produces a complicated CRBSI, and where the methicillin-sensitive Staph aureus 6 to 8 weeks antimicrobial therapy is there. Beta-lactam is better than the vancomycin. These are the different comorbid source of infection and complicated situations. Regarding the complicated CRBSI, the management is better if it is MSSA, straight beta-lactam, the flucloxacillin, oxacillin, and cephalexin. 2 gram 4 hourly intravenously. MRSA, daptomycin is definitely having lower mortality. The next one is an osteomyelitis, most common Staph aureus and the epidermidis. Contributing factor, the patient is having the high age, diabetes, peripheral vascular disease, IV drug abuse, surgical implants, spread of infection if it is a hematogenous, 20% in adults, 85% in pediatric population. These are the different way how the osteomyelitis progresses, and diagnosis and management is majority by the bone biopsy and obviously the culture. The first line of treatment for MSS osteomyelitis, flucloxacillin or the oxacillin or the napsylin, but it should be minimum for 4 weeks duration. But for an outpatient where we need the parenteral antimicrobial therapy, where we need the cefazolin, ceftriaxone, vanco, tico, or the daptomycins we have in our hand. These are some newer drugs that also come in methicillin-sensitive Staph aureus osteomyelitis. These are the non-antibiotic therapy or the local antibiotic therapy in the form of implantation, regenerative biomaterial, or a non-biodegradable AMA or the non-AMA. Regarding the Staph aureus bacteremia, vancomycin is associated with an increased mortality compared to the beta-lactam therapy. If it is a mixed infection, MSS isolates are susceptible to the ampicillin or sulbactam or piperacillin tazobactam. Sorry. Cefepime, ceftriaxone, ertapenem, and the meropenem can be there. In mixed infection, if it is an active, actually no need of addition of vancomycin. It always comes as a first line for severe PCN allergy. It's a case of an unusual presentation. A 60-year-old lady in UK sought medical care for the malaise, sore throat, and the joint and muscular pain. Then the lab isolated MSS from the blood culture. They have found antimicrobial susceptibility, shows susceptibility to the cefoxetine, rifampicin, ciprofloxacin, but resistant to the penicillin. But the oxacillin MIC testing confirmed flucloxacillin sensitivity is there. Why it is unusual presentation? Because it came with a lot of complications like a large retropharyngeal right psoas collection of the pus, bivasal lung consolidation, discitis, osteomyelitis of the C3, C4 vertebra. These are all just to express in what different way and in what extent an MSSA can come to us with different types of presentations. Regarding the Staph aureus bacteremia, the first line obviously the oxacillin, cefazolin, and the vancomycin. The treatment duration, the treat for 14 days from negative blood cultures must fulfill. The exclusion of the enterocarditis is there, so we have to fulfill before we go to the treatment duration. The condition must fulfill that the exclusion of endocarditis is there, no evidence of the metastatic infection, no implanted prosthesis, negative follow-up blood culture 48 to 72 hours after initial set, a resolution of the fever within 72 hours initiation effective therapy, no immunosuppress or neutropenic, and removal of any indwelling catheter. Complicated MSS bacteremia defined as the patient with positive blood culture result who do not meet the criteria for uncomplicated bacteremia. An ID consultation is strongly recommended 28 to 48 days from the negative blood cultures with IV therapy. This is a chart taken from the Australian board where it has been said that if the patient is having a suspected or the proven Staphylococcus aureus bacteremia, the first drug of choice is flucloxacillin 2 gram. In a children event, 50 milligram per kg up to 2 gram. IV 6 hourly we have to give plus vancomycin. And flucloxacillin can only be replaced if there is by the cefazolin 2 gram 8 hourly if the patient is found delayed penicillin hypersensitivity. And obviously, in an immediate hypersensitivity, there is no way we have to use vancomycin only. Then when the Staphylococcus aureus bacteremia is confirmed, then we have to find whether it is a MSSA or MRSA. Regarding MSSA, obviously, we need to cease the vancomycin and continue with the flucloxacillin. And once the antibiotic therapy goes on, then the repeat bulk culture 48 to 72 hours after commencing the antibiotic. And depending upon it is a complicated Staphylococcus aureus bacteremia or it is an uncomplicated bacteremia, we need to decide and go accordingly that I have already described and mentioned. It is an article that is actually a case what I got just today. The patient actually, today's patient was posted for a mitral valve replacement. And when I did the transesophageal echo evaluation, I suddenly found the tip of the aortic valve has a very small vegetation. And I did the 3-dimensional T, and by enlarging, I found definitely the margins are vegetated, but the valves are absolutely compatible. So jointly we decided not to touch the valve, but we started a flucloxacillin therapy as and therapy in the post-operative period. 2 gram therapy we need to continue because the patient is diagnosed as an infective endocarditis, the vegetations of the aortic valve tip. This is the study where it has been said that actually it's a nice study. It is in vivo effect of the flucloxacillin in experimental endocarditis caused by the MAC-C positive Staph aureus showing temperature dependent susceptibility. In 37-degree temperature, whether flucloxacillin works nicely same as in MSSA or MRSA, the study is based on that. And they found it's the flucloxacillin therapy is actually giving better result. So I have another exactly 1 minute 15 seconds left. The take home message, it's a huge topic. As an intensivist, we all deal with the MSSA organisms in different forms, whether it can be a cardiac setup, it can be a non-cardiac setup. My take home, or I can say, is I am using flucloxacillin from last 2.5 years. Not only for infective endocarditis or MSS organism, but also as a prophylactic in cardiac surgery. So I feel as an intensivist, the MSSA real insight comes or gives us an opportunity to discuss to reshape the use of the antibiotic prophylaxis. It's really a virulent organism. It can come to any form. So we need to come to a very structured stewardship regarding this organism tackle is concerned. So with this, I shall conclude my presentations, and definitely I'll wait all the experts' opinion so that we can have a fruitful discussion. Again, before I sign off, I heartiest congratulations to all the entire Criticare 2021 team, and my sincere regards to all the other faculties and chairperson. Thank you very much.
Thank you, Dr. Sarkar. I don't think there are any questions for you, Dr. Sarkar. Maybe we can just move ahead with the next presentation then. For the next presentation, I would like to invite Dr. Rahul Pandit, who is Director Intensive Care at Fortis Hospital, Mulund, Mumbai. And he'll be talking about the emerging role of thymosin alpha-1 in the management of severe sepsis and septic shock, rather. Can you please start the talk?
Hello, friends. This is Dr. Rahul Pandit. I am here to talk about thymosin alpha, which is a new molecule which seems to be sort of helping us in immunomodulation in septic patients. And over the next 20 minutes or so, I would like to talk about how it is going to help probably in the septic patients and see where we are going with it. I thank Gufic Life Sciences for supporting this session. So let's look at the overview of this lecture. Thymosin alpha in sepsis. I'm going to look at the sepsis definition, the new sepsis definition, a little bit of epidemiology and risk factors, site of infection, treatments of sepsis, then the failed novel pharmacological agents. Then we're going to talk about a little bit of history, what's happened in the last 30, 40 years, the pro and anti-inflammatory balance in septic patients, clinical and laboratory investigations and evidences for sepsis being an immunodepressive disorder, and then what are the immunological challenges posed in sepsis, what immunotherapies can be tried, and then we'll look a little bit at a cellular dysfunction and a quick overview of role of thymosin alpha in sepsis. After that, I will just go through the studies which have used thymosin alpha either solo or in conjunction with ulinastatin. So this is going to be the overview of my talk. We all know that we've moved from the old definition of sepsis, which was based on SIRS, and we've come to the new definition of sepsis, which now talks about that sepsis is not just caused by an organism, but it is a dysregulated host response to the infection, which is a very, very different way of thinking, which we've got in the last 3 or 4 years now, that we are actually looking at a dysregulated response to the host. And obviously the septic shock is one in which we fail to restore the mean arterial pressure above 65 millimeters of mercury or lactate below 2 millimoles per liter, despite adequate fluid resuscitation. So with this in mind, let's look how big is the sepsis as a public health concern. Every year, obviously, we have some data coming in from the US, and then we've got our own INDICAP study. We have around 1.6 million cases per year in US and around 30 million plus cases globally with sepsis. Sepsis seems to be one of the leading cause, and it seems to be constantly on the rise, and it is still increasing. And it's one of the leading causes of death in ICUs, as well as in children worldwide. And the mortality probably is estimated to be around 6 to 8 million patients globally who die of sepsis. The current mortality, if you look at the 2018 data which has come out, approximately talks about septic shock mortality between the range of around 30 to 40%. And if you have a 3-year mortality with a patient with septic shock, it goes beyond 50%, which is very, very alarming. Even the WHO recognizes sepsis as a global health priority, and there was a WHO resolution which was passed and published in New England Journal of Medicine, which talked about this. Now, what are the epidemiological and risk factors for sepsis? Okay, last 40 years, we have seen a substantial increase in this. And as I've already said, mortality is basically very, very high. And the risk factors for that seems to be elderly population. Anybody above 65 years of age tends to have more than 2%, 2 times the more risk of being contracted with severe sepsis or septic shock. Immunosuppressive and immunocompetent patients who either have neutropenia, some form of cancer therapy, or immunodeficiency syndrome. Patients who have candidemia, gram-negative septic shock, and invasive aspergillosis. And obviously, the tobacco consumption, alcohol consumption, and cigarette smoking seem to be associated with a higher risk in septic patients. Let's come up to our own country, India. Where are we standing? The INDICAP study done by the Indian Society of Critical Care Medicine, published by Devati et al., talked about ICU mortality in the range of 42% when patients have severe septic shock. And when they did not have severe sepsis, the mortality was down to just 17.6% in ICU. And mind you, the SOFA scores were substantially high, the Apache scores were high as well, but the age did not matter. Age seems to be the same between the severe septic or septic shock patients and non-septic patients. If you look at ICU as a snapshot, we find out that approximately 15.5% of the patients in India were admitted with severe sepsis or septic shock. Now, this was way back in 2016, hence the old definition of septic shock was not sort of considered there. But that's where we stand. We have around 15% of our patients. And if you look at 45%, 40% mortality in this, that's a large number of patients who are dying because of sepsis every year in India. And this is only a snippet of what we are seeing across the globe. This is India, Australia, UK, US, and you can see that the mortality seems to be in the range of around 27 to 30%. We are a little bit higher in India right now. And the SMR seems to cross 1, except for Australia, where the SMR is 0.68. And a 28 days mortality calculated in Australia seems to be around 32%, whereas in India is around 50.3%. And what's important is that the mean hospital stay is approximately 15 days. Now, that's a lot of money spent for many average Indians who don't have really insurance as a part of their program on a day-to-day basis. And hence, sepsis seems to be a very, very important priority for Indians in the Indian ICUs to be actually managed well. Now, I'm not going to enumerate the hundreds and thousands of causes of sepsis, but essentially anything which can cause a disruption of your barriers and cause a bacteria to enter in it is essentially going to be a cause of sepsis. So pancreatitis, tissue ischemia, trauma, burns, central lines, invasive catheters, vasculitis, drug interactions, drug reactions, autoimmune processes, neoplastic processes, all of them essentially contribute as a possible source for sepsis. But what is interesting is that when we looked at the sites of infection, lung and blood seem to be the two most common sites where sepsis seems to originate. And we still have a fair number of undifferentiated sepsis where we actually don't know infection is coming from where. So this is a study which looked at around 500 odd patients and saw that there were more than 100 patients which had more than one site of infection at times, or they were patients who had lung as the most common one, followed by the blood. Now, was it prevalent in children as well as in adults? Now, this is another study which EPIC-2, which looked at the extended prevalence of infection in intensive care, which was gathered from a demographic data of around 14,000 patients. And you can see the lungs in adult as well as children stand to be the most common cause of it, so common site of infection, followed by probably matching with abdominal and bloodstream infection, and then the renal and genitourinary tract. The microbiologic findings amongst children in adults in sepsis seem to suspect that, but this data is sort of coming in from the Western world. So we don't have a lot of gram negatives there, but in India, the major problem seems to be the gram negative, whereas in the European countries and the northern continent of America, we see that gram positive species seems to be the most common, with Staph aureus being the most common infection, and in gram negative, it seems to be E. coli and Pseudomonas, which sort of form the majority of organisms. This type of a data in India would certainly be heavily skewed in favor of a gram negative infection rather than a gram positive infection. And we've known that sepsis sort of affects literally every organ of the body. We have the skin, the bone, the kidneys, the liver, heart. You have your metabolism as a problem, elevated lactate levels, and multiple signs and symptoms can actually be produced in sepsis. And sometimes a simple mental alteration in elderly gentleman, elderly patient may be a sign of a profound sign of a sepsis. So when we look for a clinical assessment, we look for risk factors for infection. We obviously think a bit more hard when they have a geriatric patient, because they may not mount the same amount of response what a young person might do. We look at the possible foci of infection. Obviously, the temperature, blood pressure, lactate, heart rate, oxygen saturation, all of these are taken. Then a specific physical examination followed by a volume assessment and a cardiovascular status is done. And then in absence of automated devices, it is imperative to keep a log and have early recognition of SIRS, followed by sepsis. Usually, the final nail or the best way of diagnosing sepsis is to actually grow an organism from the suspected site or from the blood. And that seems to be the best one to identify it beyond any doubt. But there are around 20 to 30% of the patients in hospital who may not grow anything and would remain culture negative despite having a clear-cut sepsis. Urine analysis seems to yield a particularly higher positivity rate in patients who are greater than 65 years of age, and followed by blood culture and chest radiography. So I think in the test, we should actually be able to understand which are the tests which are going to give us the most likely information, and those are the tests we should do rather than actually going in for a shopping list of tests. So complete blood count, biochemistry, and either a blood cast, which would be either venous or arterial, looking specifically at lactate and acid base, would be very, very helpful. Now, again, I'm not going to emphasize too much on the management of sepsis in terms of straightforward hemodynamic stabilization with use of IV fluids and vasoactive drugs, which is what we have as a mainstay, modulation of host response, and then, of course, infection control, where source control seems to be the thing to do when we have sepsis, if that is possible, and obviously antibiotics. But what seems to be the middle path is the modulation of host response. Now, this modulation of host response has been tried in various ways. We've used steroids, gamma globulins, vasopressins, extracorporeal circuits. We've at times tried bicarbonates, and let's see how each of them have actually helped us. In addition to the standard therapy, there seems to be a favor for an adjuvant therapy. And a lot of adjuvant therapies looking at different functions in the body, looking at targeting different organs, have been actually tried, starting from the anti-inflammatory drugs. Okay, so high-dose steroids, E. coli, antisera, TNF-alpha monoclonal antibodies, and the FAB proteins, and antithrombin. You have the activated protein C, albumin hemoperfusion. There's a list of around 40 odd which have been tried differently. And these were all good ideas which were supported by some amount of preclinical data, the polymyxin D columns. None of them seem to have actually become prime time. They all seem to have some amount of data, but they really have not become prime time. And when they were put up for phase 2 and phase 3 clinical trials, they failed. They failed. The E. coli antisera failed. The activated protein C initially was quite high up in the use, and then as the trials went up, they failed. Statins, nitric oxide inhibitors, bradykinin antagonist. You would use non-steroidal anti-inflammatory drugs, platelet activation factor receptors, anti-CD14 monoclonal antibodies. all of them seem to basically show a good promise in the preclinical stage, but as soon as they came to a clinical stage, they seem to have failed. So it's really very difficult to use that immunomodulation component in patients who have sepsis. And these are some of the studies looking at anti-endotoxin, anti-bradykinin, anti-TNF, anti-PAF, soluble TNF alpha, and steroids. And you can see that there are a total of around 12,000 patients, and the mortality in the study arm and in the placebo arm seem to sort of match at 38% on both sides. And this is way back in 1997. So we know that things have not really picked up in terms of immunomodulation. The two promising things which came out, one of them was the activated protein C in patients with septic shock. And then as the days went by, and we did a new trial, which was published in 2013, which showed that essentially there was no difference. So, there was an access randomized control trial looking at antagonists for MD2 TLR4 on mortality in patients, and essentially it showed no difference in mortality as well. So systemic immunosuppression seemed to sort of lose its steam. Okay, so we've now really in the last surviving sepsis guidelines, we don't have anything which talks about immunosuppression in septic patients. But can we forget the physiology? We can't really forget the physiology. There's got a pathogen and you've got a host, and we know that the response to this pathogen, the dysregulated response from the host, and we need to basically still look at that possibility where we may be able to, target a cell maybe, or maybe an organ, which would actually help in the immunomodulation. And rather than doing a very, very difficult scenario, why not look at something simple, which is lymphocytes? This is one study which was published in Nature Immunology in 2016, which looked at the splenic lymphocytes in septic patients. And these are the brown lymphocytes. These are postmortem samples. And they actually looked at CD4 and CD8 cells. And they found out that the CD4 and CD8 cells in septic patients, the one on the left of the screen are the non-septic patients, one on the right of the screen are the septic patients. You found out that the CD4 and CD8 cells decreased relatively to the control patients without sepsis. And this seemed to sort of favor up the diagnosis or favor up the theory that maybe something which actually stimulates these T cells may be a useful molecule which would actually help us into building up our natural killer cells and fighter T cells to actually come out and protect our immunity. So when we look at the laboratory evidence of sepsis with an immunosuppressive disorder, what are the things which we look at? We know that it has a delayed type hypersensitive response to common recall antigens. It has an apoptosis-induced depletion of immune effector cells, which leads to loss of CD4, CD8 cells. We have a latent reactivation of viral infections like CMV and herpes simplex. We have infections with relatively avirulent organisms like Enterococci and Acinetobacter. And autopsy shows an unresolved foci of infection in approximately 80% of patients who die of sepsis. There are small studies which have actually looked at biomarkers being enhanced like GM-CSF, and then blood studies from patients with or without sepsis, which shows a decrease in the pro-inflammatory cytokine, a decrease in the HLDRA, DRA expression, and then there is the regulatory T cells which go up. So these are some of the laboratory evidences which actually tell us that the sepsis is an immunosuppressive disorder. So what are the immunotherapies in sepsis which could use? We know now that sepsis probably induces some amount of immunosuppression, and from cellular dysfunction to immunotherapy is what we are looking at in changing the whole paradigm of sepsis. So where do we stand? The mechanism of immune checkpoints inhibitors in sepsis is the normal T cell activation to antigen, presentation by antigen presenting cells, the APCs, in conjunction with membrane-bound HLA-DR to a T cell receptors. It ensures an optimal T cell priming and activation and co-stimulation signaling providing through the binding of the CD80 and CD86 of their ligand CD28. Now, these essentially bring out your T cell activation. Okay, so these cells, the antigen presenting cells bring out a T cell activations and then T cell suppressions as well. So in sepsis, it's got to get suppressed. So we have a compelling preclinical studies which show that they improve the bacterial clearance and mortality in mice and restores human immune function in human cells. And then there are some randomized, non-randomized clinical trials or case reports. If you look at the myeloid cell changes in the sepsis, we come to the point that they have the inhibition of these T cell proliferation, and there's the incomplete activation of the T cells, which we know it happens in sepsis. And the lymphoid cells show a decrease in the function, increased regulatory function of your GM-CSF and other cytokines. And it also has a decrease in the effector function and increase in the regulatory function of your B lymphocyte. And the T lymphocytes essentially are having an increased regulatory function as well. So a simplified view would be that when I have a sepsis and this goes down to the immunosuppressive phase, I could use thymosin alpha at that point to sort of have a differentiation and maturation of my T cells, which would increase my natural killer cells, CD4, CD8 ratio, and then would actually improve my HLA-DR and dendritic cells, which would then help in fighting with your own, in boosting up your own immune response to cell. And from immunosuppressive, we actually go back to an immunoactivation or homeostatic phase. This is where thymosin alpha probably acts, and this is where the use of thymosin alpha would be. This is just the same mechanism depicted in a cartoon. Okay, so what's the role of thymosin alpha? It would, immunological changes in sepsis, naturally the HLA-DR expression would decrease, thymosin alpha would increase that. There would be persistent lymphopenia, thymosin alpha would revert that and have an improve in your CD4 and CD8 counts. There would be PD-1 and PD-L1 expression, which basically does not need to happen, and thymosin alpha sort of down-regulates it. TNF alpha regulates and brings it to the baseline, so it does the T regulatory cells. And infection with opportunistic or avirulent organism probably is prevented. So it prevents secondary infection. It prevents possibly secondary viral. These are very bold statements, but that's how it looks like. It probably may be helping a little bit. But certainly the first 3 points of increasing your CD4 and CD8 and your HLA-DR expression seem to be the right thing to do. So let's look at the thymosin alpha in sepsis trials. There have been a number of studies. Obviously, some of them have been systematic review of RTCs. So this was around 530 patients where TNF alpha may be beneficial for septic patients in reducing mortality and modulating the immunoinflammatory reactions. This was another meta-analysis looking at around 1,480 patients. Again, probably significantly reduce in all-cause mortality. Then this was a study looking at multi-center randomized control trial looking at around 300 odd patients. It demonstrated that thymosin alpha therapy in combination with conventional medical therapy may be effective in improving clinical outcomes in a targeted population. And these are small studies looking at 24 patients, 300 patients, 90 patients. All of these studies essentially have shown that thymosin alpha seems to help as an adjuvant therapy in immunomodulation. Now, the other drug which we have talked about and which many of us have used is ulinastatin. So when thymosin and ulinastatin were used in combination, it probably regulates the inflammation bidirectionally, which may simultaneously prevent the immunological paralysis and prevents an excessive inflammation which happens. And this is what was sort of published as a basic science report way back in 2016. And these are some of the studies where ulinastatin and thymosin alpha have been used, and it seems to have a greater improvement in all-cause mortality and a lesser inflammation overall. And another meta-analysis looking at UTIs, it basically TNF alpha and ulinastatin suppresses the production of pro-inflammatory cytokine and shortens the duration of mechanical ventilation and improve a 28-day survival rate. These are just 4 or 5 studies which looked at ulinastatin with thymosin alpha. 100, 200, 500 patients, not thousands of patients, but certainly there seems to be a signal that you could use thymosin alpha in combination with ulinastatin. So I think we have a molecule which probably used correctly may actually help in some amount of immunomodulation and thereby may help us in having a better outcome or perhaps lesser inflammation at least in our patients. I again thank Gufic Biosciences for the support of this talk. Thank you very much.
Thank you, Dr. Rahul Pandit. This does seem like a promising molecule. We have also used it in many patients with COVID-19 pneumonia with moderate results. Obviously, to attribute the success of therapy to one particular molecule is always very difficult. And there is definitely a void in a sepsis management after the withdrawal of activated protein C. So definitely we do need a molecule which can cover most of the aspects of sepsis management, apart from just giving antibiotics and resuscitation fluids. So next coming up, we do have a very interesting pro-con session. And for that, I would like to invite Dr. Rajesh Mishra and Dr. Senthil Kumar. So Dr. Senthil Kumar is senior consultant and intensivist at Apollo Hospital, Chennai, having a talk by Dr. Rajesh Mishra, who needs no introduction. He is a practicing intensivist in Ahmedabad, and he was the general secretary of the last Criticare 2020, and he is also a president-elect for next year. So maybe we can just begin the session, pro-con discussion.
Welcome one and all to the pro-con debate on vasopressin's use in ICU. I am Dr. Senthil Kumar Rajagopal from Apollo Hospitals, Chennai, and I am going to defend that vasopressin has lost its relevance in ICU. A quick look at the physiology. Vasopressin, due to various stimulus, is secreted by the posterior pituitary, and it goes into the bloodstream and acts through a couple of different receptors. Through V1 receptor, it causes significant vasoconstriction, and through the V2 receptors, which are located in the collecting tubules, it causes water resorption. So because of these two main actions, they try to maintain the blood pressure, they maintain the blood volume and the blood viscosity. They also have some few other mechanisms. They help in coagulation cascade as well. They have action on factor 8 and 1 Willebrand factor, and they have action on platelet adhesions also. These are some of the physiological actions which are relevant to us in critical care. Because of these relevant actions, there were some interest by researchers and clinicians to use vasopressin in some critically ill conditions like cardiac arrest, septic shock, some bleeding conditions like variceal bleeding and some coagulation abnormalities, central diabetes insipidus. Yes, it was logical to think about using vasopressin in these conditions, but unfortunately, these uses are very much questionable, and some of these uses has been already removed from the clinical use. Let us see one by one why it came and why it vanished. Let us start with cardiac arrest. It all started with this 1997 Lancet journal when there was a small study published in 40 patients. There is 20 patients in each group, one group of vasopressin, one group of adrenaline. It was used in cardiac shock resistant ventricular fibrillation. Yes, this study shows some bright signals about vasopressin. The vasopressin group survival was 40% compared to 15% of the adrenaline group. But this was a very small study, just 20 patients in each group. Just one patient this side, that side would create a huge difference in the percentage. They themselves recommended this needs to be explored. There need to be subsequent RCTs. That's what they recommended, the authors themselves. Subsequently, sorry, same in Lancet in 2011, there was another study which was published this time with 200 patients, vasopressin with adrenaline in cardiac arrest, this time in hospital cardiac arrest. There was completely any failure. There was completely no advantage of vasopressin over adrenaline in this study. Okay. Subsequently, the European Resuscitation Council vasopressor during cardiopulmonary resuscitation study group published a data in NEJM in 2004. This is an RCT which had 1,200 patients. 2 doses of vasopressin or adrenaline were given. Subsequently, if there is a need, they gave only adrenaline. What they found out in the study was the effect of vasopressin was similar to those of epinephrine in both VF and PE arrest. But when they did a post-hoc analysis of a subgroup of patients with asystole, there was some improvement in survival to hospital discharge in a vasopressin group, but then unfortunately not with neurological intactness. So unfortunately, vasopressin was creating more persistent vegetative state in patients who had asystolic arrest, but in VF and PEA, they did not show any benefit. Anyway, based on these studies, some other studies in 2005, AHA-ACLS did a very indeterminate class recommendation that vasopressin may be used instead of first or second dose of adrenaline. But I don't think so many of the clinicians used vasopressin in this group. Anyway, a lot of interest came subsequently and many studies were published, one in NEJM in 2008, which failed to show any advantage of vasopressin over adrenaline. And subsequently, there was a study published in Resuscitation in 2009. It was one of the first possible study of purely vasopressin in one group and purely adrenaline in another group. Almost 340 patients, maximum 4 doses of vasopressin was given, and they had a comparable survival. There is no edge of vasopressin over adrenaline. And then subsequently, this meta-analysis came where 5 RCTs were included, 1,500 patients were studied, and they clearly shows no advantage of vasopressin over epinephrine in the treatment of any cardiac arrest, whether it is in hospital, outside hospital, shockable, non-shockable. There's absolutely no benefit at all. So subsequent to this, in 2015, AHA-ACLS removed vasopressin from the cardiac arrest algorithm. So in cardiac arrest algorithm or in cardiac arrest, vasopressin do not have a role at all. Coming to the next broad indication is a septic shock, which is in vasodilating shock. Here we need to know some physiology. In any shock, the vasopressin level goes up in the first 24 to 48 hours, and then slowly it comes down. But it never goes below the baseline level at all. But then, in any shock state, we expect the vasopressin to be reflexively high, but it does not happen after 24 to 48 hours. So this condition is called relative vasopressin deficiency. But the significance of this is unknown to us. Because of this relative vasopressin deficiency, once again researchers and clinicians had interest in using vasopressin in vasodilatory shock like septic shock. Let's see what happened in the evidence. This was a trial which was published in 2008 in NEJM. It's a double-blinded multi-center RCT where vasopressin was used or noradrenaline was used when there was a fluid unresponsive shock or already noradrenaline was going at 5 microgram per minute. If the patient had resistant shock to this, in spite of fluid resuscitation and some amount of NARAD going on, either noradrenaline or vasopressin was added subsequently. This was studied in almost 800 patients. What they found out was low-dose vasopressin commenced at 6 hours after the initiation of shock therapy does not decrease mortality at all. This is what was trial concluded. Subsequently, in 2016, in JAMA, Vanish trial came, where once again vasopressin and norepinephrine was compared in a factorial 2x2 double-blind multicenter or CT. Here there were 4 arms. One arm had pure vasopressin, the other arm had vasopressin with hydrocortisone. Another third arm had noradrenaline alone, and the fourth arm had noradrenaline with hydrocortisone. Almost 400 patients were studied. And among adults with septic shock, the early use of vasopressin compared with noradrenaline did not improve mortality nor the number of kidney failure free days or RRT free days. So there was no benefit of vasopressin over noradrenaline in this study as well. And subsequently, Surviving Sepsis campaign, when they were talking about vasoactive substances in septic shock, they did a meta-analysis of 9 studies, including the VANISH study. Almost 1,300 patients were there together. Either noradrenaline against vasopressin or noradrenaline with vasopressin studies were included. What they found out was these meta-analysis of 9 studies did not show any mortality difference between the 2 groups. What they found out was mostly the vasopressin had a noradrenaline sparing effect, but not mortality benefit. So in the Surviving Sepsis campaign subtly introduced vasopressin with a very weak suggestion. They told in a fluid resistant, noradrenaline resistant shock, either vasopressin or adrenaline can be used. Okay, so that's what they tried. It's a weak recommendation. But we need to know one thing here. When vasopressin is used in this sort of vasodilatory shock, you may see an increase in mean arterial pressure. But unfortunately, reflexly, what vasopressin does is it causes afterload increase, and ultimately they reduce the cardiac output or the cardiac index. We all know septic shock is a vasodilatory and a high cardiac output shock. A drug trying to reduce the cardiac output will reduce the perfusion, and ultimately it will worsen the shock. That's what has happened. And this study, which is published in Critical Care 2006, done by Martin, clearly shows that supplemental vasopressin infusion in advanced vasodilatory shock has shown decrease in cardiac index and systemic oxygen transport in 40% of the patients. It's almost close to 50%. So in a vasodilatory shock like septic shock, if you use vasopressin as a second line of drug instead of adrenaline, which has a good increase in cardiac output, unfortunately vasopressin will reduce the cardiac output, reduce the perfusion to the tissues. We may see increase in mean arterial pressure, but we will not get increase in perfusion. So pressure is not equal to perfusion in these set of states. So in septic shock, vasopressin levels are lower than anticipated after 24 to 48 hours, which is called relative deficiency, but significance is unknown. Adding vasopressin to noradrenaline does not improve mortality or RRT free days. Only noradrenaline sparing effect has been shown, but what is the benefit? We do not know. Increases cardiac afterload and reduces cardiac output and perfusion, as I told you earlier, which is really not acceptable. But unfortunately, we don't have evidence for that. But logically, scientifically, it is not right to use this drug. But what adrenaline can do is it is cheaper. It is 20 times cheaper than vasopressin, and it's a very good, better alternative. We all use that. Everybody is comfortable using adrenaline, and it increases cardiac output in these sort of states. But unfortunately, we don't have a data directly comparing vasopressin with adrenaline in these sort of patients. Vasopressin impact on mortality in refractory shock is unknown. In very severe refractory shock, there is no studies at all. So bottom line, vasopressin in septic shock cannot be used or need not be used. It doesn't have a clear-cut edge over adrenaline at all. So if there's a volume resistant, noradrenaline resistant shock, it is better to use adrenaline rather than vasopressin. There are other conditions in critical care like variceal bleed, where vasopressin has been tried earlier, but now we all know terlipressin is almost much better than terlipressin is as good as a ligation therapy. So terlipressin clearly ahead of vasopressin in these conditions. In coagulation abnormalities like von Willebrand's disease, hemophilia, or platelet dysfunction, desmopressin is more effective. Definitely, vasopressin is not as effective as vasopressin. In neurogenic DI, desmopressin nasal spray is more effective and vasopressin is not used. These are the various conditions in critical care where vasopressin has been tried, and all these conditions, either adrenaline or terlipressin or desmopressin, have shown much more benefit than vasopressin. So I don't think so there is a role for vasopressin with the present level of evidence in ICU to be used. So vasopressin in critical bleed and DA is once again out of question. Not only that, one side vasopressin does not have much advantage, but it has adverse effects like huge water retention. It can cause coronary spasm, angina, reducing cardiac output. It can cause skin and digital gangrenes, and it can cause non-occlusive mesenteric ischemias. I have seen so many patients of NOMI in my ICU using high-dose vasopressin. So no benefit one side, adverse effect another side, and vasopressin in critical care has very, very limited value. To conclude, vasopressin in critical care, no benefit in cardiac arrest removed from ACLS. In septic shock, does not improve mortality or RRT-free days. Don't know the impact in refractory shock states. May increase MAP, but decreases perfusion, which is the ultimate goal. In critical bleeding and DI, terlipressin and desmopressin are much more effective than vasopressin, so there is no use at all. We need to keep an eye on the adverse effects causing ACS, NOMI, digital gangrenes, and water retentions. So vasopressin in ICU as a bottom line is of no use. So I will not be recommending vasopressin with the present level of evidence to use in ICU. Maybe vasopressin can have a lighter role in increasing the attachment between the loved ones. So maybe Dr. Mishra can try to keep it in the self in his home. So it doesn't have a place in the ICU self, but maybe at home. Thank you very much.
Thank you, Dr. Senthil, for your excellent presentation and lightening a lot of my work. I will be focusing only on the area of vasopressin has lost its relevance in ICU today. I will be defending that it has not lost its relevance, rather than it has become more precise, and we need to understand and know how to use and when to use vasopressin. As we are started learning for other area of critical care, what to do. As Dr. Senthil has said, little bit about the vasoactive agent in shock. Why we do use in vasoactive agent in shock? Is a drug. These drugs come with potential lethal complication, require precise therapeutic target. That's where I will be focusing more. Close monitoring and titration with minimal efficacious it should be weaned properly. The use of vasoactive drug in shock requires individualized approach. So if you are starting using without approaching and without understanding it properly, probably will not get the effect. Vasopressin may be useful owing to this non-epinephrine sparing effect. One of the approach which we have started started practicing is D-catecholamine approach, where we try to reduce or stop catecholamine as soon as possible, recognizing its side effect and complication. The adverse effect of catecholamine depends in shock, a strong and independent predictor of mortality. It is associated with tachyarrhythmias, thermogenic, metabolic, and excessive vasoconstriction, and the tissue ischemia. So tissue and distal ischemia is not only with vasopressin only. It is very well known with noradrenaline use or adrenaline high dose use. And this has led to an interest that if we can reduce the dose of catecholamine and use other drug to substantiate the effect of catecholamine and reduce this dose, so both of them can complement each other and reduce the side effect. So catecholamine adverse effects and its complication has led us to find out any other drug which can help and reduce the catecholamine use. Dr. Senthil has already told that the physiological effect of AVP is to cause vascular smooth muscle constriction apart from other. In ICU setup, we are more concerned with the use of vasopressin for smooth muscle contraction effect that increases the blood pressure. And second is its effects as an antidiuretic hormone, so it retains the water. But that also needs some other factor. It doesn't work independently. Apart from that, this drug also improves the cortisol level. So if there is a relative cortisol deficiency, then this drug will not give the effect which is desired. So these are three factors which we should always remember when we are using vasopressin in ICU. We have to also understand that how it works at endothelial level and what happens in SOC. We know that ultimately at endothelial level in SOC, there is an increased nitric oxide level which causes relaxation. What vasopressin does is that it closes the potassium channel, and along with that, so output of potassium, along with that, it increases the affinity number, not only for vasopressin, but other vasopressin like noradrenaline. And that potentiates the effect of noradrenaline and cortisol and improves the contraction. So in a cases of SOC, where this problem is there, vasopressin is supposed to give us a better result when combined with noradrenaline hydrocortisone. As Dr. Senthil has very well elaborated that there in initiation of SOC, there is an initial surge in vasopressin level, and then it falls down well below the basic level. And there is a relative deficiency. Why this relative deficiency happens, you have to understand three mechanisms. There's a depletion of store, which happens due to hypotension, acidosis, and hypoxia. There's a decreased stimulation of vasopressin release due to the impaired autonomic failure and inhibition of stretch reflex. That means there is autonomic failure. And there is an inhibition of vasopressin release due to nitric oxide release in sepsis and high circulating norepinephrine. So if you are using very high dose of norepinephrine and not combining vasopressin, the level will further go down, and this will you will have either to use very high dose of norepinephrine with a side effect, or you need to find something which can offset the effect of norepinephrine and can help as a combined effect. So relative deficiency can be replaced. That was the thought process for all the trial, but not in excessive, that is 0.01 to 0.04 unit per minute, which increases blood pressure and decreases norepinephrine requirement, which Dr. Senthil has already said. What we have to understand when we use norepinephrine in physiological dose, it increases the mean arterial pressure. But other parameters like SBRI or PVRI, cardiac index, heart rate, or wedge pressure or CEP is not affected significantly. It remains almost same the way it is started. So this is one thing which is very important. You have to understand that low dose vasopressin infusion increases mean arterial pressure. Systemic vascularization and immune output in patients with vasculitis shock and hyporesponsive to catecholamine. The data indicate that low dose vasopressin infusion may be useful in treating hypotension in those patients. So this is something which we have to remember. So when we compare benefit versus harm, the vasoconstrictor action of exogenous low dose vasopressin in endotoxic shock does not impair the blood flow to any vascular bed. So even little bit of the SBR increases, but it doesn't affect the vascular blood supply. However, if we increase the dose of vasopressin, it may induce ischemia in mesenteric and renal circulation. The data indicate that safe dose range of exogenous vasopressin in septic shock is narrow and support the current practice of generally 0.04 unit per minute, and in no case. So what we are recommending that you have to monitor it properly, and you have not to exceed the dose above 0.04 unit per minute at any cost. In this safe dose, it's going to give us benefit, and its harmful effect can be offset. If I have to compare what Dr. Senthil has quoted, the vast trial in NAGM, In contrast to Arthur's initial hypothesis that more patients will benefit from vasopressin treatment, outcome did not differ in a group of patients where norepinephrine dose was high. But in patients who in sub-hoc analysis and subgroup analysis, where the norepinephrine dose was less than 15 microgram per minute, vasopressin administration has associated with significant improved survival at 28 days and 90 days, which is very important one. That means if your noradrenaline requirement is increasing and you know that it is a lactate level is okay, you start vasopressin early rather than it is too late and vasopressin has already started causing more damage. Another thing in VAST trial you have to understand for post-hoc analysis that there is association between vasopressin and hydrocortisone. So vasopressin and associated use of vasopressin and hydrocortisone. Vasopressin reduced the mortality in patients who had discretion of attending physician were treated with hydrocortisone. In patients who did not receive hydrocortisone, vasopressin administration was associated with high mortality. So that's what I explained initially. That's not only the vasopressin, you have to also keep in mind that you have to use physiological dose of hydrocortisone also. Vanish and VAST trial were negative in the sense of no superiority of vasopressin could be demonstrated. I do agree with this. These studies show that vasopressin is non-inferior to norepinephrine either. Its administration was not associated with higher rate of adverse effect, especially ischemic event, as it happens with noradrenaline alone. These studies demonstrated that vasopressin allows at least a reduction of norepinephrine infusion rate and fasten the weaning from norepinephrine, which we think that is an important concept to practice for decatecholamine. In a retrospective study, patients with septic shock who received fixed dose of vasopressin in association with norepinephrine had an improved outcome prognosis when vasopressin infusion resulted in increase in mean arterial pressure. So if your mean arterial pressure was low and if vasopressin infusion has improved it has improved the prognosis also. There's a retrospective study. Apart from that, we have to also understand very precisely that in a patient who are at risk of kidney injury, the VAST trial showed that all these patients had a lower rate of progression to renal failure or loss or lower rate of renal replacement therapy. But here, only at risk level, not once injury started, failure started, or loss started. So it's a very, very precise thing, precise information. So vasopressin could be considered early in patient with sepsis, with low blood pressure, without hyperlactatemia alone, or in association with norepinephrine. I will prefer it should be used with norepinephrine to substantiate and help or perpetuate the effect of norepinephrine rather than using it alone. In association with norepinephrine, to decrease norepinephrine infusion rate in order to limit its undesirable side effect according to the concept of decatecholamine. Vasopressin therapy was associated with reduced risk of cardiac arrhythmia, which is very important. One who has to understand other inotrope or vasopressor has same. It tends towards the reduced requirement of renal replacement therapy, and as the effect on mortality estimate is wide, if I start seeing lots of trial in critical care, particularly which has come in last 10 years, hardly any trial which affect the mortality. All those trials have been seen in other secondary outcome or benefit, or if they can reduce the cost, they can reduce the inotrope, they can reduce the vasopressor requirement. So any of these things which help us, even they are considered beneficial, because outcome mortality, there are very, very few trials in ICU. The requirement for RRT reduction was significant irrespective of the things. One more thing, the often dramatic blood pressure response to vasopressin and observation that duration of hypotension is strongly associated with increased risk of death in patients with septic shock is likely to provide a rationale to continuous use of vasopressin in septic shock until more definitive information is available. Overall, based on the current observation, one more information I want to tell you, at 90%, 5%, the worst case scenario is that vasopressin therapy kills 1 in every 22 patients with septic shock who receive it And the best scenario is that it saves life of 1 in every 19 patients who receives it. Though this patient, this trial showed that 28-day mortality did not improve, but what is more important is vasopressin in septic shock. What we know next is that you need a sample size of around 44,000 patients to require a detected mortality benefit of 1.5% with 95% power. This can provide a substantial power to detect differential because all the beneficial effect of vasopressin has been found in subgroup analysis, not individually. It's a substantial formidable sample size. And we know that best conducted RCT in critical care, 3,800 patients needed 4 years. So what we can do, what can be done is septic shock as a global emergency health problem. We can have a randomized registry embedded trial, and where we can find precise use and we can try to target them. Vasopressin, one more area where it has helped in to prevent cardiac arrest in hemorrhagic shock, because we know that hemorrhagic shock has poor prognosis, and particularly in pre-hospital scenario, it has got worst outcome. It has shown to improve perfusion to brain and avoid hypoxemic injury. So future trial should focus on long-term outcome in select patient group, as well as incorporating the cost effectiveness, which has not been seen, analysis regarding possible reduced RRTUs. What I will say that thanks for using vasopressin and being precise. This is the only way that decatecholaminization and being precise is way forward for vasopressin. Vasopressin has not lost its relevance, that we have to learn to be precise and realize the vasopressin therapy. Vasopressin is seen in future as an agent to be used as decatecholaminization or catecholamine sparing drug. Thanks for your patient sharing, and it's over to Dr. Senthil for further rebuttal.
Okay, Dr. Rajesh, you are really focusing on only septic shock, the use of vasopressin in only one critical condition called vasodilatory shock due to sepsis. In that also, most of the studies you have shown is either maybe, the recommendations are maybe, or it can be a post hoc analysis. And we know that these post hoc analyses are usually done with a desperate measure to prove something. Yes, they started with an hypothesis, they want to stand on it and do a post hoc analysis, and following a post hoc analysis is a desperate measure. I don't think so. They have a real value in practice. Okay. Two is, most of the recommendations were made, was not strong recommendations at all. Even the author himself in VAST trial or Vanish trial, they clearly shows, they themselves have concluded that vasopressin has not shown a clear-cut advantage over the other drugs. So they concluded themselves that vasopressin is not beneficial. When we have an alternate like adrenaline, like in cardiac arrest, vasopressin was always equivalent to adrenaline. But AHACLS clearly removed that, because when you have a known drug for so many years, which is easily available, cheaper, and has shown the equivalent potency, they removed vasopressin and they continued with only adrenaline. It is not that vasopressin was much inferior, but it was equivalent study in most of the researchers. Same way here, vasopressin have never shown a clear-cut edge. It maybe it required a bigger study, post hoc analysis. So with this, recommending vasopressin when adrenaline is available, I don't think so it can be purchased or can be followed. You start noradrenaline. If the patient have a resistant shock, we can go out and start an adrenaline, which there is no head-on comparison with vasopressin and adrenaline. And in NHS, they have started using terlipressin rather than vasopressin. Okay, so vasopressin has been out of NHS. Okay, so to my defense, I will say, when you have a cheaper, better, and readily using a drug like adrenaline, when nurses and junior doctors are commonly using it, I think we should use a drug. The other point is, you yourself tell the therapeutic margin is very narrow. Every time you go and see our nurses and junior doctors, when the map falls, they go and increase either one of the drug. And many times accidentally, I have seen vasopressin has been increased to 2.4, 3 like that. So that is very much unacceptable. Whereas if it happens in adrenaline or noradrenaline, that's okay. They have a wider therapeutic safety, whereas here the therapeutic margin is very narrow. So when we don't have a clear-cut benefit, when it is costly, and in septic shock, one thing which is not studied, I told you, the perfusion is definitely affected, and then this narrow therapeutic margin. I think at this point of time, future may bring some evidence, but at this point of time, with the present evidence, I think adrenaline as a second drug is much more better than using vasopressin.
Okay, thank you, Dr. Senthil, for your. I do agree because for your thought on cardiac arrest, because we know that once it has been removed from AHA guideline, I did not want to argue on that. But cardiac arrest also, we started making it, as I said, that everything we try to generalize in critical care. And that's one of the biggest problem in critical care, that we are practicing critical care, but we have not practiced the precise medicine, which is very, very, all of us are learning the art of to be precise for and individualized to the case. So cardiac arrest, it was proposed only for pulseless or flat line scenario rather than for VTVF, which was inculcated and then evidence came and that was removed properly. So probably it would have been only compared in flat line situation or pulseless electric activity where it was initially quoted. Probably it would have made a difference, but I'm not defending that thing. I'm just saying that was a precise thing would have happened. So it is removed, that's fine. Your thought on the septic shock, as you say, or even in cardiogenic shock, as I said, that's one of the very important things which we are not discussing. And because of the neither noradrenaline, neither adrenaline is safe. Both has a side effect. Adrenaline is even worse. Adrenaline per se, you know that it causes a lot of metabolic disturbance, increases lactate level. It worsens. It causes more arrhythmia. Looking to the side effect, people have tried to balance the. When we discuss cost, then also discuss the life save and reduction of noradrenaline dose also. So when we start monitoring, as I said, that we have to be very, very precise in using noradrenaline. Yeah, it was a vasopressin, sorry. And that precision is that you do not use when norad dose is above 15. Then you add, it is useless, I'm saying. You do not use when lactate level is very high, then it is useless. You use it when initial resuscitative measure of fluid, noradrenaline initiation fails, and you substantiate, because one of the very important things, when there is autonomic dysfunction, there is a problem, vasopressin will substantiate or add on the effect of noradrenaline and your reduction in it. So we also want to look, we are looking, when you are at the age of, at the level of 10 or 15 ml noradrenaline, at that time, if you use vasopressin, it is useless. I fully agree with you. But when you use early, it will cut down effect and you will get better perfusion effect. As far as perfusion is concerned, there are very substantial data. It's not vasopressin. It is the add-on effect of noradrenaline, other vasopressor, which compromises the perfusion. But as I told you that if you are using vasopressin and noradrenaline alone and not giving the physiological dose of hydrocortisone, probably you will not be able to cut down. In fact, of recent, the one thing which has been very much discussed, because if you start seeing, even we do not have a trial which has shown noradrenaline improve outcome or mortality benefit. All the hemodynamic monitoring drugs and monitoring instrument has been used to buy the time to treat the therapeutic cause. If you can treat the cause, if you can fix the problem, patient outcome improve. If you are not able to fix the problem, none of the supporting measure, maybe it is IOBP, maybe it is Songan, maybe it is any of the cardiac support devices, will not show you the outcome benefit until unless main cause has been fixed. Same way we have. But does vasopressin does the job for which has been said? So I will say it does job. As you have said, I rightly focus on septic shock or sepsis, because apart from that, even in cardiogenic shock, where noradrenaline requirement increases, where the risk of arrhythmia, add of vasopressin has the same evidence which I told you. Hemorrhagic shock, it has been used exclusively in preclinical scenario, in pre-hospital scenario. People have started using, and now it has started showing little benefit. Major data will come. I do agree for you about the one more thing about alternate. As I said, that vasopressin is not a vasopressin analog. Maybe it is terlop, because this debate was only on vasopressin. terlipressin is a better version of vasopressin, or even one more drug. So definitely it is being used, but the whole thought is to go away from any catecholamine, focus on non-catecholamine, and if we can do better job, and if we can improve perfusion without causing the distal ischemia or perfusion effect, then we can get better effect. So I do not disagree what you said about cardiac arrest. I do not disagree what you said about the other use, but as far as septic shock is concerned, for being precise in a special group of patients, if you use, you can cut down the dose, and you can prevent the further worsening, you can cut down the adverse effect and build this substantial outcome. I'm not looking to that, because to get that data, you use huge number for analysis, and which is not available for any other trial. And most of the trials which are available right now, they do not look at mortality benefit rather than other effect also. Thank you.
Thank you, Dr. Rajesh.
So I think we can stop now here.
One point I want to conclude. Only point we are debating is septic shock and surviving sepsis campaign. If we are believers of surviving sepsis campaign, which has unified our way of managing septic patients, clearly says it's a weak recommendation, and you can use either vasopressin or adrenaline. When adrenaline is left-right available, our nurses and junior doctors are comfortable, why another drug in the self? So till another strong evidence come, the relevance of vasopressin right now is very, very weak in the ICU. That's only one indication, and that too very, very weak. It is very, very weak. If you are a purist, if you go only based on evidence, that's where we stand now. I'm not completely against vasopressin. I'm also welcoming vasopressin. If it comes with the good evidence, in the future we can use it. Thanks, Dr. Rajesh Mishra, for an enlightening discussion. Appreciate your efforts.
Thank you. Thank you, Dr. Sir.
Thank you, Dr. Mishra and Dr. Senthil. It was a very interesting discussion, and I know there are no easy answers for it. And sometimes you do have to make some compromises, but definitely vasopressin still has got its role in difficult clinical scenarios. Dr. Mishra, you would like to comment anything?
No. I think already we have given a reply, and as I said that my choice for vasopressin is staged there. The only thing which I have changed is that we should not try to go on noradrenaline on very high dose. Use it early. When you are stepping up at norad, add vasopressin, add corticosteroid together. Do not allow hyperlactatemia to happen. And if these things are there, probably we are going to get a better effect with vasopressin rather than using vasopressin very late when you have tried very high dose of noradrenaline. You have to give adrenaline sometime. You have induced high lactate level, and then you use vasopressin. It will be futile. But if you use norad and at optimum dose, you add to that. First, most important thing that when you give vasopressin, it will optimize that it will enhance the effect of noradrenaline, and you will be able to cut down the effect of noradrenaline and its side effect, because neither noradrenaline or vasopressin comes without side effect. All these vasopressin come with the side effect, and the side effect are distal ischemia and regional perfusion defect and affected perfusion to vital organs. So probably that's where I stand.
Devin. I agree with you, Dr. Mishra. Like any other drug which we use in critical illness, every drug has got its effects and side effects. So we have to use it judiciously for best patient management.
Yeah.
Thank you, Dr. Mishra. For the next session, I would like to invite Dr. Vivek Nagia as the chairperson. Dr. Vivek Nagia is a Senior Director, Pulmonology, Critical Care and Sleep Medicine at Max Super Specialty Hospital, Saket, New Delhi. Welcome, sir.
Thank you, Devin. Thank you. So,
Mr. Neeraj, can you please put the slide for the speaker?
Right. So our next speaker is Professor Anil Hormez, and who will be talking about the inhaled sedation. Is it an important tool in the armamentarium of the intensivist? Dr. Anil is a consultant anesthesia and critical care medicine at the Rotterdam NHS Foundation Trust, Moorgate, United Kingdom. He's an honorary professor at Sheffield's Hallam University and is heavily involved in medical education at a regional and national level. May I hand it over to him now? Dr. Anil, please.
Thank you for the invitation to come and talk at the Indian Society of Critical Care Medicine. The topic I am going to talk about today is using inhaled sedation in the critical care unit and how it's an important tool for the intensivist to be able to use. I have a few disclosures to let you know about before we start the talk. The areas that I thought we would discuss in the next few slides would be about the advantages and challenges with using inhaled anesthesia, the patient groups that we could use inhaled anesthetics for, and then finally how we will deliver the inhaled anesthesia on the critical care unit. I work at the Rotherham NHS Foundation Trust, which is a district general hospital just outside of Sheffield. We are a medium-sized intensive care unit. We have 14 beds under normal circumstances. We have a combination of level 2 and level 3 critical care beds, and we have around 700 admissions per year. We've been using inhaled sedation on our unit since 2019 and have amassed quite a lot of experience with it. For starters, most of us will have our first taste of inhaled anesthesia in the operating theatre, and this over the last few years has been translated to the critical care unit. But using inhaled sedation is not a new thing. This is a paper from the British Medical Journal in 1989, and it showed that isoflurane was being used in trials even at this stage. The isoflurane was compared against midazolam in this particular study, and it showed that patients recovered quite quickly after the sedation was stopped with isoflurane, very much compared to midazolam. If we look at guidelines from around the world, we can see the American guidelines for the management of pain, agitation, and delirium from 2010, and they don't mention volatile anesthesia at all. Whereas on the right, there's a copy of the German evidence base and consensus statements, which were updated in 2015. But if we go back to their version of 2010, it shows that inhaled sedation is an accepted and certainly advised method of sedating patients on the critical care unit. And if we look at the flowchart on the right, we can see that usually propofol is used as the first line sedation, but the volatile agent can be introduced very quickly afterwards. The guidelines in my particular trust have us using intravenous sedation usually as the first line. So we start with propofol or fentanyl, we then add clonidine, we then would increase and add midazolam. If patients are still requiring more sedation, we then switch them to morphine and midazolam. And finally, there is a paralyzing agent which can be used either atracurium or rocuronium. However, what we do know is that all these sedation medications have some side effects. If we look at propofol, we can get propofol infusion syndrome, we can get problems with triglycerides going up. Clonidine gives us bradycardias and hypotension. And then we have the problems with midazolam and continued use of morphine, which consists of accumulation, active metabolites, and opioid withdrawal, and finally delirium, all contributing to a prolonged stay on intensive care. The question is how does isoflurane meet the requirements of a critical care sedation, and how would we fit this into our current guidelines? There are several advantages to volatile anesthetics. Often we can just use a single agent. So in our unit, we use isoflurane. We often find that we can discontinue all the other sedatives at the same time. We get a very good titratable clinical effect. So we can get patients very, very deep on the isoflurane, and we can also have spontaneous breathing and relatively awake with lower values of isoflurane. One important concept for us in critical care is the metabolism of isoflurane is irrespective of renal and hepatic function. So those patients who have got severe renal failure and liver failure, it's a very good drug to have them sedated on. One thing that we're all familiar with from anesthesia is the rapid onset and rapid offset of isoflurane. And again, I'll be showing you some further evidence of this from some papers later on in this talk. And the big thing, I think, for all of us is that we're very familiar with using volatile anesthesia because we tend to use it a lot in our anesthetic practice. So certainly those of us intensivists who are also practicing anesthesia, this is a familiar drug for us, and certainly the values that we're looking at are very familiar to us. But however, there are some challenges when we look to introduce volatile anesthesia into an intensive care unit, and I've listed several of them on this slide. There is some new monitoring that's needed, and we'll touch on that a bit later on. There is a big cultural acceptance because, again, for years and years and years, we've been using intravenous sedation. So colleagues and nursing staff in particular have to learn a new way of sedating patients. There is issues with scavenging the volatile anesthetic, which need to be overcome. And then the final two are important as well, to do with training. And often very important part of our process is transferring patients around the hospital, mainly for scanning. And that does provide some challenges when we've got patients sedated with a volatile anesthetic. So the next few slides, I thought we'd talk about which patients should we start using volatile anesthesia for. And certainly if you were thinking of introducing this into your unit, which would be the patients to start on. The first group I always talk about is to start with something very common and something that is usually affecting younger, fitter patients who often just need short amounts of sedation, usually overnight sedation as a result of an overdose or some other quick thing. These patients are ideal to get experience using isoflurane or volatile anesthesia because they just need quick sedation. You can switch everything off in the morning, and these patients usually wake up quite fast. So this is a good group of patients to start using volatile anesthesia for. The other main group of patients is often with specific respiratory conditions. And this is where inhaled sedation really, I think, has probably traditionally been used. We have between 5 to 10 acute bronchospastic patients attending our unit every year, and they come in very severely bronchospastic, and they often are put straight onto inhaled anesthesia as a mode of treatment. The problem with these patients is they can come in with life-threatening severe asthma or COPD, and they can rapidly escalate to multiple sedative agents. They're often paralyzed, have ketamine infusions, aminophylline, and intravenous salbutamol. But in our unit now, we put them straight onto inhaled sedation, and we can see with data from this paper, and this certainly reflects our practice and experience, that within 30 minutes of starting sedation with a volatile agent, their compliance increases, their intrinsic PEEP gets a lot better, and we can wean down their oxygen requirements very, very fast. And quite often, we can ventilate these patients for a much shorter time than we have done previously with intravenous sedation. Other patient groups are the ones who are on high-dose propofol or multiple sedative agents. These are a tricky group to sedate sometimes. Again, if you look through our guidelines, patients can rapidly escalate and increase their numbers of sedation medications given. We had a patient very recently who was a 57-year-old man with acute pancreatitis. He was on 40 mils an hour of propofol. He was on 0.8 mics per kilo of alfentanil, plus some clonidine. And he'd recently, in the last 48 hours, been started on some midazolam. I was told when I came onto the unit that he was still not synchronizing with his ventilator, and the next plan was to sedate him and paralyze him, with atracurium infusion. However, when I put the BIS on, I noticed that this trace, as you can see in front of you now, he had an isoelectric EEG and a suppression ratio of 98, which means that he was very, very oversedated with all these medications. He was switched on to isoflurane inhaled sedation that morning, and by the time I left the unit in the evening, his BIS was climbing. It was in the mid-20s, and he was on just monotherapy with isoflurane by the end of the day. So it's a good way of rationalizing the infusions that he had. Again, I've talked about hypertriglycerides. You can see in this particular snapshot here of a patient who'd been intravenously sedated with high dose propofol for a number of hours and had a triglyceride levels over 6. He was converted straight onto isoflurane when we noticed this, and within 24 hours his triglycerides were on their way down and continued to get better over the next few days. A big group of patients that we see regularly is the out-of-hospital cardiac arrests, and again, although there's varying degrees of how bad these patients are, we often want to wake them up quite quickly to assess neurology, and isoflurane allows us to do this quite quickly. It's also, once reaches steady state, is a very cardiovascularly stable anesthetic, and so patients often don't need very much vasopressor support once they're on isoflurane. The evidence base for this is actually quite good. The studies that I'm going to show you have relatively small numbers because obviously isoflurane sedation isn't particularly well used around the world. But this particular study was a retrospective study which was published 2 years ago. Their endpoints was looking at duration of ventilation, ICU length of stay, and the overall hospital length of stay in the survivors. And these were patients who had had an out-of-hospital cardiac arrest. The secondary endpoints were interesting as well because they looked at the quality of sedation, the use of opioids, and the instance of delirium once the patients had been extubated. They randomized 2 groups of patients. They had one group who, between 2015 and 2016, were sedated with intravenous agents, and that was up to the treating physician. So either propofol, midazolam, fentanyl, or rocuronium. Plus rocuronium, sorry, and they had targeted temperature management, and they were sedated to a RASS between -4 and -5. The second group, which happened at a later date between 2016 and 2017, were all sedated with inhaled sedation, in this case sevoflurane. They're also given an intravenous fentanyl infusion, and at this time point, the targeted temperature therapy had changed to slightly higher levels. Again, they were still randomized to RASS scores of -4 and -5. If we look at the results, and I've highlighted the modified temperature management group as well in particular, their duration of ventilation was less compared to the previous group. Their ICU length of stay was less. Their cumulative fentanyl dosing was a lot less. The quality of their sedation in using, and the amount of time they were able to achieve a RASS score of -4, -5 was improved, and their delirium diagnosis was a lot less in that in the sevoflurane group compared to patients who'd been on midazolam and fentanyl. We often have a big group of patients who require very deep sedation, and often for a prolonged time. What we try to avoid in these patients is having to use muscle relaxants because we know that this can increase their chances of having critical illness neuropathies. So we need to find the ideal agent to be able to sedate patients for long periods of time. This obviously is very relevant currently with the COVID-19 pandemic, and we found some increasing evidence that using volatile anesthesia may have some beneficial effects within COVID-19 and ARDS, as we've previously seen. What have we learned about sedation in the last sort of 20 years? Well, we know that continued prolonged and deep sedation has poorer outcome for patients, and our aim is always to reduce sedation as quickly as we can and limit the amount of sedative agents that patients are on. This is the Crest paper from 2000, which was the first time we learnt about sedation holds and daily sedation breaks. And again, this has all contributed to allowing our patients to have less sedation and the less number of agents used to sedate them. But one thing that I don't think we appreciate so much is the pharmacokinetics of drugs in the context of critical illness. And this is a paper from a Hong Kong group which looked at this in particular. It was a meta-analysis that looked at 33 randomized controlled trials. It had over 1,800 patients in. What they found was mainly in septic shock, that a combination of fluid resuscitation causing altered protein binding and unstable hemodynamics, this all led to organ dysfunction. And the changes in critical illness to do with protein binding, uremia, and competing drugs and acidosis all contributed to how the free agents of the sedative agents of the intravenous anesthetics worked. And what they found is that, as I've listed the results here, that the midazolam, propofol, lorazepam groups were associated with a 2-fold increase in their volume of distribution. And the clearance of the midazolam was decreased 2-fold and was up to 10-fold in the morphine group. And that if patients were on infusions of morphine, midazolam, and propofol, and also remifentanil, they had a twice as long elimination effect. So this is important because these are the type of patients that we see on a daily basis in critical care. And we do know that drugs get affected in this way. And I feel very strongly that volatile anesthesia may well be an option for these patients, just because it doesn't make any difference to do with drug binding for this drug to work. There's been lots of studies that have been done over the years. This is the Saki paper from 2004. And this looked at patients who were sedated with isoflurane, and that was versus midazolam. These were patients who were sedated for over 4 days, and he looked at their time to extubation. And you can see in the chart on the left that he found that isoflurane was safe and was a good method of extubating patients quickly. And you can see that the time to extubate a patient after 4 or 5 days on isoflurane was around 10 minutes versus 110 minutes in the midazolam group. Another study by Mesnil and colleagues in France showed that patients who'd been sedated for over 2 days, again with pneumonia, had much quicker wake-up times and extubation times. And I've listed those at the top of the graph. You can see that patients are receiving sevoflurane and remifentanil extubated within 33 minutes. Patients who are getting propofol and remifentanil extubated around about 326 minutes, and patients who are on midazolam and remifentanil were extubated at 600 minutes. So you can see a big difference in time to wake up and certainly time to extubate with the volatile anesthetic group. When we talk about outcome studies, that's important, and there's only been one that we can find in the literature. This was by Belgart and colleagues. They did a retrospective analysis between 2005 and 2010. They looked at patients who'd been sedated with isoflurane versus propofol and midazolam on their critical care units. And what they found was that significantly lower in-hospital and 365-day mortalities in the group who'd been sedated with isoflurane. And this difference was around 20%. So although this was a retrospective study, this is the first kind of glimmer of hope, I suppose, that patients who undergo volatile anesthetic sedation in the critical care unit can lower their overall mortality in hospital. We have used volatile sedation for COVID-19 patients on our unit. There is emerging evidence that the volatile anesthetics may provide some anti-inflammatory effects and some very useful effects to do with cytokines in the context of ARDS. I've put three papers up here if people are interested in having a look at this. And I think the evidence is all hopefully going to be coming out in the next couple of years about the use of using volatile anesthesia in the context of ARDS and COVID-19. So the question is how do we deliver volatile anesthesia in the ICU currently? We don't have access, or we don't have the ability to bring in anesthetic machines into our unit. The main reason for that is scavenging the volatile anesthetic. So we have started to use the Anaconda device, which is the anesthesia conserving device. The way that Anaconda works is there's a filter, which is how the volatile agent is delivered. We then connect that up to a module to look at and to measure the gas. And finally, we have the absorber, which scavenges the isoflurane attached to the ventilator. What do we need to start using volatile anesthesia? Well, we have the Anaconda starter kit, and we also need some gas monitoring, which we can monitor the levels of isoflurane or sevoflurane during the sedation. The starter kit has everything that's needed to get a patient onto the isoflurane. It has the filter, it has the absorber, it has the syringes, and has the circuit. This is a picture of a typical intensive care cubicle in our unit. You can see the monitoring on the right there and the ventilator at the back. The gas monitor I've highlighted in the box is attached to the unit, and it's added to our existing monitoring system. It's not routine for all of our ICU monitors before we started to use volatile anesthesia that would have this capability. And we are able to measure end-tidal carbon dioxide and anesthesia gas through it. We actually have multi-gas analyzers, so we can use isoflurane or sevoflurane, but in our unit, we're using isoflurane mainly, and that's due to cost implications. The monitoring, when it's up and running, allows us to have the inspired and expired isoflurane levels, and also, importantly, the MAC level, which we use initially to guide nursing staff into getting the right sedation. Over time, we now have reverted to using the RASS score as we would do with intravenous sedation. So although we start with aiming for a MAC of 0.5 to 0.7, we allow the nursing staff to up and down the volatile agent to get the adequate and desired sedation effect for the patients. One thing that we found very, very useful in our COVID pandemic was building mobile systems. And these were monitors, often that were just old monitors that we had that we could fit a gas analyzer on. And this was very useful because it allowed us to move the systems around to different bed spaces. As you saw in the previous picture, they're all fixed into the unit. So in the ICU, many of the bed spaces have the gas modules fixed in. But then we designed a number of these systems that we could wheel around to move to any bed space, which we found very useful during the COVID pandemic. This is how the Anaconda system works in real life. You can see the filter there and attached. A closer look shows that the filter is the black thing there. It's pointing downwards. It's connected to the tube. And behind it, there's a Draeger ventilator, which is ventilating the patient. The volatile anesthetic agent is delivered through a syringe and a syringe driver. And the anesthetic comes in this way. It then enters the Anaconda filter just here. This particular connection houses the gas back to the gas monitor, so it measures end-tidal carbon dioxide and the gas going back to the unit. So you can see from this diagram that it's a very small device. It's not very heavy. It doesn't really affect issues with space or not particularly heavy either. So it's a very, very compact way of delivering volatile anesthesia, and certainly much better than having to have an anesthetic machine in the ICU behind the patient, which would be and take up a lot more space. Patients can be given boluses of volatile agent through the syringe driver if they become particularly light or before any procedures like turning. And again, we've got very good experience with using this with patients who've been proned. Again, we just take the same precautions when we're disconnecting and connecting the tubes, but it keeps the patients very deep, and there is no problems with that. Patients can also be spontaneously breathing in pressure support modes with the Anaconda. There poses no problems with that. And also nebulizers can be added into the circuit. And we've also done a number of bronchoscopies with the Anaconda in situ as well. So all the normal procedures that you would undertake during the ICU can all be done with the Anaconda filter in situ. Other bonuses about the Anaconda is that it works as a HME filter and an antiviral filter. So as you can see in this diagram, we don't have any additional filters in the circuit. This is a diagram just to show the fluorosorb, which is how the volatile anesthetic is scavenged. So it comes out from the flow sensor of the ventilator straight into the fluorosorb. This fluorosorb needs to be changed every 24 hours, and we can work out how much gas is in there by weighing it. But we have a policy where we change the Anaconda filter and the fluorosorb every 24 hours once it's been started. So in summary, we found very, very big advantages in using volatile anesthesia for the last couple of years on our unit. There have been some challenges, and I'm more than happy to talk about that in the question and answer session afterwards. I hope I've given you a nice idea of some patient groups to start using inhaled sedation for, and a bit of an overview of the equipment needed to start this, and mainly the Anaconda system, which we have been using on our unit. And I'm more than happy to take some questions after the talk.
I don't think there are any further questions. Thank you, Dr. Anil. It was a very educative talk. And now this device is available in India also, although I do not have any personal experience of using this device, but I do think that it can find some applications in management of critically ill patients.
Good, thank you.
Any comments, Dr. Namia? Dr. Anil, would you like to add anything?
No, I hope that was a useful.
Sorry, there was a technical glitch, so I couldn't join in earlier. Yeah, Devin. So, I wanted to ask Anil that, of course, it's a very novel concept, bring literally the OT gases into the ICU. But usually these OT gases are quite often associated with post-operative nausea, vomiting, agitation. What has your experience been regarding this?
That's a really good question, Dr. Nangi, thank you. So we don't really have problems with that. I think what we're able to do with running the isoflurane is then to decrease the amount of other agents. And I think the big problem is opiates. So we do run them on a background of either alfentanil or morphine, but we're able to decrease the amount of agents that we use. So we don't find that they wake up with increased nausea, vomiting at all. And I suspect a lot of that's to do with the opiates.
Right. And what about the nephrotoxicity? Usually these fluorine gases are associated with quite a bit of nephrotoxicity. Yeah, so does that require the dose adjustment or something when you're using it? So if the patient already has an acute kidney injury.
Yeah. So in our unit, we only use isoflurane, and mainly that was because I didn't want to put the patients at risk from the sevoflurane. So the fluoride ions is mainly a problem with sevo. So we just stick to using isoflurane. I think our colleagues in Europe use sevoflurane a lot, and they don't have a big problem with the fluoride ions either. I think the way that the gas flows through the Anaconda is quite quick, so the fluoride gets washed out. So for our unit, sticking to isoflurane means we don't have any problems with that.
And what about environmental contamination? Considering that the circuit is interrupted quite often in so many of these ICU patients where they have to be nebulized sometimes, suctioned sometimes. Yeah. So would that also have some impact?
Yeah, so environmental concern is very important. I think that the overall kind of, carbon cost is probably very similar to what it is with intravenous anesthetics, in all honesty. We try not to break the circuit too many times. The big reason is patients don't often need to be nebulized because the volatile agent is such a good bronchodilator in patients with acute asthma and other respiratory problems. It acts quite nicely as the bronchodilator there. But the fluorosorb, which you saw in the picture, that just gets destroyed and I don't think contributes too much to the environmental costs.
Right. Thank you. Any other questions, Devin, or anybody from the audience? We'll be happy to take
So
before
there are
we
no
go on to the
further
next
questions. I'm just looking at the chat box.
Okay, great. So we move on to our next talk for the day then. Next talk is by Dr. Pradeep Bhattacharya on infection in the geriatric population. Dr. Bhattacharya is the head of the critical care medicine and in charge of trauma and emergency medicine at the Rajendra Institute of Medical Sciences, Ranchi. His area of expertise is basic physiology and critical care, respiratory, neuro, cardiac critical care, all of them. So may I now hand over the dice to Dr. Pradeep Bhattacharya to deliver his talk on geriatric infections. Is Dr. Bhattacharya
Good afternoon, everybody. Today, I'm going to present a case in front of you that is of a geriatric infection. This is an interesting case which I found, and then that I thought that I must present it because it conveys lots of knowledge for youngsters. It's a 72-year-old female who was admitted in the emergency department in a confused state with visual hallucinations. She had been found by her niece still in bed and in the afternoon in an unkempt state. She was talking to herself and she was unable to recognize her niece. She appeared to have spent the past few days in bed and had not been seen by her neighbors or friends for several days. Approximately 1 week earlier, she had complained to her niece of some chest pain and cough, but there was no past history or medical history other than hypertension. She was a retired librarian living alone and was previously active with an independent lifestyle. She used to play golf. She used to go for a walk with her friends, and she was a teetotaler. She never took any smoke or alcohol as in the form of drink. Her medications included only one antihypertensive in the form of Ramipril, and she used to take occasional paracetamol for body ache and fever. On examination, she was agitated and uncooperative with a confused speech. Her AMTS score, that is abbreviated mental test score, was 0 out of 10, and a CAM, confusion, CAM ICU score was 4 out of 4. That was consistent with delirium. Observation showed a temperature of 35.8. Blood pressure was normal. Heart rate was 90 beats per minute. Respiratory rate was 22 beats per minute, with a low oxygen saturation with 10 liters of oxygen in emergency. On auscultation, there was bilateral coarse crepitations on the bilateral chest, maximally in the middle and lower part, and the rest of the examination was unremarkable. The laboratory investigation showed that she was having some neutrophilia. Then her sodium potassium was although normal, but urea was high, creatinine was also high. CRP level was much high, it was 16 times higher. And LFT, TSH, free thyroxine level, all those tests were normal. But parathormone level was quite low, 0.4 picomoles per liter. The calcium level was again high, it was just double, and the phosphate level was also high, 1.72 millimoles per liter. Her arterial blood gas was suggestive of hypercapnia, a little bit of hypercapnia, and hypoxemia. Lactate was 3.2 millimoles per liter, more than 2 times. ECG was suggestive of sinus tachycardia. An X-ray chest was done, and this is what could be seen on the X-ray chest, and it shows bilateral lung infiltration, rather consolidation with basal predominance, and you see that it was extending up to the middle lobe also, a little bit on the right side. Now, what is the most likely diagnosis in view of these clinical findings? Obviously, one can say that because she's having neutrophilia, lactates were high, and so it's a clear-cut case of lung infection. So as the chest X-ray suggests, that is extensive bilateral perihilar consolidation, which is consistent with infection. Pulmonary edema could also result, but the heart shadow was normal. That is why no cardiac ailment, and that's why it was inconsistent with this diagnosis. Now, the final diagnosis which was made on the basis of investigation was a case of delirium, secondary to chest infection, hypoxemia, dehydration, and hypercalcemia. Now, what are the possible causes of hypercalcemia? Because this is an infection associated with hypercalcemia in this case. So when we try to find out what are the causes, at this age, most of the hypercalcemia, most of the majority are caused by either primary hyperparathyroidism or malignancy. Now, what are those malignancies? And mostly it includes ovarian, lung, esophagus, kidney, cervix, and lymphoproliferative disorders, multiple myelomas, lymphomas. They can give rise to this kind of hypercalcemia. Then infection and immobility. Obviously, these two things are there, but most common find organisms which gives rise to this finding are granulomatous diseases like tuberculosis and leprosy, fungal infections like candidiasis, coccidiomycosis, histoplasmosis, sometimes cat scratch disease or AIDS-like illnesses that gives rise to this kind of finding of hypercalcemia. When we call it as, in fact, it is associated with infection. Now, occasionally, immobilization may be associated with high calcium, but absence of infection and if there is a neurological ailment like post-stroke, polyneuropathy, hip fractures, spinal cord injury, and patient is very obese, and these kind of cases sometimes give rise to mild hypercalcemia, but not a very severe one. Now, other causes are some of the drugs like thiazide, lithium, calcium carbonate, vitamin D, theophylline, methotrexate. Then hyperproteinemia, milk alkali syndrome, Addisonian crisis, rhabdomyolysis, endocrinopathy, sarcoidosis, Crohn's disease, etc. All these can give rise to hypercalcemia. Now, list the most common presenting feature of hypercalcemia. What are the most common feature what we see in patients with hypercalcemia? Now, patients with hypercalcemia may present with confusion, lethargy, depression, stupor, coma, constipation, nausea, vomiting, peptic ulcer disease, weakness, and proximal muscle weakness are sometimes very prominent. And there may be polyuria, hematuria, renal colic. Because of nephrolithiasis, hypertension, bradycardia are in common association along with hyperreflexia, tongue fasciculation, and anorexia. But the symptoms will depend on the rate and degree of calcium rise. And calcium level up to 3.5 millimoles per liter can be well tolerated if it is developing gradually. But rapid elevation will cause major problem. So my question is that how would you proceed in this patient further? So further investigations were done this patient, and they were include blood and urine culture for Legionella, then serum electrophoresis. That result shows generalized proteinuria that was available. Then PTH related protein level was done, but that was also found to be negative in this patient. Then vitamin D metabolite level to find out any other problems associated like hyperparathyroidism or lymphoma. And none of these were detectable in this patient. Bone marrow aspirate, which did not demonstrate malignant cell. Then serum cortisol, ACTH, synecthen test was also done, which was found to be normal. On bronchoalveolar lavage, Proteus mirabilis and coliforms were found, but there was no mycobacteria, HIV, syphilis, all those were negative in this case. So a different infection with hypercalcemia. So why this case was chosen for presentation? In most of the cases of hypercalcemia, what we see that chest X-ray to look for evidence of malignancy or sarcoidosis, and serum urine electrophoresis for multiple myeloma and PTH level reveals the cause. Here, an extensive investigation is not usually necessary. But here you see the things are completely different. That is why we chose this case for presentation. Now, what we see in the urine calcium excretion level, if we see, if it is high or high normal, then either malignancy or hyperparathyroidism is there. And if it is low, then drugs such as thiazide or enhanced calcium resorption from distal tubule may be there, or familial hypocalciuric hypercalcemia or milk alkali syndrome may be there. And if serum chloride is high, then in hyperparathyroidism, and low, it is low in milk alkali syndrome. Now, serum phosphate, which was also high in this patient. So low level is common in hyperparathyroidism and malignancy due to inhibition of proximal tubular reabsorption of phosphate. While high or normal levels are found in milk alkali syndrome, immobilization, metastatic bone disease, granulomatous disease, thyrotoxicosis, and vitamin D intoxication. So none of these were correlating with this patient. So the patient continues to deteriorate and went on to have a CT scan. We decided to have a CT scan for abdomen and pelvis along with a chest. And this is the finding of CT scan. And it was suggestive of a ground glass changes in the posterior consolidations with multiple bilateral small cystic cavitating lung lesions with small pleural effusions. So this was supportive of the diagnosis of chest infection, and BAL was also already suggestive of Proteus mirabilis. Accordingly, antibiotic and other therapies were started. Now, how do we manage this case? As per the sepsis guideline, the IV fluids were given, patient was hypotensive, so inotropic and ventilatory support were started. Calcium was normal on third day after admission, but we did all the management which is required for acute hypercalcemia. But despite intensive treatment, she died on the 10th day of admission, and the postmortem examination revealed that it was a case of cavitating pneumonia with no evidence of lung carcinoma, parathyroid tumor, hyperplasia, metastatic carcinoma, and multiple myeloma. So all of them were excluded. It was simply an infection. So what we planned, how we treat this case in general treatment, hypercalcemia is treated through rehydration and diuresis. And if it is caused by immobility, contributing medication should be discontinued, and volume repletion along with anti-osteoclastic agents and passive mobility rehabilitation. This is what we do. In mild hypercalcemia with mild symptom, there is no need for urgent correction, and if the cause is corrected slowly, the things become normal in due course of time. But if in symptomatic hypercalcemia where the calcium level is more than 3 millimoles, like in this case, a rapid correction is required, and we did that. It was done within 3 days as fast as possible. And if possible, you need to make, if it is not getting corrected, calcitonin can be used as a stopgap arrangement while the onset of action of other hypocalcemic medication is awaited. Now, the third thing which can be done is the hemodialysis, which is helpful in controlling hypercalcemia. Now, what was the cause of hypercalcemia in this patient, knowing the fact that the CT of abdomen and pelvis was normal? Now, the cause of hypercalcemia was thought to have been severe community-acquired pneumonia associated with sepsis and immobility. And again, here it is explained by high level of C-reactive protein, which indicates markedly increased circulatory pro-inflammatory cytokines, the very high level of calcium normalized with dehydration and biophosphonates, suggesting that metastatic bone cancer and other solid tumors are not there. So the abnormal renal function corrected with rehydration and normalization of calcium, and the cause of death was multi-organ failure here. It was happened because of sepsis and severe pneumonia and hypercalcemia, which can also give rise to multi-organ failure. So lastly, hypercalcemia alone may induce acute renal failure and multi-organ failure. And if it is associated with sepsis, it is more dangerous. So it can exacerbate chronic renal failure. And conversely, the presence of pre-existing renal failure in patients with onset of immobilization is a high risk factor for hypercalcemia. Other things which can be caused are cardiovascular dysfunction, hypertension, hypercalcemic crisis, multi-organ failure, and nephrocalcinosis. This is all about this case. And I think all of you have got some carry home message from this case. Thank you very much. How much time?
Thank you.
Good afternoon.
It was a very interesting case, and I'm sure many of us see similar cases on day-to-day practice of ours. I would also like to thank Dr. Vivek Nagia for sparing his time. For the next talk, next we have e-Criticare special, which was by Dr. Jose Chaco. So it is a lecture from the e-Criticare which happened in 2020. And this lecture is about COVID-19 literature, the studies on COVID-19, whether they are boom or boondoggle. So Mr. Neeraj, can you please play the talk?
Thank you very much. So that's the topic we are going to deal with this afternoon. One of the most devastating pandemics in history broke out earlier this year, as we all know. COVID-19, as it was named later, was a disease that we knew very little about. Clearly, we were totally unprepared for a worldwide outbreak of this magnitude. Almost inevitably, a cocktail of therapies followed, starting from nasal rinses to inhalations and lots of other lotions and potions which claimed preventive and therapeutic properties. However, this afternoon, we won't look at any of those. We shall only look at studies that have scientifically evaluated specific treatment modalities for patients with COVID-19. One of the drugs that we have been looking at right from the start of this pandemic is something that would kill the virus early and prevent severe disease. If you look at the SARS-CoV-2 virus, it enters the cell through a very deceptive mechanism. It binds itself to the ACE2 receptor, gains entry into the cell, and then it releases its RNA, which the mitochondrion of the host cell replicates to several fold, such that the RNA become viruses. They start invading neighboring cells as well, and thus the disease becomes fairly widespread across the body. Now, how does remdesivir, the drug that we've been using quite a lot across the country and across the world, how does this fit into the picture? What does it do to the virus? It enters the cell and takes the place of adenine within the RNA of the SARS-CoV-2 virus. And when it does that, it changes the whole configuration of the RNA such that it cannot replicate anymore. So replication is lost, and the virus is inhibited, and hopefully this mechanism will work out in real-world practice. At least that's the premise behind which remdesivir was initially used in MERS as well as in Ebola infection. Unfortunately, the results were not very promising with those disease processes. Now, it's against this background that we had the ACT-1 trial, which Fahad referred to in his talk just a while ago, wherein they compared remdesivir versus placebo in a blinded fashion, 1,062 patients. And what did they find? They found that the proportion of patients who recovered was higher in the remdesivir group compared to those who were in the placebo group. The recovery time was 10 days versus 15 days, which was statistically significant. And it seemed that the efficacy was more if the drug was administered within the first 10 days of onset of illness. However, as we heard, they did not find a difference in mortality at day 29 between the two groups. So this study also showed that if you use remdesivir within the first 10 days, it may be efficacious or more efficacious compared to if you use later in the course of the illness. But as I mentioned, this study has really asked several questions as to whether it is worthwhile to really consider shortening the illness by a couple of days when it clearly doesn't change the mortality very much. So that's something we really need to look at. And for that, we have yet another randomized controlled trial. And we are all familiar with the Solidarity clinical trial, which was sponsored by the World Health Organization. They had 4 arms in their study in which the intervention group was compared to a standard control group. And these treatment modalities included, apart from remdesivir, hydroxychloroquine, lopinavir, ritonavir, and interferon beta. And in the remdesivir arm, they found that there was no difference in mortality between remdesivir and control in the same kind of treatment regime that they used as it was in the ACT-1 study. And they also found, apart from in-hospital mortality, which was not different, there was no difference in mortality among ventilated patients. So the severity of illness didn't seem to matter, be it ventilated patients or patients not on ventilator. The efficacy was similar between the remdesivir and the control groups. As we know from the ACT-1 study, that particular study showed that there was a reduction in the number of days in hospital with remdesivir use. So does it really shorten the duration of illness? What does the Solidarity trial tell us? In fact, the results of the Solidarity trial contrast with that of the ACT-1 study. There was no difference in the number of patients who remained in hospital at day 7, 14, or day 21 in the Solidarity trial. So even though this study did not give the actual numbers of patients who had recovered by a certain time frame, it showed the number of patients who remained in hospital were similar at similar points in time. The Solidarity study, of course, was very different from the ACT-1 study. The ACT-1 study was sponsored by the manufacturer. It was a blinded, placebo-controlled study. The Solidarity trial was an open-label study which compared 4 different treatment modalities. And the countries involved in the Solidarity trial, many of them were in the less developed world. The standard of care was not uniform, and they may not have reached the level of the more developed countries. And also they did not have much data regarding the baseline severity of illness. So these are some of the problems that we see with the Solidarity trial. However, it was a real-world pragmatic study which really did not demonstrate a mortality difference with the use of remdesivir in a very large number of patients. We've heard a lot about convalescent plasma. It's been used extensively in many units, including ours. And this was all based on initial reports from China, where it all began more than 10 months ago. The first case series of the Chinese study had just 5 patients, and they showed some signal of benefit. This was followed up by a proper randomized controlled study, which again showed some benefit in the severely ill patients, but not life-threateningly ill patients. So it was based on this background and some other observational studies, particularly from the US, which suggested that earlier treatment within the first 3 days is much more efficacious than later treatment. It's against this background that the Indian Council for Medical Research conducted their own study comparing convalescent plasma with the control group. And as we know, the study was, the PLACID trial was published in the BMJ just a few days ago. The study population included severely ill COVID-19 patients with a PF ratio of between 200 to 300, tachypnic, and had a saturation of less than 93% on room air. And they used convalescent plasma. What did they find? They looked at the composite primary endpoint, which included all-cause mortality or progression to severe disease at day 28. This was not different between patients who received convalescent plasma and those who were in the control group. They also found that each of the components of the primary outcome, namely the 28-day mortality, nor the progression to severe disease individually, was different between the 2 groups. They also looked at earlier versus later treatment within the first 3 days and later on, which again did not show any difference between the treatment and the control groups. One of the limitations of this study, as the authors themselves report, is that they did not measure antibody titers. Given the constraints of the situation and the lack of availability of proper testing for antibodies, they couldn't do it. But in the real world setting that occurred at the early phase of the pandemic, they could not find any benefit with the use of convalescent plasma across a broad subgroup of patients. Now, the most important question about corticosteroids. Steroids have a long checkered history with use in viral pneumonia. We all know that it's been used extensively in the SARS infection way back in the early 2000s. It was used in the Middle East respiratory syndrome, all of which showed either no benefit or possible harm. So it's against this background that many guidelines and recommendations suggested that you should not be using corticosteroids in COVID-19, at least at the beginning, at the early phase of the pandemic. That was the general understanding. But today, we have a different story. A different story has evolved over the last several months. The CODEX study, which was one of the randomized controlled studies from Brazil, they looked at dexamethasone administered in a dose of 20 milligrams initially, and then 10 milligrams per day. They looked at ventilator-free days at 28 days, and this was, in fact, the number of ventilator-free days was more with the use of dexamethasone. 28-day mortality was also lower with the use of dexamethasone, with a slightly higher dose than the recovery trial. The recovery trial itself used dexamethasone in a dose of 6 milligrams per day intravenously for 10 days, and they found that the 28-day mortality was indeed less, and the mortality benefit seemed to be much more pronounced. The more severe the patient was, the benefit seemed to be much more. Ventilated patients, patients on oxygen and IV, they benefited more than patients who did not require any respiratory support, in whom the use of steroids was seen to cause possible harm as well. So severely ill patients benefit more with dexamethasone, as the recovery study tells us. The Cape COVID study was conducted in France. They used hydrocortisone in a dose of 200 milligrams initially, then 100 milligrams per day. There was no difference in this study in terms of the mortality or number of ventilation days, although there was a signal that it might reduce mortality. There was a significant trend. There was a non-significant trend to reduce mortality with the use of hydrocortisone. The REMCAP study, which again used hydrocortisone in shock-dependent patients or routinely and compared it to a control group, and they found that there was, again, a reduction in organ failures at 21 days. Now, all these studies, apart from the recovery study, were stopped prematurely because by the time the recovery study had been published and the results were out. So the WHO meta-analysis of all these studies, as the diamond at the bottom shows that the use of corticosteroids is associated with an improved 28-day survival in patients with COVID-19. Now, the questions that still remain are, does it matter as to what type of steroid do you use? Is the first question. The second question would be, would you use a modest dose of steroid like the recovery study used of, say, 6 to 8 milligrams per day, or would you go for a higher dose? That question is, again, not clearly answered. The third question would be, what is the optimal patient subgroup in whom to use steroids? As the recovery study showed us, it might not be of benefit in less severely ill patients. So how do you assess severity and possible efficacy with corticosteroids? The COVID curve in India is slowly, thankfully, creeping to a plateau. Several lotions and potions have been offered along the way, almost all of which have been proven to be useless, except for corticosteroid, with which still there are several questions that remain. At the end of the day, we know that there is no magic bullet that can cure this disease process. It's all about going back to the basics and giving focused attention to your critically ill patient by the bedside. If you offer them good respiratory support, good ventilator care in the most severely ill patient, they may survive. And that is the bottom line. Stick to the basics and do it well. Thank you.
Thank you. This brings us to the end of this session. I would like to invite you all for the inauguration session of Criticare 2021 at 1:30 p.m. And thank you all. Do join us at 1:30 p.m. Thank you.
Code blue 508. Code blue 508. Code blue 508.
कार्डियक अरेस्ट हुआ है, हम कोशिश कर रहे हैं।
एक्सक्यूज मी प्लीज।
ये कौन है? ये आईसीयू के डॉक्टर है।
रवि, ब्रेकफास्ट रेडी है।
वाह माँ, बहुत ही बढ़िया बना है, थैंक यू।
ये रिश्तों की दूरी कब तक रहेगी बेटा?
पता नहीं पापा, कुछ कह नहीं सकते।
पापा मत जाओ ना, कभी तो मेरे साथ रुको। आपके बिना ही मैं बड़ी हो रही हूँ। जाने दो ना।
आप जाइए, मैं संभाल लूंगी।
मैं कभी डॉक्टर नहीं बनूंगी। आई हेट डॉक्टर।
सर, ये अनुज डॉक्टर भी पॉजिटिव है क्या?
हाँ
सर, ये अनुज डॉक्टर भी पॉजिटिव है क्या?
हाँ ब्रदर, अनुज भी पॉजिटिव है।
तो आप अकेले क्या आज ड्यूटी पर?
अरे अकेला कहाँ, तुम लोग जो हो साथ में। लेकिन
सर,
सबसे पहले मास्क पहना जाता है, बाद में किट। मास्क पहनो।
जब तक पेशेंट एक्सपायर नहीं होता ना, तब तक वेटिंग पेशेंट को आईसीयू में बेड नहीं मिलता।
मैं भी डॉक्टर नहीं बनूंगा, मैं कमांडो बनूंगा। कल रात को आप कौन सी फिल्म देखते सो गए? लेकिन ये फाइनल वाला है। क्यों क्यों क्यों? कमांडो भी फौजी होते हैं, लेकिन अलग। जैसे? अलग लेवल के हार्डकोर फाइटर्स, अलग लेवल का प्रेशर गेम और फुल एड्रेनलिन। रवि के काम में एड्रेनलिन नहीं होता?
We are worried for our patient. और आप है कि हमारा कॉल ही नहीं उठा रहे।
मैं आपकी तकलीफ समझता हूँ, बट मेरी प्रायोरिटी मेरे पेशेंट की लाइफ है।
कॉर्पोरेटर का एक फोन आएगा ना, बराबर समझ में आएगा प्रायोरिटी क्या होती है।
धमकाना, ब्लेम करना, मारपीट करना आपकी प्रायोरिटी हो सकती है। मेरी प्रायोरिटी मेरे पेशेंट की लाइफ ही रहेगी।
थैंक यू डॉक्टर, बट हु आर यू एग्जैक्टली?
आई एम इंटेंसिविस्ट इन चार्ज ऑफ आईसीयू।
मतलब?
क्रिटिकली इल पेशेंट्स जिन्हें वेंटिलेटर या ब्लड प्रेशर सपोर्ट मेडिकेशंस की जरूरत होती है, उन्हें ट्रीट करने वाले स्पेशलिस्ट डॉक्टर इंटेंसिविस्ट होते हैं। हम हर एक पेशेंट को अपने फैमिली मेंबर्स की तरह ट्रीट करते हैं।
आपको आपके पापा पे प्राउड फील होना चाहिए बेटा। वो घर पे टाइम नहीं दे पाते क्योंकि वो लोगों की जान बचाते हैं।
क्या मेरे पापा कमांडो है?
इंटेंसिव केयर के डॉक्टर मतलब मेडिकल फील्ड के कमांडो ही होते हैं।
फिजिकली, इमोशनली और नॉलेज वाइज भी इट्स अ टफ जॉब।
दैट्स व्हाई इट इज कॉल्ड क्रिटिकल केयर यूनिट। और एक पेशेंट। One more life to save. Let's move. We are at war against COVID. Indian Society of Critical Care Medicine, ISCCM, founded on 9th October 1993, is the largest non-profit association of physicians, nurses, physiotherapists, and other allied healthcare professionals involved in the care of critically ill. It is actively involved in improving the standards of care of critically ill patients in India via education, training, and research. It now comprises of 88 branches with more than 13,000 members, and all are actively fighting in this battle against COVID-19.
Good afternoon, sir. Good afternoon.
Good afternoon, sir. Good afternoon.
Good afternoon.
Good afternoon, sir.
Good afternoon, sir. Hello.
Shekhar, can you allow Dr. Rajesh Mishra in, please? Shekhar, Dr. Rajesh Mishra is waiting to join. Can you please allow him?
Done, sir, done.
Good afternoon, sir.
Good afternoon, sir.
नहीं सर वो थोड़ा सा इसमें टेक्निकल हो रहा था. आई एम सो सॉरी.
No problem, sir.
ये चल रहा पीछे से आता है.
बैकग्राउंड आपका बहुत फ्लिकर कर रहा है, हटा दीजिए. आई थिंक इवन नहीं आपका बैकग्राउंड तो फ्लिकर कर रहा है, अच्छा नहीं लग रहा. डॉक्टर ध्रुव.
राजेश यहाँ कहाँ आ गए यार?
आपका बैकग्राउंड डॉक्टर ध्रुव फ्लिकर कर रहा है. श्रीनिवास, यू कैन टॉक टू ध्रुव सर.
डॉक्टर राजेश, इस सेशन में आप नहीं हो.
अच्छा.
सो आप उसको फिल्म को ऑफ कर दो. आप नहीं हो इसमें. प्रेसिडेंट, पास्ट प्रेसिडेंट, प्रेसिडेंट इलेक्ट, जनरल सेक्रेटरी 4 ही होते हैं.
Sir, shall we start, sir?
Good afternoon, sir. Sir, Dr. Srinivas is our General Secretary. Dr. Subhal Dikshit is our past president, sir. He is from Pune. Srinivas is from, sir, Hyderabad. And Deepak is from Medanta, sir. He will be taking over from me. And we are sitting next to you in the India-Asia House, sir.
Right, sir. Right.
So I think we will be starting soon, sir.
Right.
Srinivas, when can we start, Dr. Deepak and Subhal?
Yeah, we can start. We can start.
Yeah.
Shekhar, are we ready to go? Shekhar?
Yes. Srinivas, please start.
Shekhar, are we ready to go?
Yes, sir. Yes, sir.
Okay. Good afternoon, friends. Thank you for joining the Indian Society of Critical Care Medicine's annual Congress, Criticare 2021, the first ever virtual Congress of the Society. Today, you have joining me for the inaugural session and the presidential events associated with the Indian Society of Critical Care Medicine. Today, we have a very distinguished guest list of speakers who, by the dint of their experience and their commitment to the profession, have actually led the path and shown us the way how medicine is practiced and what is the way forward. I am extremely privileged to start the proceedings today and facilitate the introduction of our speaker for the ISCCM oration, a very distinguished medical professional, Dr. K. Srinath Reddy. I am humbled to be privileged to be as General Secretary to be actually facilitating this invitation. May I now request our President, Professor Dr. Dhruv Chaudhary, sir, to kindly introduce the speaker and invite him for the oration. Sir, please.
Thank you, Srinivas. May I have the PowerPoint, please? Good afternoon, friends. Today we are very fortunate that Professor K. Srinath Reddy has agreed to deliver this prestigious 27th ISCCM oration to us. Professor K. Srinath Reddy is at present the President of Public Health Foundation of India. Sir is also has been the head of the Department of Cardiology at All India Institute of Medical Sciences, Delhi. Sir has been also the physician and a cardiologist of 2 former prime ministers. Sir is a Padma Bhushan, and he has been appointed as the first Bernard Lowing Visiting Professor of Cardiovascular Health at Harvard School of Public Health from 2019 to 9 to 13. Presently, he is an adjunct professor of epidemiology at Harvard. He is also adjunct professor of Rollins School of Public Health, Emory University, and honorary professor of medicine at University of Sydney. Sir has been advisors to government of Odisha, Punjab, Haryana, and Andhra Pradesh on public health. He was the one who established Public Health Foundation of India, and under his able leadership, we were having now 5 Indian Institute of Public Health throughout the country. Sir is also the member of the Sustainable Development Goal Commission of Lancet as well as of the Lancet COVID. Here I present before you Professor Dr. K. Srinath Reddy. Professor Reddy, sir.
Thank you very much, Professor Chaudhary. Dear miracle makers of critical care medicine, it's a pleasure to greet you at your annual conference. It is indeed a great honor, but I must say it is an unexpected honor. Mostly because of the fact that it is, in my view, an undeserving honor. I have not really contributed much to research or education in this field. Usually orations are awarded to doyens in that specific area. Yes, of course, as a cardiologist, I worked in coronary care units, and I'm familiar with the working and value of intensive care units. And therefore, critical care medicine is not something unfamiliar to me. My own family members and even I have benefited at some point in our lives from critical care. And therefore, I owe a great deal of personal gratitude as well. However, as a health system analyst and as a commentator, I do have interest in the practice and potential of critical care and would like to see how best this fits into an efficient and equitable healthcare system. So I will make bold to offer my thoughts with as much humility as I can muster. Firstly, I think this particular conference is being held at a time when the relevance and value of critical care is no longer really required for advocacy. It is only required for elaboration of the potential and where the gaps need to be filled in. Because this pandemic has highlighted as never before the very important contribution of critical care in saving lives. While the pandemic has shaken humanity, it has stirred science and public health. It has created a huge respect and gratitude for medicine and public health, and has boosted their image both in the policymaker priorities as well as in the public mind. And it has particularly highlighted the role of medicine in saving millions of lives, even though several lives have been lost already. Saving lives has become the foremost priority of society. And even in the debate between lives and livelihoods, clearly the priority accorded to lives has won out, as it should. But even for livelihoods to prosper, we need to ensure that lives are protected. And therefore, saving lives becomes absolutely critical, especially when those lives are in jeopardy because of treatable conditions or potential, or if they're salvageable, even when the disease appears to be very severe and life-threatening. And critical care medicine has stood foremost and fought fiercely for ensuring that lives are saved and not snatched away by death. And therefore, in the overall context of COVID-19, the role of critical care medicine has emerged as one of the pivotal pillars of medical intervention. Policymakers as well as public health economists have both now recognized the value of critical care units. And we see that very clearly in the budget of 2021, as well as in the recommendations of the 15th Finance Commission. While the whole area of epidemiological surveillance, strengthening of primary health care, both urban and rural, have rightly been accorded priority, both in the budget and in the Finance Commission recommendations. One area that particularly features very clearly in the area of medical care is the provision of critical care through strengthened critical care units. And that is where I believe it is absolutely important for us to recognize that while we are really trying to prevent disease, promote health, facilitate early detection of problems, ultimately, when the lives are actually in jeopardy, you do need hands that can save those lives. And therefore, there is no competition between prevention and care. Previously, it used to be considered that investments in critical care, particularly in prolonging the last years of life or even the last hours of life, are a huge expenditure. And there have been several critics among the health economists and so on, whether that particular money is somewhat disproportionate. However, there is no debate any longer. We now recognize that saving lives is absolutely critical, and we do need to invest also in critical care as we do in prevention and health promotion. Therefore, public health and health system configuration are a seamless continuum, and we do not actually have to spend futile energy in fighting each other as to which is a priority. All of these are indeed priorities. And that is where all of the health system and those who are involved in operating the health system and performing its functions must stop fighting each other about the priorities within the health sector and ask for more funding, financing, and strengthening of all elements of the health system, including and especially critical care. Therefore, we do need to increase critical care capacity. And for this, even as science is advancing, we must recognize that the best of science must be accommodated as relevant to our context as we expand our ability to provide greater institutional facilities for critical care, along with building the skilled human resources who can actually make use of those facilities. Whether it is proning to PEEP or nitrous oxide NO2 ECMO, we see great advances have happened in critical care, and lung protective ventilation has emerged as a very important area in which we can actually prevent a lot of damage to the lungs while saving lives. So we do recognize that there are many advances that need to be studied and integrated as appropriate into our own practice. And I will not bring coals to Newcastle by trying to talk about what are the specifics of critical care medicine that you should be focusing on, because your conference agenda is so rich in its detail and so resplendent in its expertise of its faculty that I would not really like to venture into that territory. But where I would like to really talk about is how best you can promote science and the adoption of science into clinical practice. Therefore, we do require to build our capacity as well in terms of the human resources who are well-trained and skilled and appropriately employed for delivering critical care medicine. That is where the role of the National Board of Examinations through the DNB program became very, very important. And therefore, when I was the president of the National Board of Examinations, this was one of the areas that we felt must be strengthened. Clearly, of course, the institutions which are capable of delivering that training are always somewhat limited unless we start investing in expanding the facilities. That is where not only in the private institutions where critical care medicine has particularly emerged very strongly, but also in medical colleges and their hospitals. And we must now even extend to district hospitals, where critical care medicine must be integrated, not as a tertiary care luxury, but as something that can actually save lives with the timely intervention. And therefore, I think expanding the capacity of our critical care medicine capabilities is going to be a very important element of our health system strengthening agenda. And that is where a great deal of your expertise must also now go into training a new generation of and a larger number of skilled critical care providers. We do recognize, of course, that critical care medicine is not confined only to doctors. While they're extremely important and are clearly the team leaders, we recognize that whether it's critical care nurses or technicians or physician assistants or a variety of other members of the team, they also need to be trained in much larger numbers. So how do we actually augment our capacity in critical care medicine? By building up the skilled health workforce as speedily as possible. And there we must invest a lot more in strengthening our training capacity, and even strengthening of our district hospitals will go a long way in providing training centers apart from the medical colleges and the very capable private institutions who are already accredited to the national board programs. So we do need to expand the training program, and that is where a good deal of advocacy is required. But also it requires preparation of protocols and adoption of the protocols. And those protocols need to be made in a manner that is absolutely appropriate to our conditions. But it's not just enough to make those protocols. Their impact has to be studied. Has it really made a difference in practice? Has it improved the outcomes? And that is where a good deal of implementation research or translation research comes in. And we do need to strengthen that element of research as well as the elucidatory element of research, where a lot of original research also can be undertaken in order to answer some important questions as to what interventions are effective, what are the prognostic features that actually predict a better outcome versus a poor outcome, what are the kind of diagnostic tests, whether performed either simultaneously or sequentially, which can result in less misdiagnosis or misclassification and give much better direction to the nature of treatment algorithms to be followed. And here we must recognize that this is the duty of medicine in training and the duty of medicine in practice too. As Charles Mayo, one of the two founders of the Mayo Clinic, said, the objectives of medical education are to cure the sick and to advance the science. So we must really recognize how best we are playing the second role as well, not merely to cure the sick, which we must indeed try our best to do, but also try and see how best we can actually advance the science. And that is where research comes in. there's a great scope for research, but which is underutilized in terms of its potential now. And when we look at what is happening elsewhere in the world, we are moving from small, what may appear to be complex studies to large, simple, randomized controlled trials to answer the big questions. Whether it is the recovery group of trials in UK or the solidarity trial in which is international, organized under the auspices of the WHO. The idea is you can get much better and more precise answers by doing large, collaborative, and fairly simply designed trials, rather than going in for small niche trials, which land up with small sample sizes, which are underpowered to deliver the required result with any precision, and do not necessarily fit into the context. So it is important for us to build those research collaborative networks. I always used to wonder in the 90s how the Italians conducted a series of trials called the GISI trials with participation of more than 300 hospitals, most of them private hospitals, not major academic centers, but pooled together the resources to conduct some fabulous trials in the interventions for management of acute myocardial infarction. Now, the whole world suddenly stood up and took notice. They said, Italians, how are they managing to do it? We never thought they could be so organized. Now, they showed how it could be done, and it could be done by pulling together a number of practice centers, but enforcing very standardized and fairly rigorously monitored protocols. Now, it is that kind of strength that we need in India today. And for one or two centers to be doing research on their own is not going to help to answer the big questions. The complex questions need a large collaborative research network. And that is where organizations and conferences like yours must forge that platform for creating those kind of scientific partnerships and research enterprises. And of course, you do have the strength of the DNB program and the fellows who are studying also to provide you the requisite support. But I think more funding will be available from the science agencies of the country, given what the pandemic has actually taught us, that we do need to bring in a lot more of our own knowledge to the forefront. And we recognize that context matters, and that is a message that we must send even to the funders, whether it is the algorithms of artificial intelligence or the use of sensors. We are finding that context matters, because it is very clear that what goes into an algorithm are the inputs which are generally context dependent. And then what comes out of the algorithm is the analytic product of that. And if the inputs are very variable across different contexts, then the algorithm no longer has a good fit. And this we know from classical Bayesian principles, that the prior probability as well as the test result determine the post-test probability. And we are finding that many of the algorithms that are developed in the West are not really applicable to other populations. Some of them are, some of them are not. The principles may be the same of developing the algorithm, but the specific content areas may have to be molded according to the local context. And what better than a large country like India to provide its own context or similar context elsewhere in the world than by doing its own original research and developing its own algorithms, both with its huge patient population, scientific expertise, as well as information technology strength. Even when it comes to sensors, we are just reading over the last few weeks the controversy that has erupted in the United States about how pulse oximeters are discriminatory against people who are colored, whether it's black or colored otherwise. They are basically overreading the oxygen content when compared with arterial blood gases. And therefore, a patient who may have 86 or 88 oxygen is being shown as having 92 or 94%. And this can be problematic in a management. And therefore, now they're saying that we must actually even adopt pulse oximetry to different skin colors. Have we ever thought of that? What is it in our context that we must do? Even where simple monitoring devices may have to be adapted to our context, why are we not pushing our healthcare industry to look at this? That is because we have not studied these questions adequately, and this is what we must now really address. Now, in terms of research methodology, as I said, context matters, but we do need principles of research, which are generally well established globally. And if we follow that, the quality of our research will win us respect, even as the quantity rises. And there, for research methodology or clinical epidemiology, which is required, the Public Health Foundation of India and its institutes can provide support in training your fellows in research methodology and in assisting them in developing research protocols. Even as precision medicine is emerging as a very strong force, trying to individualize treatments to patients, what exactly goes into those analytics will still have to be determined by research. And that research is best conducted in our context rather than purely imported and then found to be not very relevant. So we do also require additional areas of research, whether it is protocols for prevention of antimicrobial resistance in intensive care settings, or looking at how best we can actually prevent nosocomial infections. The research agenda can be very wide, and that is where you ought to be able to really look at how best you can actually launch your research enterprise as well, apart from the training and skilling which goes into the practical area of care delivery. The future is really exciting. In fact, as William Gibson said, the future is already here. It is just unevenly distributed. There are parts of the world which are practicing very advanced technologies. There are parts of the world which are diverse from there. Fortunately, in India, we are in a good position to leverage our own technological strength, but at the same time, try and bridge the technology gap that exists and move ahead. Digital health is bringing in a lot of promise with devices, pattern recognition, diagnostics, electronic medical records, which can be problematic sometimes unless they're simplified, sensors of various kinds, robotics, telemedicine, all of them are coming in. New drugs are being discovered for treatment. We are also seeing immunomodulators, antibodies, stem cells, all of them coming in, and they will have, at least partly, to some extent, a role in critical care medicine. Therefore, we must study all of these technologies as they emerge, some from abroad and some which may be innovated in India itself, for their relevance. Is it fit for purpose? Is it fit for context? Is it cost effective? How do we do that health technology assessment? We bring in also not only researchers and epidemiologists who have idea of how to conduct research studies, but also health economists, people who study health policy priorities, and then try and say, okay, these are the kind of technologies that can easily be fitted into our health system. We must also stimulate local innovation. Many of the technology geeks in our country, I would say, let's say technology entrepreneurs in our country, are very keen on producing new technologies, but they do not know what problem to address. What is the specific area of potential application? That is where the practitioners and the scientists of critical care medicine must join hands with the technology group and say, this is the problem we'd like to see you solve, and then direct them in the right manner so that appropriate technologies are speedily developed. And those partnerships too must develop, not as a matter of accident, but as a matter of intent. And we can actually have a lot of technologies that we can develop through local innovation, which can potentially go in for high global impact. There's no reason why not. So apart from Atmanirbhar, if the Prime Minister says we must be a Vishwa Guru, there is no reason why we cannot be, provided we apply our minds and skills to it. Then finally, may I also say that we are now seeing that there are problems emerging of long COVID, where long-term COVID care is required. Long-term acute care hospitals are being proposed. And there I would like to read out a few things from a recent blog by Sean Muldoon. Says, COVID-19 has reminded the world of the importance of facilities that occupy the middle ground of critical care landscape. A recently co-authored post in Health Affairs in April 2020 highlighted the critical resource that long-term acute care hospitals can play during the COVID pandemic. Specifically, the researchers suggest that clinical expertise in long-term acute care hospitals with critical care nurses, respiratory therapists, and intensivists aligns with the ongoing needs of COVID patients. The experts conclude that during this unprecedented international crisis, these hospitals offer opportunities to prepare for and manage the surge of COVID-19 patients experiencing respiratory failure. It goes on to say, due to the complex medical needs of the post-COVID-19 patients, long-term acute care hospitals are a key care setting. These hospitals deliver care for the most difficult to treat, critically ill, and medically complex patients, such as patients with respiratory failure, septicemia, traumatic injuries, wounds, or other severe illnesses complicated by multiple chronic conditions, many of which have been symptoms of post-COVID recovery. It also says that we specialize in the treatment of rehabilitation, of post-intensive care, and complex medical patient requiring continued intensive care, including specialized rehabilitation in acute hospital setting. This blog says that we must now adopt this kind of a pattern. Finally, to sum up, they say that these hospitals must have daily physician oversight, physician specialists, ICU level care and staffing where necessary, 24/7 respiratory therapy coverage, IV pain control management and narcotic or opioid weaning, early mobilization of both ventilated and spontaneously breathing patients, antimicrobial management to complete sepsis treatment and prevent antibiotic resistance, interdisciplinary teams to clarify interventions and monitor progress, a patient-centered, goal-directed care plan addressing function, cognition, and medical impairments, and family-focused discharge planning, whether directly to home or to less intensive level of post-acute care. So we are really looking at not merely very advanced tertiary care institutions, but also mid-level critical care units, and that becomes important. But the emphasis on communication and family communication is a very important element because that brings in the whole human element. Even as we are getting more technology intensive, we must ensure that the human element still remains intact, and very much so. We need more contact and connect. Critical care has two C's in it, critical and care. Let me add a few more C's before I conclude. We need the care to be competent and conscientious. We need care, concern, compassion, courtesy, and communication as skills among the care providers. Whether we will have more or less empathy with technological advancement depends on how we train our younger people. It is possible that technology can actually become a barrier for this kind of a human contact. On the other hand, if technology can relieve much of the care burden of the human treating physician by undertaking a good deal of technological management, of course, with supervision of the care provider, that the care providers and the critical care medicine specialist time gets freed up for better communication with the patient and with the family members. And therefore, we do need to build in these soft skills as well as we move forward. In the balance between life and death, the hand that holds the scale must be both skilled and sensitive. I'm sure all of you possess those qualities in abundance, but it's important that you pass it on to the next generation as well. So even as you discuss science and all its glory in these conferences, make sure that the values that underlie medicine are also transmitted in abundance. Thank you very much.
Thank you, sir, for that very enlightening and thoughtful oration for the Indian Society of Critical Care Medicine. I'm sure our members across levels of seniority and hierarchy who are watching this had a lot of lessons to learn from your oration. May I now request our President, Dr. Dhruv Chaudhary, sir, to confer the felicitation virtually to Professor Dr. Srinath Reddy and award the certificate of oration. Sir, please.
It was an excellent overview of it and the values for which we stand for, and you have highlighted, and we will try to emulate it. It's a privilege that you have been here with us. And now I will request my dear friend and the person who will take the charge from me, the baton from me, Dr. Deepak Govil. And also, sir, your old friend, colleague from All India Institute, Dr. Yati Mehta has also joined us. He has been our past president. I think all three of us together will be there. And needed probably, I will request you to display the certificate and the medallion piece. Sir. Thank you so much, sir. We are honored, and Dr. Mehta has been remembering you, sir.
Please give him my regards, sir.
Yeah, I'm there. Thank you so much, sir. We have been honored, sir, and I will see to it if personally I can come along with Dr. Deepak Govil, because he is in Gurgaon. I am at Rohtak. So whenever to come and personally hand you over the medallion as well as the shawl and sir, everything which is there along with the certificates.
At your convenience, sir, and I'm most grateful for this honor. Thank you very much.
Sir, it's a pleasure. It's honor is ours, sir, that you accept. Thank you so much, sir. Thanks a lot, sir. Thank you.
Thank you very much, sir. Thank you very much. So let's go forward with the rest of the next agenda of the program. We will have a virtual lamp lighting and inauguration, a formal virtual inauguration of this program. Can we have the lamp lighting, please?
Question. Sir, are you okay? Vishal?
Thank you, sir, for the lamp lighting and the formal inauguration of the Criticare 2021. Going forward, it's my privilege and honor to invite the man who's led the Indian Society of Critical Care Medicine during the year of the pandemic, Professor Dr. Dhruv Chaudhary.
Dhruv is going to talk live now.
He's going to talk live, but I think they're in a picture. They're taking a picture. May I now invite our President, Dr. Dhruv Chaudhary, who's led the organization during the year of the pandemic and has shown us the way you fight the pandemic. Professor Dr. Dhruv Chaudhary to deliver the presidential oration, presidential address, please. Sir. Sir, please start, sir. Sir.
Yeah. Srinivas, sorry for the delay because we have to remove the lamp from here. Otherwise, it would have led to the fire, this thing. So we can start now, please.
Yeah, you can start, sir. I have already introduced.
Okay. Just give me a minute. Good afternoon, everyone. Today, it's my pleasure to welcome you all and also to deliver the talk as a president of the society over the last one very interesting, challenging, and tumultuous year. I think all of us have gone through and faced the challenges of it. So when I was wondering what I need to talk about it, looking at this disruptive year which we had 2020, I couldn't come up with the better this thing which I thought of the past, present, and the future. And when I heard today Professor K. Srinath Reddy sharing his views on critical care, he has been one of the foremost teachers in the country in cardiology, public health, epidemiology, and policy maker. Trust me, it was music to my ears because I share a lot of what he said and expressed. Now, when you start looking at it, when you start where we are today, we should always look at the past. I'm a very ardent student of a history. I always look at it where we are because it tells and gives us our past, our background, the mistakes which we made, the corrective actions we did it, and could we have been earlier, could we have been later. So I think it's extremely important for us to always look back and see and reflect, because when you do any narration, it is always good to be in hindsight, you are always wiser. But we forget at that point of time the challenges which were present at that point of time. When I look at the foundation of our society 27 years ago, I think our forefathers who started it, or I will say they still continues to be with us, they were far-sighted people who realized and who saw the future nearly 3 decades ago. And that's how in 1993, the Indian Society of Critical Care Medicine come up. Obviously, around about a decade later, what we saw in the North America, or which people usually tend to follow. I think the cherished dream of those 6 people had been to see how we can establish this particular specialty, because it was divided at that point of time between anesthesia, medicine, surgery, etc. And by and large, traditionally, the anesthetists have taken over because it has been considered to be an extension from their operating room because of their, what I say is adaptability is one word, but as their familiarity with the technology, because which have been used for monitoring and resuscitation. But nevertheless, if you really look at the history of critical care, it takes us back to the Crimean War when Florence Nightingale started separating out sick patients, and that has become still the day till today. Sickest of the sick patients are kept around the nurses one, and from there the concept of intensive care there. And I want to tell all of you, or rather re-emphasize one of them, is that nursing care, basically critical care is a nursing concept, and we need to give nursing an important place if we want to improve the quality of care. Treatment, yes, interventions we are doing it, but care is provided by the nurses. And I think that is what we have taken in account in our society when we started looking in terms of improving and expanding the care. Second thing was the recognition. Whatever you do, everybody wants it to be recognized. I know there has been a challenge. Let's say somebody who has done an anesthesia degree, and if you would have asked 20 years ago, will you like to be in intensive care? I think people like Dr. Mehta will be very brave, and a small number who said, okay, we take it up. Reason is simple, because at that point of time, people are not aware about the specialty. So it was seen as just a part of a subspecialty. But over a period of time, the recognition has come up, and gradually people are realizing the worth, and they've realized that it is not a single organ, it's a multidisciplinary. Single organ critical care has happened, and that you have seen in the cases of coronary care units, that you are seeing today in terms of neurocritical care also. They have made an impact, but end of the day, we need to look at it in multidisciplinary models, because if you see any body, it is not one organ which works, it's the music between the organ and the coordination between various organ systems which lead to the life. I think that is what is important, and that's what we have learned, we are still learning. And the expansion of this was also important. I remember when Dr. Rumta took over, he says, my aim is that to take over this society to the farthest of the country, because in the tier 1 city, you still have a critical care facility. What will happen to a person in Jaisalmer? What will happen to a person in Itanagar? What will happen to a person in Tanjore? What will happen to a person in Ladakh? So I think that is important, because it is important to train people, make them skilled, make them learn the basics of it, so that lives can be saved across the board. Therefore, the mission became at that point of time of critical care for 2 years was to take it to places, and I can say with sense of its happiness that today we have nearly 88 branches throughout the country, and which have gone into now tier 2 and tier 3 stresses, and I'm certain we'll keep on expanding in the future. What it also told us was the collaboration. We realized that, as I said in the beginning, that when you look at the intensive care units, it was considered an extension of a department. Later on, we realized that patients are unique, their problems are unique, and there could be multi-organ dysfunction syndrome. Therefore, you need to have a set of people who can work together. And similarly, you go outside because you are primarily dealing with acute care or with a multi-organ dysfunction. You need to interact with microbiologists, you need to interact with pathologists, you need to interact with respiratory physicians, you need to do a procedures like anesthesia skills, you have to have it. And somebody said yesterday, it was very interesting to hear it, that you need to have a skill of the UNO Director General, so as to do a diplomatic transactions with all the countries. I think you need to do it. And effective communication is becoming a challenge. And again, I feel very happy when we started our teaching training programs of the Indian Society of Critical Care Medicine. More than any other branch, I think we started doing it. And we realized that communication is a skill, not that it is inherent, but it can be taught. It can be taught to the people. And then building of a team, whatever you may do it. There is a saying in Hindi, Akela chana bhar nahi phod sakta. So similarly, it was important and it gave us the meaning of word team. And if I look at a team together, everyone can achieve more. I think that is what we look at it as a team. And this is what it has taught us. We built up the team not only in the institution, we have built up the team not only in the organization, but we need to build up a team which can provide 360 care and management to the patient and their families. I think that is what we have learned from the past, and we are realizing the gaps and trying to cover them in planning, and that's what we are looking at. If you see today in 2020, you can see it, myself and Dr. Srinivas probably will go in the history. I hope it doesn't happen in 21, and I wish that Dr. Deepak Govil and Dr. Arindam is already there. So that way it is there. Deepak is able to fly to Mumbai and can attend that. But trust me, it has been a very disruptive environment. And as I said it in my note in the critical care communication, a lot of water has flown through the Ganges during this 1 year. The day we landed back from Hyderabad, till we were supposed to meet in Ahmedabad, I've not been able to go to the office. So I will go into the history of our society's history as one of the only president as of now. And I wish that Deepak should be going there in the month of May itself, along with Srinivas, not to go there. And everybody knows this was the environment which was full of uncertainty. It was full of unpreparedness. There were physical distances, and obviously it put a lot of resources, constraint and financial resources, not only on us, but throughout the country, state governments, local governments, as well as to our institution and organization. But disruption itself creates opportunities. I think that's what we look at it. And when you look at the disruption opportunity, leadership also comes from the crisis. It has been well said that people talk about leadership in crisis. They say the crisis will itself choose a leader. You like or you dislike it. And that is what we are seeing across the world, across the country. People didn't know how to handle it. It started somewhere from pneumonia starting from Wuhan. Gradually, we then look at in the local language, if I use the global village, it spread across. But again, to our country, and Dr. Mehta is sitting along with us here, it basically dominantly came from the West, not from the East. And probably we first time in my state, we had the first flavor of it when the Italians came up and no government was willing to owe them. In fact, they were in the no man's land, and give credit to Professor Dr. Yati Mehta's team that they took care of it. I think that was also a very learning experience, and we realized what we are lacking, what are the processes, etc., which are needed. It created issues in terms of untouchability, in terms of isolation. And when I'm talking is not only of the care givers, but also the care providers. People are so scared. I remember the first boy which we admitted as a part of a quarantine, when we released him, I could see the joy of happiness. I can see the tears of joy on the face of the father. So they thought that probably some death sentence has been given to them. So it is all because of us. And then look at that 1 year, the amount of information, amount of knowledge which has come up. But it also reminded us of one thing. Usually the knowledge is drowned in the information. And when you start looking at the skills which you want to act, you need a wisdom actually to pick up the right knowledge. I think that's what this last 1 year has taught us. This also has taught us that if you stick to the basics, probably the probability of your sailing through the challenge is much more. Therefore, the more we redefine the things, more it takes us to the basics. So if our foundations are strong, if our values are strong, if our ethics are strong, probably we will also be sailed through. And same is true also for the organization. We developed a new team, new initiative. That's what we see. We realize how to go ahead with it, how to handle it. The first and foremost thing for any crisis is not the reaction, what happened, it happened. This is what the reality is. You accept it. And then if you will not accept it, that the reality, it will take you away. But if you will accept the reality, we have immense resilience to adapt to it. And that's what we did. We did adaptability. And in the first and foremost, the part was the building, trust building team and the inclusiveness. If you thought that as a doctor, you could manage it without a nurse, I think we were wrong. If we thought that as a doctor and nurses, we can manage it without an orderlies and paramedics, we were wrong. So it gave us an insight that we need to build team. And same thing when we start looking in terms of an organization. Adaptability is there because challenges will come, crises will come. Those organizations who do not adopt, most of the time they die or the time take its own toll. Therefore, it is important for the organizations also to adapt, to imbibe the new realities and then on the basis of that take a calibrated response. And I'm happy to say that as a part of this at Indian Society of Critical Care Medicine, when we came up, we did it. And we were very clear, we had a very clear role distribution. And the most important thing for anything you do is a trust. I must say that when we look at it, I was called by my government. I was given the task of the looking after the COVID epidemic during this period. And I can say with a sense of satisfaction, over 1 year, we did pretty well in my state of Haryana with the help of everybody from the government, from the private sector, from the non-organization, NGOs, etc. But it also took a toll. And how to run the organization, because all said and done, it's an old saying, spare the stick and spoil the child. Therefore, you need to have some amount of have a eye or some amount of a pressure on the organization to keep on running it. And the best person who came to mind was none other than Dr. Deepak Govil, who was the president-elect, and we had an inherent interest in it, and that probably has been responsible for you seeing even culmination in terms of having our virtual e-criticare. In fact, we used to sometimes a lot of debate, we fight with each other, we do it, but end of the day, when we thought what is best for it, what we do. He kept on asking me, Dhruv, why can't we, let's start with the virtual thing. I said, look, hold on. Because I was optimistic that probably we may have a hybrid type of a Congress where everybody wanted to meet with each other. But then at the end of November, we realized things have started going up again. There have been fluctuations. That was the time when we called it up. And trust me, without him, it would not have been possible to have a virtual criticare today. If every single place there is a footprint, it is of Dr. Deepak Govil. I just have been, I can say it, you can say it that I'm just camouflaging it as a head. That's not a right word. But having said so, I think that's the question of trust. Same with the trust I had with my secretary. That's what we looked at it. I asked him one day, I said, Dr. Srinivas, what are you looking at it? He said, sir, when I said I was very scared of it. But I simply told him, I said, you are the one who has to run the show. I am now the president, fine, that's okay. But it's the general secretary's job to do it. And trust me, it's the team. Look at the way our team, especially communication youngers, the way they have done it. I think I need not to say about it. The way our research team, the way they have performed, and you will see the results in coming up. I think it is there. What it led to? It led to one thing which is important, which we all forget. That is empowerment. The people whom you are commanding, people whom you are working with, empower them. This can only come from the trust. I think that is the key. And what is happening in our country, which we sometimes I feel very sorry about it, we always start with mistrust. Trust the inherent ability of the goodness of the people, empower these people, mentor the youngsters. Trust me, they will deliver you and they will deliver you at a time when you will not be expecting. And I'm so grateful to each and every member of my team, each and every member of a committee, that we have sitting together with the goodness of the thing, with the trust. We try to create SOPs. Some I may not be physically available, but probably when we talk to each other, we share the one value system, how we can take the society forward, how we can help the people the most, and how can we come out safe, unscared from this scourge called COVID. I think that's what, as a team, we were able to do it. That's what I said, new teams, new initiatives. And I leave it on a very happy note that we were able to deliver on a very large extent. That's what but ultimate credit to it will become if you will also agree and appreciate it. The present, as I said, COVID pandemic is a new normal. We like or we dislike it, it is bound to be there. You must have heard me sometimes. Dr. Mehta is there, Deepak is there, and a couple of my friends are sitting around. They have been saying it is the first epidemic and a pandemic which is being fought not on the floors of the wards or the hospital intensive care. It is actually being fought in your lounges, in your bedrooms, in your coffee rooms. The reason is because the 24/7 information toxicity is coming up, and it has created a new normal, especially in the upper middle class and the people who are in the cities. You go to the villages, they are least bothered about it. But nevertheless, somewhere we need to do it that till every single person in the villages and the cities is protected, it's not going to go. So we have to live with it. And we have to adapt to ourselves. And one of the most important things when it started was the PPE. There was hardly N95. There was hardly PPE. The PPEs which were there, one of my residents came and said, sir, it looks like a rice cutter. If you look at it, what is it? It's basically where you put the gunny bags, actually. It was like that. But now you see over a period of time how things have changed. Now we realize it is your, basically that we now understand its spread. Therefore, what we are realizing is what was true a year ago may not be true now, except your protection of your respiratory tract and maybe a bit of a shield, and simply you need a gown to cover yourself. Probably it will take a lot of distress which our people who have been working in the warm and humid environment had. They were actually drowning within their own sweat. I think that's what it was there. We have all learned the value of teamwork, no doubt about it. I will not be repetitive, but what is important is the one area in the virtual media which has played is the technology at play. That's what Professor K. Srinath Reddy also said about it. Technology is at play. We are today talking to each other, meeting each other. It is all part and parcel of result of technology. And it gives me immense pride that in India, we have come to such an extent that we can now practically do everything in technology. Obviously, patient touch and patient consolations and the art of healing gets a little underplayed. But from the technology perspective today, we are none to anybody in the world. And today was the most compliment which I say is that somebody told me, not belonging to our organization, said it, Dr. Chaudhary, it has been near, practically, it's like a near international experience we are having in the Congress, which we saw in a couple of it. Again, the credit goes to the team. It reminds me of an anecdote about Professor Satish Dhawan. I hope all of you have heard about him. Professor Satish Dhawan was the chairperson of ISRO for the longest point of time. And also Professor Satish Dhawan was the director of Indian Institute of Science. When legendary Dr. Sarabhai died, then Prime Minister Mrs. Gandhi asked the Principal Secretary of the Science and Education, in particular at that point of time, to ask somebody to look for to head ISRO, because that was the nascent organization. He has a unique distinction of heading both organizations. He was in US at that point of time. If you have read any of them, Ramchandra Guha's blog, what was interesting, why I'm quoting it is he gives you the finest examples of it. He said, I will come 1 year and you need to shift the center from Ahmedabad to Bangalore. Look at the political leadership. Immediately agreed that this is how the ISRO center today is at Bangalore, not at Ahmedabad. He headed both organizations, and when you read his book, he says the requirement of Indian Institute of Science was different and requirement of ISRO was different. So there he empowered people in research. Here he empowered people in taking your decision as far as your making the things for ISRO is concerned, the system, the SOPs. And you will be surprised when one of the persons with the legendary APJ Abdul Kalam, who headed the missile testing group, why I'm giving you an example. This is where the leadership actually comes into it, which is there. And you will be surprised. The first one is a failure. And now Kalam Sahab was at loss to go or not to go. Then Dr. Satish Dhawan said, you did your job, now it's my job to accept the failures. And when the 81, 2 years down the line, when it was a success, it was Kalam was asked to say and proclaim to the world it is a success. So that is what sort of a teamwork and a faith and a trust in your team is required. And I'm very lucky to have that team where I was able to display it. Financial prudence again is the key. What we realized was that probably revenue losses could be there. And each year we calculated that we do spend a lot of money in terms of having our executive council meetings. Technology has given us a new way to us. It has also shown us that how we have to be tax compliant, how we have to be there. But at the present, this is what is important, because no organization can sustain for a long if there is no financial prudence. And I think I again here compliment my friends, Dr. Deepak Govil, Dr. Srinivas, and Rajesh Mishra, and prior to that, Dr. Subhal Dikshit for that. What is the purpose of a professional organization? That's what we are together. Why we are here together? I think we all have a shared interest of spreading information and knowledge of critical care. We want to create advancement of knowledge, creating opportunities for ourselves, for our colleagues, our peers, and our younger generation. I think that is an important lesson which we have to do. But at the same time, we need to understand that there are going to be difference of opinion, and difference of opinion must not be considered the same. For progression, difference of opinion is the key. And I'm certain we have very young, smart young people with us, both men and women. And what I am finding is sometimes they come up with the brilliant answers, brilliant questions, but at the end of the day, it is equally important for the seniors like us is to see to it that in their enthusiasm, they may not injure themselves. That is where the mentorship is required. We need to take them to a proper places, nudge them, tell them what is right, what is wrong. allow them to explore it. And even if they make a mistake, we should be standing there like a parents that, okay, no, don't worry. But as I always say, it's not never jump from the 5th floor. If you have to jump from the 1st floor, because the probability of success is far better. And somebody also should not try to take a parachute and jump from the 5th floor. Again, you will be injured. So I think prudence is required. Wisdom is required. Information, knowledge. So it's an exuberance and enthusiasm of youth and sagacity and wisdom of the experience which needs to combine. And I think Indian Society of Critical Care optimizes it beautifully. So that's how we look at it. Leadership, I don't need to harness about it, but this is something I look at it. We did try to start something program in leadership so that people get sensitized. And probably COVID has shown us that we need far more commitment to it. If I don't know one method of measuring PPI, pulse variations, etc., or of cardiac output, of respiratory monitoring, doesn't make a difference. But if I have a poor leadership, I can sink the ship. I think, therefore, it is very important from the organizational perspective, get leaders to feed the youngsters and nurture them so that we can have a leadership which comes up, which shares the value with which our founders have started the society. Not there we are here simply to be president, vice president, or general secretary. We are here to serve the purpose, to serve the society, to serve the organization. Through organization is a mean for me to serving the society. I think that should be the motto more than anything else. Now, there are new paradigms which are coming up, which were very aptly explained by Professor K. Srinath Reddy in a wonderful address. We need to be the advocates for the patients, because if patient is safe, we are safe. So patient safety and advocacy is the key. ISCCM has taken a step this year, and I'm very happy to announce here that we have started a total group on paradigms with keeping this thing in mind, which will be headed by Dr. Manamare, but Dr. Deepak Govil will be sharing it with you in annual general meeting. So we want to tell patients we are standing with you, because critical care is an expensive care. It is a care which takes a lot out of you. It drains you. It requires 24/7 involvement in. Therefore, no wonder we are finding a lot of burnouts which are there in this particular specialty. Therefore, patient safety becomes paramount. We need to tell patients that we are standing with you, especially when it is the most delicate time of their life. That is what Dr. Reddy also said. People now know who intensivist is. You do not need to go to anybody and tell it. The only thing is keep a human touch. That is the key for the success in clinical medicine. Research, he very aptly pointed out, and I will request my Professor Deepak, Dr. Deepak Govil to take over it, because they offered the good offices of Public Health Foundation of India. We have a very robust research committee now. Myself and Dr. Deepak sat together. We looked at it. How can we ensure continuity? And I give credit to him that he agreed to me. And Professor J.V. Peter from CMC Vellore has been there along with numerous, and I think along with it, Professor Mohan Gujar from Sanjay Gandhi PGI made an excellent, and we have now developed a full-fledged standard operating procedures, how we are going to do and define. And probably Indian Society of Critical Care Medicine will go into the history that this is one society where guidelines are crystal clear how we have to give. And then they put a demand for a research committee, ethics committee. And I can happy to say so, with the permission of my friend, Dr. Deepak Govil, that we have made a institutional ethics committee, and Professor Gagandeep Kang, the famous microbiologist and researcher in vaccinology and immunology, and the only female Royal Society person, has agreed to be its first chairperson, and Dr. Gujar will continue to chair such. And it also brings out an integrity and ethics of a service, because most of the people is there from the looking at the movies, looking at the TV show, that something hanky-panky goes beyond the four walls of intensive care unit. I think it's basically, we need to talk to the people. We need to be transparent. We need to follow the ethics to the core. Then probably this sort of a myth can be dispelled. I know all of you are working hard. Money is important, but I always feel money should be subtle. Money should not be the prominent factor. Because the feeling when people get they're dying because they're poor, trust me, it can create a lot of social disharmony, and that is what we are already seeing in the setup. Now, critical care always have been an expensive proposition, but as Dr. Govil, as Dr. Srinath Reddy also said, and the government of India has also realized it needed a pandemic like COVID to realize it. And today now you can see the district hospitals going up. And I will request all the tertiary care, both in public and private sector, to join hand to ensure, and through the society, I think I will request Dr. Govil also to become an integrated part with the Government of India and Ministry of Health and Family Welfare. We will all use our offices so that we become advised and follow it, because for that, our guidelines, which we have come up, ICU design and guideline under Dr. Mehta, Dr. Govil and Dr. Roongta in particular, probably can stand the scrutiny. Equity in technology is as important. Probably it's not that simply technology is there. That's fine. But are we able to provide the same amount of broadband or bandwidth at the smaller cities or not? Which we are getting at. So we are finding technology untouchables also. Therefore, I think it is important from the society, from our perspective, is that we need to see technology is there, how best we can use and how we best educate. Social media is a menace. It's a double-edged sword. Dr. Deepak Govil, again, I will say, has created an excellent platform, which we are going to do it. But yes, we need to use social media positively. Look at the reach it is there. If newspapers are going to, let's say, 20, 30 crore people, the social media practically is going to more than 100 crore people, 1 billion people. Look at the reach which is there. But what is important is we need to speak to the people in their language. What as a doctors we do, we take technical jargon. I always say the person is a good one or a good communicator if what he or she speaks, patient understand. Not that what you or he say, what you say, and there's a different connotation altogether. We need to use social media. And finally, what we talk about, medical literacy. Medical literacy today in the COVID has shown us how illiterate and medical professionals we are. Till date, we are still not sure about COVID, which drugs to use, how to use, where to use, when to use. And the people are learning about this vaccine, about this disease at the same time when as a doctor we are learning. So sometimes you will see the people who are a little more Google smart. They try to make fun of us. But it is very important, use your wisdom, use your experience. Therefore, when we talk in terms of medical literacy, we need medical education. I think that's the key. That's where we need to go ahead. And I'm certain in coming year, we will invest more and more in medical education. The present organization, when I look at it, my friend, is looking at it. It's an equitable participation. We are having it. When I say equitable participation, because we need that people from every single part of this diverse country is represented. And we need and respect democratic traditions. You look at it within pandemic, it is the technology will help us to take and do and conduct the elections. Similarly, we also found out that somebody asked me, why can't you have an extension of tenure for 1 year? I said, for what? We have done it. It has given us an opportunity to do and excel. So therefore, it is very important to respect democratic traditions. And I'm very happy that today evening, we will be changing the baton and Dr. Deepak Govil and his team will take over with their fresh ideas, fresh views and all. Election reforms are a constant process, especially in the branches. By and large, at the center, we don't have much of a problem, but we are going from 2023 onwards. There will be, like people are saying, ek Rashtra, ek election. I won't say that, but ek society, ek election. That is what we are going to do it. It will be increased task, but we want bringing transparency up to the ground root level so that the people get empowered. That is what we are looking at it. Financial prudence, I don't need to speak much. We are looking at it. But at the same time, we have a huge liabilities on us because of the taxation, etc. I expect within next 1 year to 2 years, it should be sorted out. We are already seeking it. We are fortunately financially viable organization. But at the same time, I will tell a word of advice to all my colleagues and friends. The society and the organization we are heading, we are custodians. We are not owners. I think that is a very important lesson which all have to do. It is our people who have put the money into it. They have put our faith into it. They put their trust into it. We need to stand by that trust. If we breach it, nothing can be more, what I should say, harakari can be there than this. I think that's important. I am repeating it, and that actually brings down to accountability. All of us are accountable, not only to ourselves, to the executive, through executive, to all of the society. I think that's what we need to do. I have believed in it, and I have practiced it. The future is, this is my last slide. So the future is that when you start looking at it, and this is where I would like my new team to probably have some look at it, and the youngsters, and especially colleagues on strengthening education and research. I think that is what we are doing. We have already initiated a step. I'm feeling very happy to share with you, though we will talk in AGM also, is that, sir, we have started now 2 fellowships for the middle level people abroad and India of 5 and 10 lakh respectively each year. So that if somebody wants to learn on the research, etc., the society, we fund it. We have also created 4 research fellowship for the people doing their DNB, people doing their DM, IFCCM, etc., who want to do research 2.5 lakhs or 4 each in each year. We are creating new opportunities to member. This is what I was talking about. But I think in the leadership, I will request Dr. Deepak to take over it and take its logical conclusion. That is one my regret because of this couldn't do it. We need to do and look at the issues which are contemporary to relevant India. I will again not emphasize much because Professor K. Srinath Reddy has very nicely, beautifully said by a simple example of pulse oximetry. Can it be different in different races? How it can make a difference? And that could be the reason why blacks were having much more severe disease when they're reaching because of the problem which was there. I think we need to look at contemporary issues. Similarly, we have been also want to be a part of policy planning and execution. I think now as a professional body, the next step is people have recognized to move at that level with the governments. And I'm happy to share large number of us are actually now participating at different level in the government. I am from the public sector, so I had that advantage. But Dr. Mehta has been there, who himself has been the member of the governing body, if I recall, of PJ Chandigarh. So I think we need to participate. There's no public-private when we look at the public good in this. Encourage and mentor youngsters. I think that as we continue to do it, and time has come, as I said, we need to look at corporate social responsibility, though that's a term, something for the corporates. But I think as the organization is growing and the patient right and safety, another prepare for technology advancement, artificial intelligence startups. That's what we are coming with the new group from this executive, where we will be having a group which will be dealing with the technology and artificial intelligence, which will be headed by none other than Dr. Srinivas Samavedam, and Dr. Prashant will be helping it out, Dr. Deepak Govil in it. We need to shall collaborate with technology firms, because now you look at digital health is becoming a huge platform. It gives you an opportunity. I think that is the thing which we need to pick up, and probably with the help of the technology group, we need to do it and open society to people who are shared common interests. My first foremost as a part of society will be people from the society. But like in artificial intelligence, how many people are in the society? There are people in the society who are working as intensivists, but they're teaching in IITs. Similarly, there are people who are working in teaching institutions who are biomedically experts, because it has to become a confluence of technology and medical manpower. Only then we will be able to progress. That's what it is there. And in the end, dear, I will say it, a leader is best when people barely know he exists. When his work is done, his aim fulfilled, they will say we did it ourselves. And I feel very happy to say that we achieved, if not everything, a very large chunk of it. Thank you very much for your trust and love. Thanks a lot.
Thank you very much, sir. It was really a learning experience, both working with you in the last year as well as listening to you as how the whole society worked in the last 1 year. Thank you very much, sir, and hope to work with you in future as well.
Oh, sure, sure.
And again, it's my proud privilege now to have the past president oration, and I'm privileged to invite Dr. Yatin Mehta, sir, to come forward and deliver the past president's oration. Sir.
Good afternoon, good evening, everybody. And it's a pleasure to invite Professor Yatin Mehta. And sir has been the chairman, Institute of Critical Care and Anesthesia. He's presently working in Medanta, the Medicity. I call him as my elder brother. And we have learned a lot. And the most important thing I've learned from his patience and keep a happy, smiling face, even among the adversity. I think that's something not easy. And I think he has been teacher for DNB FNB for the last 20 years. He has edited multiple books. And he has also been the member of the governing body of the premier institutions of the country. He has an immense influence on cardiac anesthesia as a specialty. He has an immense influence on critical care as a specialty. And it has been our good fortune that with his experience, both as a clinician as well as an academician and an administrator, today we are having it. So I present before you Dr. Yatin Mehta from Gurgaon. And the good part is, sir is today, though his talk has been recorded, but he's sitting with us and is there, sir. So Dr. Mehta, sir, before we start. Sir.
Good afternoon, everybody. It is indeed a pleasure to be delivering this oration and an honor for ISCCM annual conference as the past president. I was looking forward to deliver this lecture oration in Ahmedabad, looking at the Motera Stadium, but unfortunately things have not turned out that way because of the pandemic which we had. So I thought it was appropriate that we talk about the COVID journey in India and also how ISCCM has participated in this journey. So from the beginning, if you look at it, how it all began from the Wuhan wet market, from bats, what they say, and December 31st, Chinese officials informed the WHO of the 27 cases of pneumonia of unknown origin. India got affected a month later when 3 students came to Kerala from Wuhan, and then it just exploded, spread all over the world. So on February 3rd, Kerala government announced that it was a state calamity. February 4th, India cancelled Chinese visas, and WHO was a little late. They called it COVID-19 in February 11th. February 21st, the silent advance to India happened. There were Italian tourists, 23 Italian tourists who were visiting India, and they went to Jaipur. Out of which 3 were Indians, rest were all Italians. They were in a coach. The doctor who was accompanying them had been coughing and had some fever. He was the doctor of the tour, Italian guy. So one of the tourists had developed fever and coughs. He was admitted at SMS Medical College, Jaipur, along with his wife. And their nasal samples turned out to be positive. At that point of time, India had 1 testing lab for RT-PCR. And then the enemy marched into the town. So the remaining 24 members of the team, 21 Italians and 3 Indians, were quarantined. All were asymptomatic and they were tested. 4th March, 14 Italians turned out to be positive. They were at the Indian-Tibetan border force quarantine facility at Manesar, and the Prime Minister's office rang us up. They wanted us to take care of these guys. So I had exactly 12 hours to organize the whole system. And so they were to be shifted by evening to Medanta, the Medicity, the hospital where I work. They arrived in the evening in the ambulances with the accompanying people in the PPEs. I received them without the PPE. I was wearing a N95 mask, and I was trying to reassure my staff. I had good meetings, and the whole day was spent in planning of how to organize separation of these patients. So that's how the story began. March 6th, screening at the airport began in India, and March 10th, 50 cases were reported from 13 states. First death happened in Kerala on March 12th. So what were the initial challenges? Initial challenges were modification of the infrastructure, how to handle in the busy tertiary care hospital. The nurses and the staff were very, very scared. So I told them that I'll be the first one to treat the patient. So if I'm older than you, if I can handle it, I'm sure you can if you take the precautions. Motivating the staff was very difficult because the knowledge was still evolving. There was an absolute fear on their faces. So we earmarked dedicated ward on the top floor of the hospital with separate lifts. We organized a PPE because no PPEs were manufactured in India, so we had to get it through the health ministry. Where will the food come? Where will the clean utility, the pharmacy, where will the dirty utility go? How will they be separated from the rest of the things in the hospital? And the mobility of the staff to and from that ward. So that all had to be restricted and limited. Initially, all the patients were on the floor, none of them required an ICU. One of the patient was an 80 years old Italian lady with a CKD and developed her oxygen requirement. She required oxygen and which went up. So initially we managed with NIV, which she did not like, and then we managed with HFNC, and eventually she had to be intubated. So we, instead of mixing this with the rest of the intensive care unit, we created an intensive care unit. And the downside was one of the Sundays I was in the hospital, and I came back home, and this is what I found outside my house. They had taken my RT-PCR, and it seems that although it was negative, they had forgotten or they had not been able to, because it was a weekend, report it to the civil surgeon. So promptly the civil surgeon's office and the municipal commissioner put this all up on a Sunday. So obviously I pulled all the strings and managed to get it off, but that was a downside. There was a lot of misinformation happening. What works, what does not work, everything was being tried empirically, anecdotally. Some people were pushing for Lysol injections, and politicians were also getting into advising medical therapies. One of the things, India is also nowadays very much into the Ayurvedic sort of medicines, immunoboosters. So one of the days I was seeing a major politician's, big politician's son, who's also a politician, admitted a place, and he was sitting without a shirt with some ointment on his chest, and I said, what happened? He said he was drinking kada and he spilt it over his chest. So these are the downside of all these anecdotal therapies. So knowledge was nascent, it was growing. Earlier, 1 year ago, what did we think? People thought it was a DIC pathology or it was a direct lung injury. Then we began with hydroxychloroquine, chloroquine, remdesivir, lopinavir, ritonavir combination. Many of these things were thrown out. Convalescent plasma became very popular. Everyone wanted convalescent plasma. Ivermectin was being recommended by some governments. Should we intubate early? Should we intubate late? What is the best way to ventilate them? How much people give? So knowledge is still evolving. It's still dynamic. So what are the additional challenges for how to modify surging numbers? Anticipating what were the numbers going to happen in the next few weeks or few months. Obviously fighting fear. People were not ready to come to the hospital, and you have to keep abreast with the knowledge and efficient testing. So we had to brace up. The whole country had to brace up, and which we all did. We should be proud of how we as a nation and we as intensivists all performed during this terrible period. So we had two dedicated separate ICUs, one for suspected to start with and one for confirmed cases. Then we grew to 4 ICUs for confirmed cases. So they had to be isolated. So we had red zone, orange zone, yellow zone, green zone. We had to provide separate entries, separate exits, separate washrooms, create separate shower and changing facilities, donning, doffing, education of staff, modifying the rosters, how long can they work in the COVID ICUs, because they are not even allowed to go to the washroom, how to give them food. So these were all issues with the limited supply. Sometimes in the middle of the night or on the Sunday, I had to organize getting the PPEs from the health ministry. So we got the godowns open to get it, because nobody else was supplying them those days. And we had to avoid wastage. So for N95 masks which were limited, we had to ration it. And we had to figure out how to sterilize it and recirculate it to start with. We modified the shields. So everyone now slowly was getting into, local guys were manufacturing things which were of use. Salary incentives were also considered by some. Knowledge crunch obviously had to be taken care of. Then there's these sort of web meetings and Zoom meetings and CMEs on the net. I think they played a very important role in bridging this gap. So there were logistical issues of sampling of the patients. Where do you sample the suspected? Where do you isolate them in the emergency and triage? How to separate them from the other patients? Turnaround time had to be shortened. Judicious use of PPE so they are not wasted. Efficient utilization of staff. They were also falling sick also. And looking at their appraisal. This is one of the first few days, and this was the PPE kits given to us by the ministry. And the tragedy was that this PPE kit was made in China. So we had to fight fear and misinformation. Obviously, continuous motivation of the staff was required. I led obviously from the front, which all of us did, and we were heading their own departments. Because unless you go, I was given an option that you are more than 60, so you can, if you don't want to go into the ICU, it's okay. I said, no, if I don't go, I cannot persuade others to go. So the first tracheostomy was done by me, first bronchoscopy was done by me, and I used to go later on every other day. Otherwise, initially I used to go every day inside the COVID ICU. And first dreaded intubation happened in an intensive care unit, which was probably the first reported intubation in northern India. An Italian lady had to be put on a ventilator. It was done on that room of hers was converted into an intensive care unit. We had to figure out the gas points, the suction points, the monitoring installation, how to monitor it from remote areas. We had to prone her also in that. So that had to be monitored carefully with cameras and things. So we set up a system by which cameras were installed inside and we could monitor it from the patient from outside. It could be zoomed onto the monitor, on the ventilator. So this was that patient. And these were the first 50 cases. They all had travel history from China or from Italy, from Middle East. So Maharashtra overtook Kerala, March 15. It still remains ahead of everybody else, where cases were doubling every 5 days. So mid-March. So March 20th, Indian Council of Medical Research redefined its definition to include patients with symptoms as COVID-19. March 22nd, first day, 14 hours of voluntary Janta curfew was declared by the PM. And when the PM says Bhaiyo and Beno, everyone starts shivering. So this is what happened. He gave you a small dose, a trailer on that day, and March 25 he declared a nationwide complete lockdown. It was timely done, it was ruthless, but it had to be done. There was no other way to control because there were no vaccines. There were no medicines at that point of time. And you could see how devastating it was on the people's lives, on the economy. I've lived all my life in Delhi, I've never seen Connaught Place like this, the birds enjoying the Connaught Place. So you could see the humanities surging, all the workers, daily wage earners, factory workers, mill workers, mostly from northern India, from Orissa, just panicking and trying to rush back to the home. And we brought out the worst and the best in India. This was one of the worst. Poor guys were walking hundreds of miles, thousands of miles to go to their home with children, with families, with belongings. And here were the policemen trying to feed from their own pocket a poor guy who was wanting some food. So you saw on one hand unfortunate consequences of the lockdown, on the other hand you saw the best of humanity coming out. So more than 1,000 confirmed cases were there, and the discussion went on whether India had entered a community transmission. And the happier side of this, we managed out of the 14 Italians, we managed to send 13 home. So these were the happy Italians who went back home. This is a team with the nurses and things. and that we published in the Indian Journal of Medical Research. This is Balram Bhargav, is ICMR chief, and this was the chief scientist, Ganga Khedkar. And this we have reported, as I said, IJMR, we analyzed the data of these patients. April 14, then more than 10,000 cases were surging in India. We did not know what to do. And lockdown was further extended till May. And you could see how Gujarat, Maharashtra and Tamil Nadu were the worst affected. This was 17th May data. So message was loud and clear. COVID had arrived and was here to stay. Glut of cases and prolonged battle was expected with limited weapons at hand. May 16th, 85,000 cases we overtook China. Further extended May 17th, the lockdown, and you can see the cases surging here. And debate went on, was India still in denial? But we had exercised the lockdown pretty fast. And India crossed 1 million cases by 30th of January. April, yeah. And here you can see more than 40 million cases worldwide increasing. India is also getting dark here. US and certain European countries were getting the higher numbers. And here you can see the cases surging. This was December 2020, how September it peaked. New cases were almost 1 lakh per day. And this is as of on 17th of January 2021. Maharashtra is unfortunately leading from the front. Maharashtra and Kerala are the two states which have the maximum number of cases. So probably we had not learned from our past mistakes or from other people's mistakes. But India decided to fight back. At the moment, active cases are on 1.3% and recovered cases are almost 97, 98%. And a death rate, fortunately, during these worst days also has been the lowest in the world. But there was a price to pay for this. A huge number of medical fraternity, medical doctors, intensivists, anesthesiologists, others, paramedics, nurses, had to sacrifice their lives for it. So it was an unprecedented global challenge. Ignorance, misinformation, crowding, poor sanitation, globalization and travel, politics played an important role, inequalities, all these played, and the virus, the virulence of the virus played an important role. Initially, this was the people on the Japanese cruise ship, Diamond Princess, and they said that the patient's response was variable. So you had to individualize the therapies. This was another paper in those days. And they said again the same thing. There are too many doubts about COVID. This was one of our earlier papers from Vedanta, out of the first 100 patients, and we analyzed it and we came out with the neutrophil to lymphocyte ratio of a particular, I think more than 7, and CRP were the cutoff where the severity of the illness can be predicted. So this was a prediction assessment of the thing. So science went on simultaneously. Fortunately, all of us worked hard clinically, and all of us from all over India, the intensivists really put all their acts together and hands together to work for the thing, and science also progressed and education also progressed. So I must thank all my colleagues in India, intensivists and anesthesiologists and pulmonologists who all worked together. So this was one of the first papers of cytokine storm. And you can see the 3 past presidents have participated, and this was one of the earlier things which was recognized, that the deterioration of the patient in the second week was because of the cytokine release syndrome. But there were a lot of research was hindered by a lot of things. Social factors, phobia, difficulty, technical difficulties, getting the drugs, initially DCGI clearances, but then ICMR, DCGI both, put them on the fast track. Patient attrition, isolation of the patients, family not accessible, consent, all these were, and quarantine. So these were all reasons why research could not be done as much as it was done under normal circumstances. Antivirals came and went, and some stayed back. Immunomodulators, some of them are still being investigated. And you have this repurposed remdesivir first paper, which has shown shorter hospital stay and lesser severity. So this was a multi-center study, and two of the Indians who participated, many centers in India participated, but two of the authors were Soumya Swaminathan. We are proud to be, she was ICMR chief at that time, and she now is the chief scientist at WHO, and also Dr. Srinath Reddy, who's delivering a lecture in this conference oration. So these were the results so far. Recommendations were made and they're withdrawn. Some of the drugs were also withdrawn. So thousands of clinical trials are still on. At the moment, more than 2,500 studies on. So this was one of the first papers, ISCCM. It was leading from the front, as I said. Position statement of Indian Society of Critical Care Medicine. So we all worked together. Most of the office bearers and past presidents were involved in this. And this was the surviving sepsis COVID-19 guidelines which have just come out. Sheila Mehta is one of the co-authors in this. So we are all proud. Everybody has, I think, pitched in. And India came out with a new journal, RCM Friends. And it was a socio-academic journal, very active. Some people were very active authors in this. I sometimes try to read the articles and the comments. They're quite interesting and good images. So it's a good way to connect. I must thank RCM for starting this. And again, Indian Society came out with a position statement. Again, most of the office bearers were involved in this and the past presidents, November 2020. And also ISCCM came out with airway management guidelines. So ISCCM has been very active, not only in publishing, but also in conducting educational activities, CMEs. So I think they have been very, very active. But we are learning every day. And this was the paper. Now tocilizumab became very, because of the cytokine syndrome, toci became the in thing. So everybody wanted to use toci. So we did this randomized large multi-center trial, and this has been accepted for Lancet Respiratory Medicine. I was a PI in my hospital, and Dr. Dhruv Chaudhary and Dr. Rahul Pandit and several others also participated. It was a multi-center large study. It was a negative study. And Dr. Deepak Govil also co-authored with me. Then these were the two case reports. We came out with diabetic ketoacidosis. So they were anecdotal. I mean, these are two cases who were not diagnosed as known diabetics, but turned out to be diabetic ketosis and turned out to be COVID-19 positive. So there are a lot of learning on the way. I think we all have done that. And this was again recommendations by the Indian Society, current approaches to COVID-19. Again, most of the senior people are involved. Dhruv Chaudhary, Atul, Dr. Zirpe, Subal, Deepak Govil, me, and so on. And these were the recommendations for SWAC also, initial ELSO. This was a recommendation by ELSO guidelines for ECMO. ECMO was becoming very popular. We all who were practicing ECMO got better at it because we had to practice it more often. And these were the initial recommendation by ELSO. And these were the leaders in ECMO, the Suresh Rao from Chennai, Dipanjan and Arpan Chakrabarti from Kolkata, Rajesh Mishra, Sandeep Diwan, and this was the Calcutta group with one of the doctor patients who had survived after a long stay in the on ECMO machine. So I think they've been quite active with fairly good results. As I said, ISCCM has been very active in conducting CMEs and educational activities. I have delivered more lectures during the COVID times than in the past. You can see Dhruv Chaudhary was very busy, and Dhruv Chaudhary, Pradeep, Rangappa, Rahul Pandit, they were all, and R.K. Mani, they were all in the COVID task force of their own states, and few of them, Dhruv and Rahul, got sick also with COVID, so they obviously led from the front. And Kapil and Subal have been very active in Pune, so we all have been busy with the academic activities and so on. So, incredible in India. Puja, somebody had made this mask with Corona Idol. And then finally, the long-awaited vaccine arrived. Indian trials began. Some of them were not completed, but the vaccines have been released and the process has begun. So we should be proud to be Indians because 2 vaccines have been developed in India, and the Covaxin has been developed purely in India by ICMR and the institute in Hyderabad. So I think we should be proud of that. Some people needed some incentive for getting the vaccination. Some people did not need an incentive. But I'm glad that now next year will be better and we can meet physically rather than virtually for the next ISCCM and in Ahmedabad, I think. So, lot of people, I think now almost 1 crore have been vaccinated, and it is going to be open to public from next week. Some people got exposed because the mothers thought, how come they were not called for vaccine if they were doctors? But one thing we must be proud of, that India now during this period won historically the cricket tournament in Australia. We should be proud to be Indians. I think India fought the whole battle very well, clinically, academically, scientifically. We all worked as a team, individually also, and along with the government agencies and other agencies abroad. So we will win the war. We are winning it already. This was the General Niazi signing the surrender document with General Arora. General Arora, by the way, was my patient and a very close family friend. So thank you very much for your attention, and I think we shall overcome. Thank you again.
Thank you, sir, for that motivating and morale boosting past president oration. Extremely fortunate to have been here listening to that talk, sir. I may now request our President, Dr. Dhruv Chaudhary, to felicitate Dr. Mehta with the trophy and award the certificate of the past president oration. Sir.
एक snapshot. Thank you. Oh, yeah. Thank you, Srinivas. Finally, at least we three were together. I think that is something which is probably we are feeling very happy about. Yes, please.
And going forward with the next of the next point, next program on the agenda, the ISCCM has always focused on research and its own original work. And I'm now pleased to invite Dr. Sagarika Panda to present the ISCCM Best Research Paper for the benefit of the members of the society. Dr. Sagarika Panda, please.
Good afternoon, all. Myself, Dr. Sagarika Panda, DM Critical Care Medicine from All India Institute of Medical Science, Rishikesh. I am going to present my study. That is correlation of lung ultrasound aeration score with oxygenation in ventilator-associated pneumonia. So as we know, ventilator-associated pneumonia is one of the most frequent hospital-acquired infection. It contributes to increase in the ICU and hospital length of stay, the prolonged the use of mechanical ventilation, and tremendous use of hospital resources. It has an attributable mortality of 13%, but the crude mortality increases further when there is delay in diagnosis or initiation of appropriate therapy. So monitoring of its course is primarily important for a favorable outcome. Chest X-ray is frequently inaccurate to diagnose such a modest change in the lung aeration, as it lacks the diagnostic accuracy in critically ill patients. Lung CT is considered gold standard to monitor the lung morphology in VAP patients and also to assess the effect of different therapies on lung re-aeration. But the risk of transportation of a critically ill patient out of the ICU and the risk of radiation exposure limits its repeatability. Whereas lung ultrasound is an easily available bedside tool, which in the last few years has been shown a promising result for diagnosis of VAP with a greater sensitivity in comparison to chest X-ray. Lung ultrasound aeration score has also been studied to have a good correlation with CT scan for quantifying lung aeration in VAP patients. But whether the change in lung ultrasound score reflects the oxygenation status is not yet known. Thus, in this study, we aim to identify a correlation between lung ultrasound score with oxygenation and static compliance in patients of VAP. Correlation between day 1 lung ultrasound score and 28-day survival was also studied as a secondary outcome. So this is a prospective outcome assessor blinded observational study, which was carried out in Critical Care Medicine, Department of Anesthesiology, AIIMS Rishikesh, over a period of 15 months after approval from the Institute Ethical Committee. The sample size initially calculated was 55, but 39 patients enrolled for the study due to limited admission in view of COVID-19. 13 patients were excluded in view of various exclusion criteria, 3 patients were lost to follow, and finally 23 patients were analyzed further. Adult patients of age group 18 to 60 years with a diagnosis of VAP as per the CPI score more than 6 were included for this study. Morbidly obese patient with a BMI of more than 40, patients with subcutaneous emphysema and thoracic dressings, patients with chronic lung conditions like COPD or interstitial lung disease were excluded from the study. Lung ultrasound was performed for consecutively 5 days since the diagnosis of VAP at 6 areas of each hemithorax, namely the superior and inferior area in the anterior, lateral, and the posterior chest field. Then each area was given a score between 0 to 3. 0 score means a normal lung scan, that is the presence of A line. A score of 1 means presence of few well-separated B line. 2 means presence of multiple coalescent B lines, and 3 being the presence of dynamic air bronchogram. Oxygenation, that is the PO2 by FiO2 ratio, and static lung compliance were also calculated at the same time point. Now coming to the result. So 23 patients were included in this study. 70% were male patients. The mean Apache 2 score at the time of diagnosis of VAP was 16 with a standard deviation of 6. And the SOFA score was 8.6. Endotracheal aspirate culture was found to be positive in 65% of the patients, that is 15 out of 23. The most common organism isolate was Acinetobacter, that is 47%. Other organisms were like E. coli, Pseudomonas, and Klebsiella. Now coming to the primary outcome, that is correlation between lung ultrasound score with oxygenation and lung compliance. So here we found a statistically significant negative correlation between lung ultrasound score and oxygenation from day 1 to day 5. And as we can see, from day 3 onwards, a high correlation was found between them, suggesting the clinical improvement become apparent after 48 hours of therapeutic intervention in terms of mechanical ventilation and antibiotic therapy. The correlation between lung ultrasound score and static lung compliance was not found to be statistically significant on day 1, but from day 2 to day 5, the correlation becomes statistically significant. Correlation of day 1 lung ultrasound with 28-day survival. We found the day 1 lung ultrasound score to differ significantly between 28-day survivor and non-survivor. The mean lung ultrasound score for survivor was 18, and for non-survivor it was 21. And when Wilcoxon Mann-Whitney test was used, we got a p-value of 0.024, which is statistically significant. The diagnostic performance of day 1 lung ultrasound score to predict 28-day survival when analyzed by ROC curve, we found a cutoff of 19 with a sensitivity of 75% and specificity of 73% to predict 28-day survival. And area under the ROC curve was obtained as 0.78, demonstrating a fair diagnostic performance of the score. The same cutoff was also found by Lee et al. In their study involving ARDS patients. Now, the change in lung ultrasound score over time when studied, we found lung ultrasound score decreases significantly over the time from day 1 to day 5. So here, as we can see, the mean score on day 1 is 19.43 and day 5 is 17. So when we got a significant value in the change in the lung ultrasound score over time, a post-hoc analysis was performed to explore the time point at which the lung ultrasound score differ maximally from day 1. So here, as we can see, various days were compared with day 1, and we found the difference between day 5 to day 1, the mean difference is minus 2.35, which is statistically significant. So day 5 lung ultrasound score differs significantly to the day 1 score. The trend in the lung ultrasound score over time was also compared between the 28-day survivor and the non-survivor. And we found a significant difference between them over time. So here, as we can see, this red line demonstrates the survivor group. So lung ultrasound decreases gradually from day 1 to day 5. And this change is also statistically significant. But in case of non-survivor, the lung ultrasound score rather increases over time. So to conclude, lung ultrasound aeration score appears to be a valuable tool for evaluating the recovery of VAP, as shown by a significant correlation between the score and atrial oxygenation. So serial measurement of lung ultrasound score can define clinical course of VAP resolution and also will help in identifying those receiving adequate therapy and good outcome by as early as day 5. Thank you.
It was a wonderful interpretation of a very commonly used and easily applicable tool at the bedside for a practical problem in the intensive care. Thank you, Dr. Sagarika, for that. And I now request Dr. Subhal Dixit, our immediate past president and the chairperson of the Abstracts Committee, to kindly felicitate Dr. Sagarika and award the certificate. Dr. Subhal. Then the next program on the agenda is our annual traditional Hansraj Nair paper presentation. And it's my privilege to invite Dr. Dattatreya Prabhu to deliver his talk as part of the Hansraj Nair Award presentation.
Good day, everyone. Today I'm going to present my scientific study PASS, a novel study to evaluate for the persistent AKI in critically ill adult ICU patients. To start with, I would like to thank my co-authors, Dr. Sonali Prabhu, Dr. Chakrapani M, and Dr. Mayur Prabhu. As we all know, acute kidney injury is highly prevalent in critically ill ICU patients, particularly in those presenting with sepsis. The prevalence rate is around 20 to 50%. Persistent AKI is usually with the elevated serum creatinine or oliguria. In later stage may require renal replacement therapy. Reversibility of the AKI is influenced by the recovery of response, which in turn affected by the extent of renal damage and whether the normal renal function in the damaged renal cells can be restored by promoting regeneration. Recovery from AKI was defined as 50% decrease in the creatinine levels or normalization of the urine output in the absence of diuretics or both. Hence, prompt resuscitation of the circulation and optimal perfusion pressure are absolute necessity in critically ill patients with AKI. Persistent AKI for more than 48 hours has shown significant increase in mortality. Aggressive intervention at admission is needed to decrease the morbidity and mortality. Early accurate diagnosis of AKI improves standard care and reduces the mortality and morbidity. The objective of this study was to use easily available variables at the time of ICU admission of critically ill patients with sepsis to predict whether AKI will be persistent or it is transient, to guide us on how aggressively we need to go ahead and to resuscitate them and to refer the patient to the other centers and prognosticate them. It is a prospective observational study in ICU patients. Inclusion criteria were patients who are more than 18 years of age, admitted to ICU with AKI, acute kidney injury, and septic shock. Exclusion criteria were pregnancy, less than 18 years of age, known renal artery stenosis, end-stage renal disease, on patients who are on ACE inhibitors, NSAIDs, cirrhosis with hepatorenal syndrome, cardiorenal failure, and obstructive acute renal failures. Study period was around 18 months. 63 patients were recruited after approval from ethical committee and informed consent from the patients and relatives were taken. Parameters like serum creatinine, base excess in ABG, plethysmographic variability index, K-well index, R-wave amplitude variability in ECG, mean arterial pressure, and renal resistive index were assessed at admission. After 6 hours of fluid resuscitation, as per survival sepsis guideline, hemodynamic status and volume status were assessed again, and patients were classified as volume responders or non-volume responders, depending on the hemodynamic stabilization. Reassessment of the variables at 24 hours and 72 hours after admission was done. Primary outcome was persistent AKI after 72 hours, and secondary outcome was initiation of dialysis or death within 15 days of admission. Multiple logistic regression used to predict the acute kidney injury recovery. Odds ratio calculated was unadjusted and adjusted with variables like vasopressors used, volume responders, and volume response, and mechanical ventilation. Coordinates of the ROC curve yielding best sensitivity and specificity was taken as cutoff to develop a model scoring system called PASS score for predicting the recovery from AKI. A predictive equation, that is the PASS score, was derived using ROC analysis, and its efficacy was tested using sensitivity, specificity, positive predictive value, negative predictive value, accuracy, and kappa scores. Decision tree analysis was used for preparing the flowchart. All statistical analysis were performed by SPSS 20. Results: in 63 study participants, 32 were volume responders, where 31 were non-responders to fluid resuscitation. 34 patients of 63 patients recovered from AKI. Response to fluid, mean arterial pressure, base excess, plethysmographic variability index at admission, and requirement of vasopressors did not correlate with the AKI recovery. Multiple logistic regressions showed that serum creatinine less than 2.36 milligrams, RV variability of more than 14.4, and a renal resistive index of less than 0.8 at the time of admission correlated well with the AKI recovery, with adjusted odds ratio of 5.44, 4.03, and 6.20 respectively. Based on this, points were allotted to the PASS formula as developed. Serum creatinine less than 2.3 is allotted 1 point, and the values more than that were allotted 0 points. RV variability more than 14.45 is allotted 1 point, and the values less than 14.4 is allotted 0 points. Renal resistive index of less than 0.8 is allotted 1 point, and renal resistive index more than 0.8 is allotted 0 points. PASS formula which was developed was serum creatinine points into 5.4 plus RV variability points into 4 plus RI points into 6.2. The total score of more than 7.8 predicted a good recovery from the AKI. PASS score of more than 7.8 has sensitivity of 79.4% and 72.4% specificity for recovery from AKI, with a positive predictive value of 81.8% and negative predictive value of 76.7%. Test and gold standard agree on 50 out of 63 having a diagnostic accuracy of 79.34%. The kappa value of 0.586 indicates a good agreement with the p-value of less than 0.001. ROC curve analysis showed that PASS score of more than 7.8 had an area under ROC curve of 0.85, that is 95% confidence interval, 0.755 to 0.943. A flow chart, as I had told before, was prepared, which can help us in guiding the management and used as a tool to identify the salvageable renal angina and predict the persistent AKI, in helping us the management and to the reference to the higher center can be used in the peripheries very easily. Here, as the patient comes, we have to look at the serum creatinine levels. When the serum creatinine levels are less than 2.36, the recovery from the AKI is supposed to be good. If the creatinine is more than 2.36, we have to look at the R-wave variability. If it is more than 14.4, the recovery from the AKI is good. Whereas if it is less than 14.4, we have to look at the renal resistive index. If the renal resistive index is less than 0.8, then the recovery is good. Whereas the renal resistive index of more than 0.8 has a poor chance of AKI recovery. discussion. There are many papers which have discussed about prognostication of the AKI at admission during the course of admission, in which one of those is Mastura et al., where the renal angina index was presented. Depending on the changes in the serum creatinine, was proposed to identify the persistent AKI. Whereas some other studies, they use the biomarkers to predict the severity of the renal angina and persistent AKI, like cystatin C and interleukin 18 levels, but they were time consuming and very expensive and was not easily available in all the centers. There is one more study where they made a scoring system called PARI, Persistent AKI Risk Index, by Ryo Matsura et al., which helped to identify low risk and high risk for persistent AKI using parameters at admission and after 24 hours. It cannot guide, but the negative point of this study was it cannot guide the clinicians at admission to predict which patients will benefit from aggressive resuscitation, and can only prognosticate the patient after 24 hours of admission. So literature studies have proven that estimating increased renal resistive index on the first day of admission can help predict the acute renal failure in septic shock and differentiate persistent AKI from transient AKI in critically ill ICU patients. R-wave variability related to increased QRS wave amplitude due to increased ventricular preload is reliable indicator of intravascular volume and hemodynamic status. This is called Brody's effect. Our study concludes that serum creatinine, renal resistive index, and R-wave variability at admission are statistically significant with a p-value of less than 0.005 to predict the AKI reversibility, which we have further analyzed to develop the formula called PASS, Persistent AKI Scoring System, to predict whether the AKI is going to be persistent or transient. Our study utilizes easily available bedside patient parameters available at the earliest of patient's admission and help us identify the patient and understanding the prognostication of the patient. By following the flow chart, the PASS chart of the PASS, we can help to prognosticate the patient and whether the patient will have a transient AKI or the persistent AKI. PASS is combined scoring system that, in summary, PASS is a combined scoring system that includes serum creatinine levels, renal resistive index, R-wave variability at admission. PASS formula and flow chart is a simple bedside method reliably to identify the potential patients at a high risk of persistent AKI and those who can be salvaged by initiating a aggressive fluid resuscitation and or by referring them to some other higher center. So PASS formula, as presented earlier, the serum creatinine into 5.4 plus R-wave variability into 4 plus RI points into 6.2. If it is more than 7.8, it predicts a good recovery from the AKI. These are the references which I have taken for the study. Thank you.
Thank you, Dr. Prabhu, for a practical and very elegant research publication, and that was our Hamsraj Nayyar paper presentation. May I now request our President-elect and the Chairperson of the Scientific Committee, Dr. Deepak Govil, and the person who's made this presentation possible over the years, Dr. Chetan Nayyar, to felicitate Dr. Dattatreya Prabhu and award the certificate. Dr. Govil and Dr. Nayyar.
Thank you. Thank you, ISSM panelists, on behalf of my co-authors. Thanks a lot.
Thank you very much, and that brings us to an end of the our inauguration and the presidential events. And I hand it over back to the organizing team for the rest of them. Thank you.
Dr. Dhruv, Dr. Deepak. Dr. Sheila. Yes, Dr. Deepak. Dr. Sheila, can we start? Dhruv, बोलो ना start. Tech team, is it alive?
Yes, sir. Please start.
Dr. Dhruv.
We'll start after Dr. Dhruv joins.
हेलो
हाँ जी सर, कैन यू स्टार्ट?
इन्होंने म्यूट कर रखा था, अब खोला इन्होंने, तो दैट्स ऑल, यू आर ऑल सिटिंग।
Can we start? Or
everybody, we can start.
Is Dr. Jindal there?
सर का एक बारी चेक कर लो यार.
प्राजक्ता सर को फोन करो प्लीज.
मैं कर रहा हूँ, एक मिनट.
Yes, sir.
डॉक्टर ध्रुव कर रहे हैं.
बाकी अभी मैं प्रशांत को कह रहा हूँ. प्रशांत is with me. Okay.
I'm here. Can you?
Yes, sir. Sir, good afternoon.
Good afternoon. Thank you.
Dr. Dhruv, unmute yourself.
Good afternoon, sir.
Good afternoon. How are you?
बढ़िया सर, ठीक ठाक सर. आप वीडियो चलाएंगे सर, आपको देख के अच्छा लगेगा.
I think it is.
Yes, sir. Now
Yes, sir. Yes, sir. Great.
So much, sir. Thank you so
Thank
much.
you.
आप शीला से करो, शुरू करते हैं फिर सर.
So, Sheila, can we start?
Very she.
I'm here.
I think she's.
Welcome, all of you.
Welcome. Thank you.
Yeah. On behalf of Indian College of Critical Care Medicine, I welcome you all in this convocation ceremony 2021. It's a virtual event because of unprecedented situation in the country. We welcome the Chancellor, Vice Chancellor, and the College Board. We welcome Dr. Dhruv Chaudhary, Chancellor and President, Indian Society of Critical Care Medicine, Dr. Sheila Nanan Maitra, Vice Chancellor, Indian College of Critical Care Medicine. I welcome Dr. Deepak Govil, President-elect, Indian Society of Critical Care Medicine. I welcome Dr. Subhal Dixit, immediate Chancellor and the immediate past President, Indian Society of Critical Care Medicine. Dr. Srinivas, General Secretary, ISCCM, welcome here. I welcome Dr. Indamka, General Secretary-elect, Indian Society of Critical Care Medicine. I welcome Dr. Ramesh Venkatraman, College Secretary-elect, Indian College of Critical Care Medicine. Dr. Y.P. Singh, Secretary, Accreditation, Indian College of Critical Care Medicine. I welcome Dr. Babu Abraham, Secretary, Examination, Indian College of Critical Care Medicine. I welcome Dr. Vivek, Secretary, Nursing, Indian College of Critical Care Medicine. I welcome Dr. Ajit, Secretary-elect, Accreditation, Indian College of Critical Care Medicine. Dr. Sachin Gupta is welcome here as Secretary-elect, Examination, and Dr. Sushrut, Secretary, Nursing. I welcome you all in this hall along with Dr. S.K. Jindal, sir. I would request Dr. Dhruv Chaudhary, Chancellor and the President of Indian Society of Critical Care Medicine, to give welcome address.
Thank you, Munir. And I welcome you all. And it's a great honor and pleasure for me to welcome everybody in front of my mentor, my teacher, and I look up to for everything, Professor S.K. Jindal, sir. Thank you so much, sir, for your blessings that you have joined us, sir. And always you have been there whenever need and things were required for us to develop the institution, department, anything what we looked forward to. And next, I know, sir, that this is, sir, I just wanted to inform and share with you, is that this is the 10th year of our college. Now we have completed a full decade. And during this period, we have started giving the fellowship of intensive care and critical care medicine for last 10 years. And looking at it, the unprecedented time, we first time having actually the virtual Congress. And if you really ask me, practically pan-India people are there from Chennai, from Bangalore. Sheila is from Mumbai, Munish is from Jaipur. I am sitting right now in Gurgaon, and you are in Chandigarh. And similarly, we have friends from Calcutta. So practically, it's a pan-India presence which is there, and Dr. Subhal Dixit and his team from Pune. So I think this has given us a platform for not only uniting, but also, as you have always been saying it, and we have tried to follow it up, that the future is technology, and the college has tried to adapt it to it. And we have started the programs of teleeducation within the country. And in order to uplift the education, the college has actually has been with the very active participation and hard work of Dr. Sheila and Dr. Munjal. We started structured training education program this year. I am very happy to share with all my colleagues and friends that we have now today capacity to teach and train more than 1,000, if to be precise, 1,084 doctors in various phases, which includes CTCCM. We have got IDCCM and IFCCM. In addition to it, we have also started enrolling in Indian Diploma in Critical Care Nursing, and around about 400 nurses plus each year in critical care, and taking clue from us. The Nursing Council of India has started what called as the nurse practitioner in critical care. So I think we have been taking a lot of steps. And not only that, we are realizing that the critical care also has a subspecialties. And in those subspecialties, we are starting fellowships, though they were supposed to start last year. But this year, we will be starting now the fellowship program in neurocritical care. We're also starting an online full training courses plus on-site training program for ECMO. Additionally, we are also starting training for respiratory therapists in association with the physiotherapy, respiratory therapist society in it. In nutshell, we are committed as a college to have spread of education, and not only spread of education, to ensure quality of education. And that's why the step was started. And we are actually having 2 classes now per week, sir, starting from 5th of August, if Sheila corrects me. And this is one thing which I put my foot down. I said, as a teacher, if you and I can't do it, then nobody can do it. And thank you, Sheila, for taking that through and see to it, sir. And that has become now not only the bedside clinical discussions, it is now we are having through that case discussions, we are having through lectures, we are having through case discussions, plus the general club. So everything has been started online, and all the people who are doing IDCCM, ISCCM, they are doing it. So it's a great satisfying year for me as a teacher, the way you and Dr. Mujal and the whole education board has been there. And particular thanks to both, again, Dr. Sheila, to you, Dr. Babu Abraham, Dr. Sachin Gupta, and the person who is going to take over the charge from me, Chancellor, Dr. Deepak Govil, for the first time doing online clinical as well as theoretical theory examination for Indian Diploma Critical Care Medicine, for CTCCM, for IFCCM, and we actually conducted 972 students appeared around Pro Proctor, and our pass result in theory has been around about 56 to 57%, and then they go to the practical aspect of it, where the pass result, depending upon it, from 60 to 70%. For the nursing, I think that is around 70%. Indian College of Critical Care Medicine also looking at it, we are re-revising the criteria for the teachers, and we are trying to in alignment with National Board of Examination, and we have made it mandatory for teachers to be appointed for the board, which we do it after accreditation and looking at their biodata, to have 1 paper at least in peer-reviewed journals, or at least 2 case series. So that the idea is to encourage them, and we can put and streamline the quality of education in it. And looking at it, the challenges which you're facing for the first time in any postgraduate training courses, we have now introduced the concept of audit. I think with these things, I welcome you all, and I'm sure that the coming years, board will do better and better. And with the starting of new courses, including ultrasound, including your other number of courses which have been lined up, medical law ones, telemedicine, plus along with it, we are also seeing a couple of more new training programs coming up. We will excel, and we will set a benchmark for it. And probably in the form of Professor S.K. Ajindal, if he gets little, sir, you will see it, we'd like you to advocacy for it to allow professional bodies to help and get recognized their courses by National Medical Council, because the number required are huge, which may not be possible from the formal sector to provide it. Thank you very much.
Thank you, Dr. Dhruv Chaudhary. Now, I request Dr. Sheila Nanan Maitre, our Vice Chancellor, to give her welcome speech. Dr. Sheila Nanan, please.
Dr. Manish. Good afternoon, Professor S.K. Jindal, Honorary Chancellor, Dr. Dhruv Chaudhary, Honorary Secretary, Dr. Munjal, our President-elect and Chancellor, Dr. Deepak Govil, the past President and past Chancellor, Dr. Subhal Dikshit, the General Secretary of ISCCM, and all the college board members, the teachers of the college, the fellows of the college, all the students of the college, all those who are receiving awards today, the ISCCM members, ladies and gentlemen. It is indeed a great pleasure for me as I am here before you to welcome all of you to the college convocation ceremony on behalf of the college board. Now, as Dr. Dhruv has just mentioned, this is the 10th year of the Indian College of Critical Care Medicine. We've almost finished, completed a decade. And this college was started 10 years back by the then president, Dr. Rajesh Chawla, Dr. Divatia, Dr. Ramakrishnan, and put on a lot of hard work to make the college this new body at that time. And all the chancellors, vice chancellors, and all the college board members over the last 10 years have made this college grow from strength to strength. We are merely the custodians. And over the last 1 year, I can tell you that along with the chancellor, myself, the college secretary, and the members of the board, we have left no stone unturned to make this college really become what it is and grow to even greater heights. Now, the last year, as Dr. Manisha said, has really been challenging for us. During our tenure, we faced unprecedented challenges. And as a college, you can imagine, which is involved with teaching, accreditation of institutions, accreditation of teachers, all this became extremely challenging for us. And two of our, I would say, if I had to look at two big achievements of ours, was one, firstly, conducting the examination. This was really, really challenging because to conduct the examination of all our courses, over 3-4 sessions for these students who are already working as frontline workers, to conduct online examinations for them across the country was really a huge mammoth task. And I tell you very honestly, I didn't have the confidence that this would happen. And if it wasn't for Dr. Dhruv Chaudhary and Dr. Deepak Govil, who really took this forward, and Dr. Dhruv insisted that we should have examinations for the college and the students should not suffer. And we realized the importance of them clearing the examination, moving forward and taking the job forward. And to execute this, I must thank Dr. Manish, and special thanks to Dr. Babu Abraham and Dr. Sachin Gupta, who together worked out this master plan. I mean, an incredible plan, and by which we could execute these examinations. And we have set an example for other societies, other institutions, that it is possible to conduct online examinations during a pandemic. The second achievement of the college, which I take great pride for, which Dr. Dhruv has already alluded to, is the STEP program. This is the structured training and education program that we started for the college. Again, the brainchild of Dr. Deepak Govil and Dr. Dhruv, and I was given the responsibility along with Dr. Manish Munjal to take this forward. Now, during the pandemic, one thing that really suffered was education. All the teaching, the training that was happening, all this suffered. Classes stopped, even in centers where it was being done. And our students really suffered because they were just working and working, and no one was getting their regular classes and teaching. So the plan of STEP was to have pan-India classes for our students of all the courses. These would be online classes that would be taken by expert faculty. And the goal was not only to prepare them for the examination, but also to make them good intensivists. Carefully selected topics, carefully selected faculty. And as Dr. Dhruv has already mentioned, we conduct these classes twice a week from 7 to 8 on Wednesdays and Saturdays. And I'm very proud to say that along with Dr. Manish, we have been able to conduct more than 50 sessions and involved more than over 100 faculty already for these programs. And they're running very successfully. And I'm sure the future secretaries and chancellor will also take this forward and keep this as an ongoing event. Regarding our courses, now, our courses, the college faced a lot of threat from other boards, especially the national board, and we had various challenges. Nevertheless, I can say that our courses, the IDCCM, the IFCCM, the CTCCM, and even the nursing course, the IDCCN, all the number of seats have only increased. The popularity and the demand for this course has only increased over the last 1 year. Despite the challenges of the pandemic, we started 4 new fellowships There was a fellowship in neurocritical care, thanks to Dr. Sapra, in echocardiography, which Dr. Deepak Govil took forward. We also have the fellowship that was started for ECMO, and Dr. Shetty was responsible for that, and also the respiratory therapy fellowship that we have started. So 4 new fellowships started during a pandemic. Dr. Vivek Kumar was responsible for this fellowship. Now, one of the big challenges that we faced was, one of the roles of the college is accreditation. So accreditation of new institutes, and reaccreditation of the existing institutes, and also appointment of the new teachers and accreditation of this was really a challenge. To conduct inspections, how are we going to conduct inspections during the pandemic, when there were so many travel restrictions? And even this, the college worked out ways by which we could use local faculty along with other faculty, how we could also use online facilities and make this possible, along with visits from local inspectors. And we made sure, and here I must give special thanks to Dr. YP Singh, who made sure that all our accreditations for no institute was left pending. And the entire year, we were able to accredit several institutions and teachers for this. A real word of appreciation goes to our students. I must say, indeed, it has been really challenging. As Vice Chancellor of the college, I can say that they have been frontline workers. In addition to this, they have also been studying, and they have also been teaching, appearing for examination. So this has been really, really hard for them. And I'm very grateful to Dr. Dhruv Chaudhary and Dr. Manish and the college board, who came up with the idea that this year we are going to, give a special certificate of appreciation to all the students who worked and studied and gave examination during this pandemic. I would fail in my duties if I don't appreciate my, the college board members. And here I want to give special thanks to my chancellor, Dr. Dhruv Chaudhary. Dr. Dhruv Chaudhary has been a very close friend, guide, and philosopher. And I must say that he's a person who leads in a very, very different way. He's never done micromanagement. He's always given us a free hand. But of course, he keeps his checks. And this is something I really like. So whatever ideas Manish and I proposed and whatever we wanted to do, he gave us a free hand. And he really supported and helped us, in a different way. And I cannot tell you how much my association with Dr. Manish has been. I can say that almost every day or every alternate day, we have been on the phone. And unfortunately, none of us could meet the college board members. And Dr. Manish is someone who is very hardworking, very honest, and someone who works very silently. So a lot of the time, I would be the front stage, but Manish would be doing all the backscreen work. So I'm extremely grateful to Dr. Manish Munjal, the secretary of the college, who has done a lot of work. I would fail in my duties if I do not thank Dr. Deepak Govil. I can say one word about him. I have never seen a more hardworking guy than Dr. Deepak Govil. He was the chancellor, the vice chancellor, as well as the secretary and the entire college board put together. If we did not have the help and support and guidance, constant guidance from Dr. Deepak Govil, I don't think we would move forward, especially during a challenging year during the pandemic. And there are 2 people who I want to mention who say very few words and have worked very silently. And one is the past president and the past chancellor, Dr. Subhal Dikshit, and the other one is the general secretary of the college, Dr. Srinivas. Both men of very few words, very wise, and have been a constant support and guided me throughout this period during this the time of the pandemic. And the other people I want are the 3 secretaries, to appreciate other 3 secretaries. Now I can tell you, Dr. YP Singh, he looked after accreditation. And I know, being the accreditation secretary, how challenging it is to do accreditation. And it has been even more challenging during the pandemic. And this is really a kind of thankless job. Every week there are applications from teachers, from institutions for recognition. And Dr. YP Singh, despite having health issues during this period, has worked extremely hard to make sure that our accreditations happen from time to time. I've already mentioned Dr. Babu Abraham and Dr. Sachin Gupta. Babu Abraham, the education secretary, and this was really the test of Dr. Babu Abraham, been able to execute the examination along with Dr. Sachin Gupta during this difficult time. Dr. Babu Abraham, I must say, is a master planner, and the way he conducted the examination is unparalleled. Dr. YP Singh, along with Dr. Ajit Kumar, also did a great job with accreditation. And last but not the least, our nursing secretary, Dr. Vivek Kumar, along with Dr. Bandopadhyay, Now, he has done a lot for the nursing, for the courses. Not only that, they have also come up with a textbook for the nurses, which hopefully we will be able to release during the course of this year. And he was also behind the respiratory therapy course. So I wish to, give my special thanks and appreciation. I don't think I could function as a vice chancellor as effectively, especially in this challenging year, without the entire support of my college board members. And I welcome the new team, and I wish them every best. The new chancellor and the president, Dr. Deepak Govil, and the vice chancellor, Dr. Pradeep Bhattacharya, and the new secretary of the college, which is going to be Dr. Ramesh. So I welcome all the new college board members, and once more, special thanks to all of you. It is indeed a great honor, and I wish to welcome all of you once again for this program. Thank you.
Thank you, Dr. Sheila, for the nice words. As Dr. Sheila and Dr. Dhruv, Chancellor and Vice Chancellor, they already narrated most of the activities of our college we conducted in the last 1 year. But as customary, I will read out few slides. It's an annual report of College Secretary. I take great pride and pleasure to present annual report of the Indian College of Critical Care Medicine for the academic year 2020-21. This is the 10th year since formation of Indian College of Critical Care Medicine. It's an academic wing of Indian Society of Critical Care Medicine. Under the leadership and guidance of the College Chancellor, Dr. Dhruv Chaudhary, and the Vice Chancellor, Dr. Sheila Maitra, along with the active involvement of college secretaries, Dr. Babu Ibrahim, Dr. YP Singh, Dr. Vivek Kumar, and the board members, there has been continued growth and the success of our critical care courses, evolution of our examination, and the starting of online classes for our students. During this COVID time, with all kind of restrictions, exemplary work has been done by the Dr. Deepak Govil, Examination Secretary Dr. Babu Ibrahim, Examination Secretary-elect Dr. Sachin Gupta, and Accreditation Secretary Dr. YP Singh. Great efforts have been taken to popularize the IDCCN course by Dr. Vivek Kumar, our Nursing Secretary. A total of 723 candidates appeared in 6 examinations conducted at examination centers and through pro-proctor system and through Zoom meetings. And total of 31 applications for the new institutes and 110 applications for the new teachers and 46 applications for the re-entrants were processed in this year. In 2020, at Hyderabad convocation, Dr. Sushil Ambesh, Dr. Kapil Barauke, Dr. Ebo Jacob, Dr. Ghanshyam Jagatkar, Dr. Bharat Agyasi, Dr. Sudhir Koteta, Dr. Soren Panja, Dr. Ashok Kumar Singh, Dr. Manoj Kumar Singh, Dr. M.N. Siva Kumar, and Dr. Neetu Jain. They were presented FICCM. And the honorary FICCM award was given to Brigadier V.S. Kole. He's from Pune. So some detail about our courses. The IDCCM, IFCCM, CTCCM courses continue to remain popular. We have total 596 IDCCM seats and 104 IFCCM seats and 384 CTCCM seats. These are offered in 199 accredited institutes across the country. We have 1,092 seats for the IDCCM program. During 2020, we started Fellowship of Neurocritical Care, that is FNCC. It was started in collaboration with the Society of Neurocritical Care Medicine. And the course coordinator for this course is Dr. Harsh Sapra, and Dr. Kapil Jirpe was also very much involved to starting this program. Then we started Fellowship in Critical Care Ultrasound, and the course director for this course is Dr. Deepak Govil. Then we started this Critical Care ECMO Fellowship program, and the coordinator for this program is Dr. Ryan Shetty. We also started Advanced Education in Respiratory Technology, that is RT, and we started fellowship in advanced respiratory care in adult critical care, that is FARC ACC. It's a collaborative fellowship program by IARC and the ISCCM, and the course coordinators are Dr. Vivek from ISCCM and Dr. Manjush Karthika is from IARC. We Indian College of Critical Care Medicine Academy Awards were given to Dr. Vijay Lakshmi. This Dr. Vijay Lakshmi Kamath Award was given to Dr. Pratyush Gandu, and Dr. Anand Memorial Award for topper in IDCCM will be given to Dr. Nidhi Raghuraman. Anand Memorial Award for the topper in IFCCM will be given to Dr. Meghna, and CTCCM topper award to Dr. Pratik Kumar Patel, and IDCCM topper award will be given to Asthap Rajesh Pandit, and this award will be given during this ceremony itself. We now have 199 accredited institutes across the country offering our training program. 18 new institutes were accredited during 2020 for our courses, and 90 new teachers included in our teachers pool during 2020. As Dr. Sheila and Dr. Dhruv already mentioned about this program, it's a STEP program. This we started in 2020. A STEP ICCM which is a structured training and education program for Indian College of Critical Care Medicine. It is exclusively for our IFCCM, IDCCM, and CTCCM students, and it was introduced during the year 2020. This course has been formulated in keeping with the aim of our college to carry out high quality education activities. The objective is not only to prepare our students for the examination, but to make them high quality intensivists, both in knowledge and practice. STEP ICCM will be an ongoing interactive online teaching course. Each session will be conducted by expert faculty who are fellows and teachers of the college along with the moderator. The STEP sessions are conducted on Wednesday and Saturday from 7 p.m. to 8 p.m. The first session was held on 5th August 2020. Until now, 54 STEP sessions on varied topics have been held. So here is a report for the FICCM Award 2020. As recommended by Credential Committee, the following members of ISCCM will receive the honor of FICCM in this ceremony. They are Dr. Akshay Shetty, Dr. Kumar Sahu, Dr. Gunjan Chanchalani, Dr. Sharmili Sinha, Dr. Prashant Kumar, Dr. Jayesh Kumar Daboria, Dr. Rakesh Gar, and Dr. Priya Mathur. So Dr. Priya Mathur, she was selected in 2018, but somehow she could not able to take this award in earlier program. So this year we will be honoring her. And the honorary FICCM award for 2021 will be given to Dr. S.K. Jindal sir in this ceremony itself. Now we start our next session. Next part of this program, it's the awards presentation ceremony. Honorary Fellowship of Indian College of Critical Care Medicine Award 2020 is given to Dr. Dr. Surinder Jindal is from Chandigarh. He is Emeritus Professor, Department of Pulmonary Medicine, Postgraduate Institute of Medical Education and Research, Chandigarh. I'll request Dr. Dhruv Chaudhary to introduce Dr. Surinder Jindal, sir. Dr. Dhruv Chaudhary, sir.
Thanks, Manish. It's a proud privilege for me to honor, to recommend his name for Honorary Fellowship of Indian College of Critical Care Medicine. It could not be a better day for a student actually to say thanks to his teacher, because of whom we are where we are. Professor Jindal has been trained in both India and USA. He has been a great medical teacher and scientist, and has been one of the pioneers in pulmonary medicine in the country, has been the first institution, PJ Chandigarh, which started DM in pulmonary and critical care medicine in 1989. And Dr. Guleria, his first distinguished fellow, has been now the director of All India Institute of Medical Sciences. A lot of other people are heading the institute. And if Sir can read me, Dr. George is now the president of the All India Institute of Medical Sciences, Raipur. Dr. Jindal has been the editor, associate editor of important, I can say, both red and blue journals and widely read professional journals, as well as author of several books. He has got more than 350 publications to his credit. Sir has been honored with the Outstanding International Educator Award for scientific contribution by the American Thoracic Society, one of the largest society of respiratory critical care in the world. He has also been awarded by other international bodies like American College of Chest Physicians, International Union Against Tuberculosis and Lung Disease, and other awards of national body. Sir has been actually very actively involved. He's a fellow of Academy of Medical Sciences. He is the one who established the telemedicine network of PGI Chandigarh, which subsequently was chosen by the Government of India and associations of African countries. And this is how we are providing care. Sir has also, wherever he has gone, it has been his Midas touch. He has changed not only the tele-education, he also has been responsible for looking at the whole instrumentation of the PGI Chandigarh. Sir has done several CSR, DBT, as well as ICMR projects. He is practically on the board of every single research and scientist body of this country worth the name. And Sir has also been one of the chief editors of the textbook of pulmonary and critical care medicine. And is also another very interesting book, which I would recommend all of you to read it actually, Medical Encounters, True Stories of a Patient. It's a real, gives you an insight. He's a person, multifaceted person, man of few words, but you trust me, those who have worked him, he has touched everybody. And all of us who have been his students know it, can vouch for it. And Sir has, after retirement in 2014 from the public sector, from the government, but he continues to provide his guidance, consultations to each and all of us. I hereby present Professor S.K. Jindal, sir. Professor Jindal.
Thank you very much, Professor Dhruv Chaudhary, I think, for your very kind words. I'm glad that several of our former students and colleagues are now heading different institutes and different colleges like you yourself, you see. I'm very thankful for selecting me for this award. Honorable Vice Chancellor Sheila Maitra, other dignitaries, guests and delegates, you see. So I'm thankful to all of you for the prestige and pride or the privilege which you have accorded to me. I must say that I value this honorary fellowship and will value it all my life. In spite of other awards, I think this is of special importance to me, you see, especially in being chosen by my former students. I have been a witness to the growth of critical care in this country for over half a century, for around half a century. And there has been an exponential growth of critical care, which encompasses multiple specialties and super specialties as well as subspecialties. And now, for example, I learned that you yourself are going to offer fellowships in multiple subspecialties as well. I think this is a great achievement, you see, for the college. The growth in critical care has been rather exponential, partly due to technological developments, as well as to the need and charisma associated with critical care. I think nothing could highlight this need more than the pandemic COVID-19, which has almost made the entire country feel that they need ICUs, ventilators, and so on, you see. But I must say, of course, that we all know that. I don't have to stress upon this group that critical care does not involve only the mechanical sports, but the need for a protocolized management incorporating different aspects, you see. Unfortunately, the standardization for care has been rather non-uniform in this country in particular. And I am sure that the college is taking a lot of steps in this direction. As you have yourself said, that lot of accreditation programs are also going on. I think in due course of time, these things will be solved to a great extent, you see. I, in fact, remember an article written in early part of this century, you see, the critical care in 21st century, from CPR to PCR, you see. I remember this article because it stresses upon that in future, perhaps, the mechanical sports alone may not be the answer, and it is these are molecular techniques and other therapies which not only will supplement, but which may also substitute the type of care which we are offering at this present. I am glad to know that the Indian College is undertaking a lot of efforts in this direction to frame guidelines, publish a journal, and doing, of course, the accreditation, etc. You see, what one expects in future that it will also lead in some research activities, developing new technologies, adopt alternative strategies, and frame guidelines so that critical care becomes available at an affordable cost, you see, to the general masses of this country. Well, once again, I'm very thankful for selecting me for this award, and I express my gratitude to the college, to the functionaries of college, and all other members. Thank you very much once again.
Thank you, sir. I'll request Chancellor and Vice Chancellor to present this award to Dr. Surinder K. Jindal, sir.
Sir, thank you so much, sir. We are doing it virtually. We would have been very happy to do it in this thing. But
yeah, I also miss the presence, you see, and taking it from your hands. But anyway, I remain very thankful, and I'm sure
we have got it now. And Sheila, if you will permit, and Deepak Govil is also, I think, sir, I have it. We will come to Chandigarh now, and along with our colleagues there of the critical care, we will have the privilege, sir. Thank you so much, sir.
Thank you so much. Great honor to have you with us, sir.
Thank you, sir.
Dr. Deepak?
Yes. Yes, Doctor. Mute karo.
Thank you. Now we will move on to next award. Fellowships of the Indian College of Critical Care Medicine Award 2020. The first awardee is Dr. Gunjan Chanchlani. She is from Mumbai. She is Chief Intensivist, Kambala Hills Hospital and St. Elizabeth Hospital, Mumbai. Next awardee is Dr. Jayesh Kumar Dubaria. He is from Rajkot. He is Director, Critical Care Department, Synergy Super Specialty Hospital, Rajkot. Next awardee is Dr. Prashant Kumar from Rohtak. He is in the Department of Anesthesiology and Critical Care Medicine at Pandit Bhagwat Dayal Sharma Postgraduate Institute of Medical Sciences, Rohtak.
He is here with us.
Congratulations, Dr. Prashant. Next awardee is Dr. Rakesh Garg from New Delhi. He is Additional Professor of Anesthesia and Palliative Medicine at All India Institute of Medical Sciences, New Delhi. Congratulations, Dr. Rakesh Garg. Next award is Dr. Raksha Shetty. He is from Bengaluru. He's MD head. He's head pediatric intensive care services at Rainbow Children Hospital, Bengaluru. Congratulations, Dr. Raksha Shetty.
Thank you so much.
Next award is Dr. Sarmili Sinha from Bhubaneswar. She's senior consultant critical care medicine at Apollo Hospital, Bhubaneswar. Congratulations, Dr. Sinha.
Thank you very much, sir. A proud moment. Thank you.
Next award is Dr. Tapas Kumar Sahu from Ranchi. He's senior consultant and head Institute of Critical Care Medicine and Anesthesiology at Medanta Hospital, Ranchi. Congratulations, Dr. Sahu.
Thank you. My gratitude to Indian College. Thank you.
Next award is Dr. Priya Mathur. She's from Jaipur. This award was given to her in 2018, but because of some personal reasons, she could not attend last two convocation ceremonies. So in this ceremony, we are awarding her with the FICCM. She's head Department of Critical Care Medicine at Apex Hospital, Jaipur. Congratulations, Dr. Priya.
Thank you so much, sir. Thank you so much. My gratitude to all the members and all the dignitaries. Thank you so much.
Now, Dr. Vijay Lakshmi Kamath Memorial Award for the Best Performing Candidate in IDCCM for 2020, it goes to Dr. Pratyusha Gundu from Rajamundry. Currently, she is Junior Consultant Critical Care at PRK Hospital, Hyderabad. Congratulations, Dr. Gundu.
Thank you very much, sir. It's a great honor to receive this award, sir. Thank you.
Anand Memorial Award for the toppers in IFCCM examination 2020 goes to Dr. Meghna. She is from Chennai. Currently, she is consultant at Apollo First Med Hospital, Chennai. Congratulations, Dr. Meghna.
Yes, Meghna, please unmute yourself.
Anand Memorial Award for the topper in IDCCM examination 2020 is this year it's going to Dr. Nidhi Raghuraman from Chennai. She's junior consultant at IQRAA Hospital, Calicut, Kerala. Congratulations, Dr. Raghuram.
Thank you so much, sir. Thanks a lot, sir.
Award for the best performing candidate in the CTCCM exam 2020 is given to Dr. Pratik Kumar A. Patel. He's from Ahmedabad. Currently, he is ICU registrar at SGVP Holistic Hospital. Congratulations, Dr. Patel. Award for the best performing candidate in IDCCN 2020 goes to Ms. Astak Rajesh Pandit from Pune. She is unit in charge Pune at Ruby Hall Clinic. Congratulations, Dr. Pandit. Now I will speak out the names of the IFCCM successful candidates for the year 2020. They are Dr. Akansha Chawla from New Delhi, Dr. Amit Jain from Jhansi, Dr. Ajay Padam Nabhan from Chennai, Dr. Deepak Gupta from Noida, Dr. Deepika Dash from Ahmedabad, Dr. Iqbal Hassan from Noida, Dr. Josh Kuti Matthew from Kochi, Dr. Meghna from Chennai, Dr. Murthy Armili from Bengaluru, Dr. Prasant Singh from New Delhi, Dr. Priyanka Bagade from Mumbai, Dr. Poonam Rai from Puttur, Dr. Reshmi S from Trivandrum, Dr. Rohit Yadav from Noida, Dr. Sanjeev Yadav from Agra, Dr. Sweta Chandakhede from Hyderabad, Dr. Suman Sagar from Bengaluru, and Dr. Vikasdeep Bansal from Mumbai. Congratulations to all. We welcome the board of the ISCCM 2020-21-22. They are Chancellor is Dr. Deepak Govil. He is Chancellor and President also Indian Society of Critical Care Medicine. Dr. Dhruv Chaudhary will be there as the immediate past Chancellor and the immediate past President of Indian Society of Critical Care Medicine. We welcome Dr. Pradeep Bhattacharya as a new Vice Chancellor in Indian College of Critical Care Medicine. We welcome Dr. Rajesh Chandra Mishra as President-elect of Indian Society of Critical Care Medicine. Dr. Arindam Kaur will be there now as General Secretary in Society of Critical Care Medicine. Dr. Rajesh Pandey is a new incoming member as a General Secretary-elect of Indian Society of Critical Care Medicine. Dr. Ramesh Venkatraman will take charge as Secretary in Indian College of Critical Care Medicine. Dr. Sachin Gupta will take charge as Secretary Examinations of Indian College of Critical Care Medicine. Dr. Ajit Kumar AK will take charge as Secretary Accreditation in Indian College of Critical Care Medicine. Dr. SUSHRUTA Bandyopadhyay will be Secretary Nursing of ICCM. Dr. Babu Ibrahim will come in new board as Secretary-elect. Dr. Subramani K will come in board as Secretary-elect Examinations. I will be there as Secretary-elect Accreditation, and Dr. Shyam Sundar T will be there as Secretary-elect Nursing. We appreciate the hard work done by the retiring board members. They are Dr. Dhruv Chaudhary will be retiring as Chancellor. Dr. Sheila and Maitra will be retiring as Vice Chancellor. Dr. Subhal Dixit will be retiring as immediate past President ISCCM. Dr. S. Srinivas will be retiring as General Secretary Indian Society of Critical Care Medicine. I will also be retiring as Secretary ICCM. Dr. YP Singh will be retiring as Secretary Accreditation. Dr. Babu K. Abraham will be retiring as Secretary Examination, and Dr. Vivek Kumar will also retire as Secretary Nursing. I will request Dr. Ramesh Venkatraman, our college secretary-elect, to give vote of thanks.
Thank you, Dr. Munjal. It's my honor and privilege to deliver this vote of thanks to everybody. I think thanks is a small word for all the hard work they have done. So I'm going to basically do it as a heartfelt appreciation and acknowledgement of all the work that has gone on because of the elite members of this college over the last 1 year. I have been very fortunate to be inducted into the college for the first time and observe the activities that are going in the college. Dr. Sheila Nairan has already exhaustively mentioned everybody's contribution here. And I would like to sum up the whole thing by just stating the qualities that I have observed from all these people and learned and hopefully can take forward towards the next year. I would start with Dr. Dhruva Chaudhary, who's the Chancellor of the college. His leadership, his clarity, his encouragement and support was immense throughout the year, and without his efforts, we couldn't have conducted any of the programs. Sheila rightly pointed out that he was hands off, at the same time knew exactly what was going on. So those skills are something that really helped the college. Next person is Dr. Sheila Nayanan Maitra herself. What I learned from her is her passion and persistence to get things done. She's relentless when it comes to a task and tries to get whatever needs to be done. She's been instrumental, along with Dr. Manish Munjal, in initiating the STEP sessions and carrying it forward in a very successful way across the country. So thank you, Dr. Sheila Nayanan. Next, my predecessor, Dr. Manish Munjal, honest, loyal, and prompt worker. He was a workforce consistently working across all through the year. I just wish and hope that I can fill your big shoes, sir. Thank you very much for your contributions to the college. I would like to then thank Dr. Deepak Govil and the General Secretary, IACCM, Srinivas Samavedam, who are active participants, had genuine interest in the college and the society, and had always contributed in whatever endeavors needed to be done and take it forward. So thank you, Dr. Deepak Govil and Srinivas Samavedam. Next, going on to the specific secretaries for each. The first, I'm going to start with the exam. Dr. Babu Abraham. I could see, I worked with him, so I could see his hard work, his organizational skills, and his meticulous nature coming forward in terms of trying to create these templates for these different video rooms, along with Dr. Sachin Gupta, to pull off one of the largest online exams ever probably done anywhere in the country and maybe in the world. So Babu, that was very inspirational, and thank you so much for your hard work. Thanks, Sachin, for helping us get through those tough times. Dr. Sheila also mentioned the difficulties in getting the different institutions and the teachers accredited. Dr. YP Singh's consistent efforts and a thorough checklist of what he does in every meeting was very remarkable to watch. And thank you, Dr. VP Singh, for your contributions. Dr. Vivek Kumar, whom I've known for a while as a friend and as a colleague, had genuine enthusiasm in initiating the courses. His attention to detail and bringing in the respiratory therapy course was very important. It's a forward step for the society. I think it will help in transforming the way we provide critical care in the ICU with more respiratory therapies around. Thanks, Dr. Vivek, for your efforts. I also want to take this opportunity to thank the members of all the committees and subcommittees who are working on behalf of the college and who have contributed immensely in trying to make sure that the quality and the standards of this college are upheld. The last but not the least, the string that ties all of this together would be the office staff, specifically Ms. Shabana and Mr. Neil, who have worked off hours, on hours, been on phone all the time, trying to answer questions for the exams and STEP sessions, and have done a fantastic job in making sure that in the last difficult year, they have been able to successfully do all this. So thank you for every one of the office staff who has worked immensely in the last year. So thanks one and all for any contribution from any of you towards the betterment of the society and the college. I do look forward to working in the next year and trying to take this forward to the best of my abilities. Thank you so much for the opportunity.
Thank you, Ramesh. Thank you all for sparing time and coming and honoring this program. Thank you very much. Namaskar.
Thank you, sir. Good day to all.
Thank you.
Thank you. Thank you so much. Thanks a lot.
Thank you.
and its own original work. And I'm now pleased to invite Dr. Sagarika Panda to present the ISCCM Best Research Paper for the benefit of the members of the society. Dr. Sagarika Panda, please.
But the risk of transportation of a critically ill patient out
At the RV inhibitors, NSAIDs,
days since the diagnosis of VAP. In the means present complex in
Thank you, Dr. Sagarika, for that. And I now request Dr. Subhal Dikshit, our immediate past president and the chairperson of the Abstracts Committee, to kindly felicitate Dr. Sagarika and award the certificate. Dr. Subhal. The next program on the agenda is our annual traditional Hansraj Nair paper presentation. And it's my privilege to invite Dr. Dattatreya Prabhu to deliver his talk as part of the Hansraj Nair Award presentation.
Good day, everyone. Today I'm going to present my
Like yesterday, we have got a exciting line of lectures lined up for you, and I, along with Dr. Sahil Kataria, will be the host for you today. So to begin with the first session, I would like to invite Dr. Deepak Goel, who is the president-elect of ISCCM and director critical care medicine, Medanta, the Medicity Hospital, Gurgaon, and Dr. Shrikant Srinivasan, who is head critical care medicine at Manipal Hospital, Gurgaon. So over to you, Dr. Deepak Goel.
Good morning, Dr. Deven, for kind introduction. Can we have first slide, Sahil, Neeraj? So first talk is by none other than Dr. Daniel Talmor. He and pain, his area of action.
For inviting me to this lesson. I'd like to thank the Indian Society of Intensive Care and so the management of increasing attention have a number of them, but the most important one is on the bottom, and that's that I have my own opinions of which I'm going to express today. So